sembri mio figlio. Capisci? Guarda, se noi siamo quelli pazzi là. Vabbè, a me questo non mi serve. Lo mettiamo qua se qualcuno serve dentro.
Scusa, hai ricevuto qualche banner che ho mandato a Save the Date?
Non ho ricevuto.
No, allora, te lo do io, stai tranquillo. Allora, quello dietro l'abbiamo messo, gli do il banner nuovo.
Sì, ok. Da lui che va insieme quando mandi tutti gli altri banner.
Insieme agli sponsor, diciamo.
Sì, quello 6 secondi.
Io sono vecchio. Voi, ragazzi, qua questo qua dico, mettila
Posso
due.
solo dire una cosa, se uno che lasciamo un po' spazio giusto, sì.
Manca Diana, stai sereno per favore.
Le luci sono questo il setup, così non si cambia, è con lo speakers.
La facciamo tutto così, si vede talmente bene.
E poi lo
si vede talmente bene.
Se vogliamo piano si muove.
Michael, cioè adesso se rimane qualche soldo compriamo le buone noi.
No, se rimane qualche soldo, veramente io ce la faccio. Diana! Esatto. Poi per la 4, ma... È molto importante il tempo, è un po' più importante, noi siamo molto psicopatici. Vai, capo. Tu devi sapere se sono chino o normale, no?
Sì, perché ho le configurazioni normali.
Diciamo, abbiamo ovviamente la possibilità che mentre finisce uno noi carichiamo a seconda presentazione, o deve aspettare che finisce, deve aspettare che finisce.
Se è lo stesso computer deve aspettare.
Vabbè, quindi facciamo così, durante la discussione, tu togliamo la presentazione precedente, carichiamola, metti un capo, carichiamola così, sei pronto, tanto le parti chiude. Se ha la possibilità di salvare i nomi, secondo me, l'orario dei nomi, o lui li vede automatico, come fare? No, perché tu mi hai detto che stanno sul programma, non è il problema.
Quando lo mandiamo fuori,
solo quello che vede rosso sarà chi nome.
No, quello di rosso si può caricare.
No, noi comunque mettiamo anche il verde dentro, perché se no non mi esce il nome. Qui c'è il contatto, qualsiasi cosa che mi basta che carico.
Te lo dà.
Vediamo il computer.
Ma come? So se te bravo. Te lo mando per email se vuoi.
No, perché c'è il problema impegnato per l'email. Posso, no.
Quando
C'è il lettore.
sì, eccolo qua.
Grazie. E ti dicono là, questa cosa di qualcun altro. No, proprio, però. No, nel senso, lo tengo come possibile. Ah, ok, sì, quello sì.
Not yet. Okay. It's nice, isn't it?
That is gorgeous. So, right, you see? This is beautiful. Great setup on stage.
Michael, Momeni is not presenting anything for the opening,
Yes.
but Fabio will have three slides.
Like,
Okay.
if we want to present only
next year's congress and then just say hello.
Perfetto, lo mettiamo là nell'angolo.
It's great. So then what, is it the center part of the
Yes,
stage?
where you have from the white vertical line.
Now this is what you want in YouTube. It's like this. We will start shortly.
That's what you see. Yeah, that's not left and right.
Yeah.
Cool.
You have a PowerPoint?
Photo shoot. I know. Arash, the president.
Yeah, that's right, that's right.
Michael, would you like as well to have a photo?
What's how are things at Anderson?
Going good, you know, we're in a chair switch right now, so it's down to the wire. We got 3 finals. It's Ron, you, Jamaica, and Sam Lynn.
Okay.
And, you know, I mean, it's not a bad one there. I mean, it's shades of green, so we'll just have to see. It's going good. It'd be nice to get past this transition. It's been tough.
Yeah, important to have some calm.
Well, there's certain decisions that I think management hasn't been able to make. So
I checked it.
that is our challenge, and like we keep saying, we have open career positions. So we have these open that's then that's our
When are you talking about? Tomorrow? I will find I am here to hunt people down.
That's always
I heard a lot of share searches challenge. On the flip side, I felt like we had a strong Yeah. It's hard to get people to cross. I'll bring it back. It's tough. She's got
Sono 2 3, sì, 2 3 sono
Ah, aspetta.
Barone, una bestemmia, pupuline, o anche, sì, siamo capiti. Lui ha due presentazioni, ma ci mancano ancora 3 presentazioni, 4, una cambiamo. Directly from okay, so can you pronounce it like this?
Yeah.
And each originally, right, so I was thinking about it. So I'm going to
We became friends.
Alex was here, so I said I will go to Turkey, and then very nice. Yeah, I have a good friend who lives in you have no talk in the morning, right? Guido, buongiorno.
Ci interrompiamo tutti.
I trained with somebody, so that's like things sneak up on people. But he had agreed. I'm like, well, that's what he said. He just got it. Yeah.
Have you seen the next year's story?
No, io la passo da là.
I try to stay independent as much as so right, I just kept telling them numbers. They just kept getting more. It's just like they kept questioning, like, am I on this side or not? So how are you? Thank you. I don't have it on the
I'm hunting down people for presentations.
Okay, so actually,
That's what I was trying to get at, because we didn't.
Yeah, 20 years. I like it. It's ripples fairly long, and so it feels great. Let's talk about better ways. Yeah. But there's no we have extras. So yeah, if you go for texture, then it seems like everything bottoms out or goes lateral. I mean, we're kind of used to it. So you just get in almost all patients here.
Hello.
Good morning, my friends.
Oh,
Okay. This is this stage. It's the block of the CT. I struggle with this one.
it was made of color. It's not wrong. It's not the same thing.
Ovo je puno ljepše nego prošle put. Ovo je aktivno. I sjetio sam se kad smo stali tamo prošli, prije 2 godine, na stanici, sve isto, kaže, evo, to su bili isto, ovdje je uvijek bio, sjećaš te, ovdje je mi dobro, znaš, ima tako povaca, a veli, ženski idemo prvo nešto pojesti. Ali neko rade, mogu sada, ne, pusti me, to idemo nešto pojesti. Ista stvar, mi smo došli kad manje kiša složili na te vlade, tom trenutku. Ista identična stvar. Instanci na Uber, ono nije nam ga odjelio, ima kao poziv, znaš, srđeno i onda 20 minuta smo čekali da nam potvrdi auto. Koji dolazi?
Mi smo čekali, kiši ovako je išao red. I tako sam pričao, po jedan, i onda tamo gledam. Ajde da ima 4 da uđu. Jedan po jedan, šire. To je 100 taksi.
A ovdje peć, znaš, imate sad neka kuna, visa sa što, i dolazi nekih ljudi žive. Se gleda ono, prolazi sesiju, nije možeš pokazati kao doćeš znači na odmah, propast. Koliko stane živi?
Ajde, doći ću ja, samo im stavim ovaj prezentaciju pa dođu.
How's everything? Hard to get up? Yeah. I think it's kind of right. Early birds. I should take your number and we should do this process.
a partire, così vediamo se vince della
La vedo così.
Vai. Va bene, no? Sì, non c'è problema. Tanto adesso la gente lo sa che iniziamo a lavorare. Senti, va bene se te la lascio già in considerazione questa, tanto altri non ci abbiamo. Buoni. Non presentation. Se vuoi facciamo un po' di diavolo.
Nice to see you.
Nice to see you again. How are you?
Fine, thanks. As a whole.
That's good.
You have attended every previous workshops here. I followed the net stream. This is the first time. I'm sure it's what is new in Zagreb. In your clinic.
I would say 80% of the program is breast cancer. They have some trauma. Now I'm trying to get that
with breast cancer because it's subject to treatment. Oncologic surgeons in Bulgaria. Many skin cancers, facial.
we have skin cancers as well, but it's more now we are fully
Okay, in the personal is family. This is the most important thing.
University first year on
Great, great. This is the important thing for us.
my doctor and she's been very nervous. Yesterday I tried to put her to go to sleep, but she knows enough to go to sleep. And my boy is
Yes, it's much. Yes, I think so. How that stress, it's stressful. Our profession is very stressful. So it's good. Him. And how about it's fine as well. My doctor is dental nurse doctor. And now I'm trying to help her to find a place where she can learn the basics. The basics. Yes.
been very, very good.
Parla prima lei? Who
Sì.
speaks first?
Sì,
You. Okay, just for the name.
Posso avere un microfono a mano? Next. Can we start the connection? We are. So thank you very much. I'm very pleased and honored to open this meeting. I'd like to thank the authorities that supported us, like the FDA. I'd like to thank the recent NCCN guidelines that cited our research. I'd like to thank all the scientific society that endorsed the meeting. I just cite the largest, like the American Association of Plastic Surgery and the European Association of Plastic Surgery. I'd like to thank the president of the European Association of Plastic Surgery, myself, and all the national society from Europe, because there was a huge support from all national society of Europe. It's impossible to cite all the society, but they all supported us. And of course, I want to thank the sponsors. Without those sponsorship, we couldn't manage to arrange such a meeting. And so we thanks all together the sponsor support. And of course, I like to thank the faculty. The faculty is the strongest point of our program. And if you can see, this is the total age index of the faculty. So what we are going to do today is to give for free on streaming the science according to 1,684 total age index of this Congress, of this faculty, which means an amazing scientific program that will be later after me explained by Mark. Another information that I would like to, it doesn't work, thank you, is this one. 1,610, and it's on a black screen, because this is the number so far today of the BIA-ALCL cases around the world that we have been collecting as a world network for BIA-ALCL. So this is the latest figure, and we are taking care of this problem seriously. And I thank everybody that is supporting us for this. Last information before I give the microphone to my partner, Mark, is this one. Save the date, please. This is the next meeting that we are going to hold in Tampa, Florida, 11-12 of April 2025. As you can see, beside the MD Anderson Cancer Center and Sapienza University, which I thanks again for their endorsement, we have the University of South Florida that will host us in Tampa to give this meeting. And I like to especially thanks the local host in Tampa, which is going to be Professor Denise Dayicioglu, which it's here with us. Please, Denise, stand up and thank you very much for your... We will come to you. Thank you very much for the attention. And please, Mark will introduce you to the program. Thank you.
Thank you so much. You know, it's really hard to believe that it's been 18 months since Fabio and I made our closing remarks at MD Anderson Cancer Center in Houston, Texas. And in that 18 months, while it seems like not much has changed, just going through some of those presentations, you start to realize what a massive shift we've had in all aspects of breast aesthetics and reconstruction. And so we've tried to capture a lot of that in the program that you're going to be seeing today. If we go through the program, we're going to start with some of our topics that we have every year, which is autologous breast reconstruction. Mastopexy is applied to breast conserving therapy, implant-based reconstruction. But what you're going to see is really taking it to a new level, addressing the topics that people want to hear about. For instance, reinnervation. And our entire new panel that we've never done before is technology and innovation in breast. And it's just because so many things are developing right now, whether it's new devices, whether it's research pushing the limits on what we have access to, whether it's AI and machine learning, suddenly changing the way that we interact with patients. We'll also have state-of-the-art on both breast augmentation, and we're going to throw in a fair amount of controversy, really pitting different ideas against each other. We call it consensus, but the reality is that we want to have debate and we want to foster discussion. We've invited all of our friends to help present, but I can tell you we don't always agree with academically all of our friends. In fact, we have a lot of discussions and we work through it. And I always find that at the end of these conferences, if we can achieve consensus, we do something not just for the audience, but also for patient care going forwards. When Fabio first approached me 5 years ago about being a part of this conference, we came up with essentially 3 words that I wanted to define this conference, and it's always been at the core heart of this conference every single year. And those 3 words are accurate data globally. It's to give you the most accurate information possible based on the studies that are being written and to disperse it globally, meaning that we give away the registration for anybody that wants to see this information. That's radically different from any conference around the world. What's been the effect of that? Well, our very first year has been watched 10,000 times by discrete different types of physicians, treating physicians, patients, etc. Almost every year thereafter has been about 6,000. In fact, last year we've had 6,000 to date, and we usually have about 2,000 people watching online in real time. We're currently going to about 50 countries worldwide. And so again, what Fabio talked about, this idea of high impact factor, letting you see the people that are writing the papers, performing the studies, not just paid consultants of companies, but the ones that are driving the field forward. It's not about opinion, it's about evidence. And we will always strive to deliver that for you. I want to thank Fabio for being this year's host and being just the heart of this conference. I want to thank Michael Sorotos, who really makes everything happen, has been absolutely key to the program committee. I want to thank our organizing company under the auspices of Diana Marchik and her fabulous team have done all of the organization and putting us in this spectacularly beautiful hotel. I also want to thank the sponsors that make this happen. And there's really 4 components to this conference: the sponsors, the patients that actually have access to be able to watch this, the faculty for which we couldn't do this conference without, and really push us to our limits to push the field forward, and also the audience. All of you are taking just as much of an active role in this, asking questions, challenging what you don't understand, and just keeping all of us honest. And so with that, we're going to start. You're going to listen to over 70 speakers over the next 2 days. It is just awesome. It's going to be big ideas. And with that, let's begin. Thank you.
So hello and good morning to everyone and welcome to Rome. The first thing I would like to say is to thank Professor Fabio Santanelli for the invitation and congratulate him for the superb organization of this Congress. This section is very interesting and is on autologous breast reconstruction. And so I'm sure every one of us will improve the knowledge of this argument after the speeches of the speakers. So I don't want to lose time for the speeches. And I just would like to ask you to respect the time that is 11 minutes for the speech and 4 minutes for the discussion. And so I ask the moderators to introduce the speakers. Thank you.
All right, good morning. My name is Bert Losken, and I'm going to introduce Arash Momeni. Arash almost needs no introduction. He's going to be talking to us about navigating neurotization of deep flaps and where we are today. Arash.
Thank you very much, Albert. I would like to thank Fabio and Mark for the kind invitation. It's truly an honor to be here today and share with you some thoughts about flap neurotization. These are my disclosures. The relevant one is that I will be showing data that are part of the Sensation Now registry that is sponsored by Axogen. But I think the more important thing is we have reached a time where we're thinking about refining autologous breast reconstruction. And whenever you do that, I think it behooves you to think about where you started. And so when you think about the evolution of breast reconstruction, when we started in the 70s and 80s, we were focusing a lot on flap survival, ensuring that the reconstruction actually is successful. And by the 90s, by the time that came around, we had mastered that. And then we focused on reducing donor site morbidity with the transition away from muscle to perforator-based approaches. So that by the time we reached the 20-teens and now 2020, we can focus on more refined topics such as flap neurotization, patient-reported outcomes. How can we refine the results that we achieve after mastectomy and reconstruction? And I think this slide illustrates it pretty nicely when you look at the first free gluteal flap for breast reconstruction and what you can accomplish in 2024 after bilateral mastectomy and autologous reconstruction, where on the left side, that is truly a reconstruction. And on the right side, that would qualify for panels that we have at meetings termed aesthetic breast reconstruction. So we really have come a long way as a specialty. But it is not really about technical virtuosity of an individual surgeon. Rather, it is about concepts. So what are the goals of reconstruction? And I think that you can summarize those by the 6S. Or success is accomplished when you can create a breast of adequate size, shape, symmetry. Ideally, it should be soft. You should be able to do this safely. And ideally, you should be able to restore sensation. Now, why is sensory restoration important? It goes along the principles that we have in plastic surgery. It's form and function, and breast sensation is a functional component and a characteristic of the female breast. And beyond that, there are practical considerations. We all know, have heard, or maybe have treated thermal injuries, mechanical injuries that result because patients have an insensate breast despite you having recreated a nice shape. And when you have a patient like this, you then have to ask yourself, sensory restoration of what? Of the nipple, of the breast skin, of the flap? These are all open questions. Also, how does timing come into play? Immediate reconstruction, delayed reconstruction, what is the impact on the sensory recovery depending on the timing of reconstruction? And so there are lots of questions, and sometimes it's actually important to look into the past, into the literature to see what has already been addressed and where are opportunities for the future. So again, looking at timeline, in the 70s, you had the first reports of implant and autologous reconstruction. And then in the 80s, you had a decade of nothing, where seemingly breast sensation was really not on the minds of any reconstructive surgeon. It was not until 1992 where we had the first small case series of a pedicle tram being reinnervated. We have learned since that there is an opportunity for spontaneous recovery to occur, certainly better in autologous than an implant-based reconstruction, but we also know that this spontaneous recovery is really insufficient. This is a nicely done study that was published in JPRAS not too long ago, where unilateral reconstructions that were non-neurotized were followed long-term, and at 3 years, you did still see a significant delta between the contralateral normal breast and the non-neurotized reconstructed breast. So there is still an opportunity for us to improve. And that brings me to really the core topic, which is flap neurotization, a topic that really has become a hot topic by all objective metrics. These are kind of the hits that you get when you search PubMed. So there is a lot of buzz around this and a lot of activity on the scientific side of things, which is obviously encouraging. But what are the options when you want to neurotize a flap? And there's 4. You can do primary nerve coaptation, you can use nerve autografts, you can use nerve conduits, and you can use nerve allografts. And each one of those has pros and cons, ranging from donor site morbidity to the distance that you can bridge to cost, like in the case of nerve allografts. But each one of these has a body of literature supporting its utilization. And I think that's where the debate comes into play. And that's where I think the excitement really is. And so that prompted us in 2018 to look at the literature in a systematic way. Unfortunately, we were not able to run a meta-analysis because of the heterogeneity of the data. But what we were able to see is that there seems to be a better and earlier return of sensation if you neurotize the flap. Fast forward 4 years, not much has really changed. We still see that sensory recovery appears to occur earlier and to a greater extent, but the data that fed into this systematic review out of Boston still were heterogeneous to the degree that it prevented them to perform a meta-analysis. So what should we do moving forward? I believe in standardization. Whenever you have a clinical question that you want to investigate, you need to standardize things and you need to prospectively follow that. So standardization with respect to technique and also standardization as it pertains to postoperative evaluation. And these are some of the characteristics that I believe would be helpful for broad adoption, if you will. So technical simplicity, minimization of donor site morbidity, prevention of axonal loss, etc. So I'm just going to run through how we do it in my practice. So this is just standard flap elevation from lateral to medial. The key is the eyes only see what the mind knows. Once you expect sensory nerve branches to emanate from the rectus sheath, you will see them. So once you elevate the flap, you keep an eye out for those nerve branches, and they typically are in close proximity to the dominant perforators that you're going to take. Once you have that and you have identified your nerve, you open up the rectus sheath and then you retrograde dissect the nerve along with the perforator. The key here is that you stop at the sensory motor Y junction of the nerve because you want to preserve the motor innervation to the rectus abdominis muscle, and then you clip the nerve distal to the sensory motor Y junction, again, to have a selective sensory target for the flap and to preserve the innervation to the rectus abdominis muscle. Sometimes you get lucky and you have 2 nerves in close proximity, thereby capturing a broader dermatomal distribution once you perform that proximal coaptation. And this is typically what you have on the back table, a long pedicle and a short nerve stump. That is, however, selectively sensory in origin. The sensory nerve selection, I believe, should be centrally within the flap. So I don't look for nerves along the proximal or superior and inferior edge of the flap. I look at it really centrally because I want to capture a broader dermatomal distribution, which I think intuitively makes sense. Now, the question is to bridge or not to bridge. I don't want to come across like Shakespeare, but I think that's a question, and that's one area of debate, certainly also related to cost. And this is what some of my friends say. They can raise a long intercostal nerve with the flap, and that is true. You can dissect it all the way to the back. The problem with that is that you then by default have to cut the motor branch to the rectus abdominis muscle, which then begs the question, what is the functional benefit of doing so? And then you have a problem with axonal loss when you proximally coapt that nerve. Whenever you talk about preservation of sensation or restoring sensation, you also have to preserve motor innervation to the rectus abdominis muscle. So I do believe that you should preserve motor innervation to the medial aspect of the muscle when you make that split. So I use a lot of heparinized saline solution because it allows for a very clean dissection. It's pretty much bloodless. It allows the heparinized saline to go the path of least resistance, and then you can identify the nerve. It's typically at the level of the arcuate line. You can see a clip on it. That's where the sensory nerve goes up, and you preserve the motor innervation to the medial aspect of the rectus muscle, which also, I believe, helps with postoperative bulging because you have tone in that muscle. The recipient nerve dissection is such that you have two options, medial and lateral. There's pros and cons to both. Medial certainly is consistent, but it is smaller in diameter and it's not the dominant nerve to the NAC. Lateral is larger, but is commonly involved in the thorough mastectomy that we typically encounter. And so my preference is to go medial whenever possible. It's a technique that Aldona Spiegel taught us a number of years ago. And importantly, you're not compromising on the quality of that recipient nerve. The axonal numbers are exactly the same, whether you go into larger lateral fourth or the anterior third intercostal nerve. This is the intraoperative finding when you take the rib cartilage out. So that's what you will see at the time of the recipient vessel dissection, but you can also do it in a rib-sparing manner. So where you fall on that is really up to you. You can do it either way. And then I perform the proximal nerve coaptation first before I go ischemic with the flap. Then I go ischemic with the abdominal flap, perform the microvascular anastomosis, and then perform the distal nerve coaptation. Thereby, you're not compromising any ischemia time. You basically have a natural flow in the operation, and it makes for a very efficient dissection. Whenever you do these things, you have to make sure that you study them. And so this is the long-term outcome in patients that were neurotized versus non-neurotized. And in 8 out of 9 areas of the breast, we were able to see significantly better protective sensory return than in the non-neurotized cohort. And this was independently corroborated by a study out of Cleveland Clinic, where, again, they saw that the neurotized cohort had perform nerve coaptation that these are early clinical results. Clinical investigation still is ongoing, and we're looking at long-term follow-ups. Importantly, we have a number of open questions. The impact of this on patient-reported outcomes. How does flap weight play into the equation? How many nerve coaptations should you perform? What is the impact of medical comorbidities on clinical outcomes? And my final thoughts are the impact of the breast surgeon, because you can do a whole host of different things. You can do single perforator deeps. You can do in-flap anastomoses to have larger flap volumes. You can do stacked flaps and then neurotize each. You can do all this, or you can do even 2 intercostal nerves that go into a nerve allograft to get for a broader area of reinnervation. But when you open up the breast pocket and you see the underside of the dermis after mastectomy, and you then have mastectomy skin necrosis, I think then it allows you to conclude that you're only as good as your breast surgeon allows you to be. And as a result of that, I think that it is very important to collaboratively discuss these topics with your breast surgeon to minimize the ischemic insult so that you can actually then leverage that on the functional side. And with that, thank you very much.
Okay. Thank you, Rush. If anyone has any questions, please come up to the mic. If you can step up to the mic and ask them. Steve?
That was a beautiful presentation. The de-skinning, I have concerns that you encourage marginal fat necrosis in your flap. So by trying to help your neurotization, you're reducing the peripheral vascularization of your flap. These are marginal gains versus marginal losses. And I'd like your comments about that. And secondly, if you are deskinning, aren't you just getting the neurotization as much from your mastectomy flap as you are from the flap itself? I'd like you to comment on that.
Sure.
Because it is all down to the mastectomy.
Totally. So thank you for the question. So the first question that I want to answer is the issue with the fat necrosis. So when I deskin, what I typically do in those cases, I inject ICG after I've done the micro, and thereby I'm visualizing the perfusion of the flap. And I think that's one thing that folks have done in the past, which is where you just look at the dermal level or at the skin level when you inject ICG. And we have kind of a reverse iceberg phenomenon where at the surface level, you have a broader distribution of ICG versus the flap side. So after I've deskinned, I then at times have to trim the flap even further to minimize the risk of fat necrosis. So that hopefully proactively addresses that. The second question, sorry, was?
Just in terms of how much of the need.
Oh yeah, got it. Okay, so the second question was related to, is the neurotization and the sensory recovery as a result of what I did versus spontaneously from the mastectomy skin flap? I think that if I didn't deskin, I would have to say that all the sensory recovery has to come from the mastectomy because there is a dermal barrier at the flap level. There is nothing that would make me believe that after you neurotize the flap, the innervation would jump over intact dermis into the overlying breast skin. When I look at our center's results versus that of other centers where I know that they de-epithelialized it, we do see a delta in the sensory outcomes of the mastectomy skin. So reverse engineering those conclusions, it makes me believe that there is value to removing that anatomical barrier. That's part of an upcoming manuscript. So hopefully we'll address those concerns in the future. But I agree that it's also the quality of the mastectomy. I would assume that if you have a low mastectomy skin necrosis rate and you're respecting the pocket and you're keeping the pocket footprint small, you will by default retain a lot more sensation. So you start at a higher vantage point, and then you will have better sensory recovery over time. Mo.
Really enjoyed the presentation. Mo Nahabedian, Washington, D.C. and Virginia. Quick question. What are your thoughts on flap reinnervation versus mastectomy skin flap reinnervation? So some people take conduits, hook into the intercostals, route it up towards the nipple-areolar complex. How does that compare to reinnervating the flap?
Yeah, it's a good question. I'm a fan of flap neurotization rather than skin flap neurotization for a number of reasons. Number one, it anatomically seems to make more sense, right? When you have an abdominal flap and you're innervating or coapting to the intercostal nerve, downstream, you have a dermatomal distribution of that coaptation effect, if you will. Whereas if you innervate the skin directly, first of all, you need to have a good target. I rarely have anything. I showed you a representative image where I'm looking at dermis. Innervating that is not going to be that fruitful. And also, you're just at best innervating a patch of skin if you go directly into the skin or directly into the nipple. So I'd rather get more bang for buck by going more proximal to then have the dermatome that I capture.
Okay. Thank you very much for your presentation. We started really strong. So I would like to ask now Professor Nahabedian to come to the podium, please, speaking about enhancing aesthetics in Diep flap reconstructions.
Okay. All right, fantastic. Thank you, Mark and Fabio, for inviting me. And what I wanted to do for the next 10 minutes or so is talk about enhancing aesthetics in Diep flap reconstruction. So the way I decided to do this was really to take the good result or not so good result sometimes and make it better. There's so many advancements that we've been doing now with mastectomies and flap reconstruction that some patients we can get good results just from the get-go, but some we have to work at. So this is just kind of a talk about how I go from good to great. These are my disclosures, section editor for the Recon. So I think it's no surprise to all of us now that breast reconstruction is really an aesthetic operation. When we do breast surgery, we really have to have aesthetic ideals in mind and have to know what we really want to achieve. And this is really going to be based on, what we know just from the aesthetic world. So Pat Malucci did this paper, and I referenced this quite a bit as to what constitutes the ideal breast. And if you look at this breast, and this was a study done through crowdsourcing analysis where they asked a number of people what type of breast is the most attractive, they uniformly kind of agreed that that upper pole, lower pole ratio of 45-55 with the lower curve, the upper slope, the nipple slightly tilted upward constitutes the ideal breast. So having this in mind when we're doing breast reconstruction is actually kind of a useful tool. The other one is Phil Blondiel's paper looking at anatomic concepts of the footprint, conus, and skin envelope. So I'm always thinking about where I'm going to position the flap. What is that base footprint going to be like? How much skin do I have? How much skin do I need? And how much volume do I need? So you have to be thinking about all of these things when you're designing your flap and trying to determine how much of a flap to use when building a breast out of it. So guiding principles, we talked a little about just now working with your breast surgeon. That's probably first and foremost. You could be the best plastic surgeon in the world, but if you're working with a breast surgeon who is very sometimes aggressive, let's put it, it may be really hard to get good outcomes because we're going to be dealing with a lot of mastectomy, skin flap necrosis. Not all patients are the same, so it's not a hammer and nail approach. We have to provide the full spectrum, individualize patients, and do what's best. Some patients are going to be better suited for implants. Some are going to be oncoplasty. Some are going to be autologous. Setting expectations, you know, we're kind of driving the bus, but we have to know what the patient wants too. So going from good to great is really going to be kind of a patient-driven thing. So we may be happy with it, but the patient may not be. So there's that line that we have to kind of understand. And sometimes we can realistically get them to that great level where they are thrilled with the result as well. You know, having protocols, so it's not just what we're doing in the operating room, it's everything else before and after, managing complications and having backup plans. Technical details. So when I'm doing immediate deep flap reconstruction, there are certain things that we do that enable us to create a good foundation so that we can work with. Obviously, defining the map is usually along the inframammary fold. So I've got kind of a triangular mound that I'm positioning on that chest wall. If it's a unilateral reconstruction, we may want to cone the flap a little bit to give us a little bit more lower pole projection rather than creating kind of a flatter look, because patients really want more of a projection. But again, it's going to be age dependent. The younger patient may want a certain look, but the older patient may want something else. I like to anchor the flaps medially. So we tend to put sutures, just little absorbable sutures medially to prevent any lateral drift of the flap and maintain that sternal cleavage plane. Sometimes it's good to sit the patient up to about 45 degrees to see how the flap is going to lie once it's within that breast pocket, especially true for delayed reconstructions where we're trying to set that inframammary fold and we're trying to get that lower pole contour. Assessing perfusion of the deep flap. So we do a lot of fluorescent angiography to make sure that we're well perfused throughout, because you don't want to get fat necrosis, which is going to compromise your outcome and get you a less than good result. And then the abdomen is the other part of the good to great. So we really have to tighten up the abdomen. If they have a diastasis, we repair it. We support the anterior rectus sheath and try to minimize any bulges. With delayed reconstruction, determining the position of the new inframammary fold, it's usually a little bit above what you would think relative to the other side in the unilateral. And that's because when you take that abdominal skin, you're going to be pulling down that upper abdomen. So the fold is going to lower naturally. It's better to have a breast that sits a little too high than a breast that sits a little too low. It's really hard to raise that footprint once you've been done. And then you have to try to estimate your volume deficit and your contours. So you're using the other breast as a template. Mustafa Hamdi wrote an interesting paper that I'll talk about in just a second, using a hug flap. So you can take that lower abdominal skin and sometimes make it into a little breast mound to create lower pole projection instead of having to use an implant. So this is what he described. It's using that lower pole skin, keeping it on perforators, just doing transposition flaps and creating a little mound and then putting your deep flap on top of that to give a lower pole projection. Kind of a cool little technique. So whenever we are now getting ready to inset, you know, we will determine how much skin we need. If they've been radiated, a lot of times we'll cut out some of that lower pole radiated skin, just use the natural breast skin to contour that lower pole of the breast. It'll look a lot nicer than having tight radiated skin that's discolored. So try to create all the nicest shape you can using the lower abdominal tissue. And again, sitting the patient up to about 45 degrees. We're never going to get them to stand up, and we're never going to be able to see the true final result until they're in the office, a few weeks later. But at least we can kind of estimate where we need to go. And then the umbilicus, another important part. You don't want kind of a mushrooming belly button. You want something that's going to be kind of an innie. So using some of these dermal fascial sutures to kind of create that nice umbilical appearance. As far as secondary procedures, these were papers that I wrote years ago, but keeping in mind, when you look at autologous reconstruction, initial volume and contour symmetry is not a high percentage of patients. So secondary procedures are common when we really want to go from that good to great. And these procedures may be doing some fat grafting, excising some skin and fat, putting in implants, doing mastopexies on the other side or reductions on the other side. And all of these things can help in increasing that final volume and contour symmetry. So I'm just going to go through a couple of case examples. This is a pre-op patient who's going to have bilateral deep flaps. She's a good candidate. She's, moderate volume, probably about a C cup, and she wants bilateral nipple-sparing mastectomies and deep flap reconstruction. This is what she looked like 3 months later. She's got a very good result. I left a little skin paddle that you can see just adjacent to the nipple areolar complex, but we're going to do a couple little touch-up procedures to kind of go from that good to great. Okay, so what we do later on down the road is we're going to do some upper pole fat grafting. I'm going to revise some of the skin by cutting out those skin paddles that you can see there, and that's just so I can assess, this is how I used to do it. Now I just bury that completely, but that's kind of the skin paddle for Dopplering, but also to kind of make sure that the flap doesn't get congested. And then we can come back a year later and we've got, she's very happy. If you look at Malucci's ideal principles, it really kind of follows that. Her upper pole, lower pole ratios are about 45, 55. She's got that slightly upturned nipple and the nicely contoured lower pole. So she's a very happy camper. This is another patient who's going to have bilateral deep flaps. And, we're starting off a little compromised. She's got some asymmetry. She's got a left-sided cancer, and there's some skin involvement because you can see that erythematous area. So we're going to do skin-sparing mastectomies and deep flap reconstruction. So here she is afterwards. And, from a technical perspective, it was successful, but she's not happy. She lacks projection, which is true. She does, especially on that left side. She's got some asymmetry. Yes, she does. Contour irregularities. Yes. And she wants more volume. So these are realistic expectations. I'm not real thrilled with this. She's not real thrilled with this. So we're going to kind of go through some of the things dealing with fat grafting and implant reconstruction. We've been using implants under deep flaps. This can be kind of a hybrid approach where you put an implant in immediately or delayed. You can do it safely either way. This was just a review that we did several years ago demonstrating that putting in implants is safe and effective. So the first thing we did was we put a small saline implant. And usually on these patients, I put saline implants in because they can put them in deflated and then blow them up. It's a lot easier than putting in a gel implant. And these implants are usually small. I'm not putting in large volume implants. So here she is. She's got her deep flaps. She's got her saline implants, and she's improved. And we've done some nipple reconstruction as well. But she comes back. She's still not quite where she wants to be. She's got some upper pole concerns. And you can see on her lateral views, there is a little bit of a contour irregularity. So again, going from good to great. We just, this is where I say, yeah, we can probably make that a little bit better. So we do some fat grafting, and I think we've improved the upper pole slope. You can look at her lateral, and you can kind of see the position of the nipple areolar complex relative to the breast mound and her abdominal contour. Everything is looking good, but she wants more volume. And I said, all right, fine. We could probably take those implants out and put in something a little bit bigger. Again, this is kind of trying to meet patients' expectations, but assessing whether or not they're realistic. So we take the old implants out, the saline ones, and I put in 250 cc silicone gel implants because now I've got a defined pocket. There's more space. It's easier to manipulate. And we did a little bit more fat grafting, and she's thrilled with this result now. So I think we've gone from maybe the good to great. And again, our beauty is in the eye of the beholder. So sometimes the patients are thrilled with something that I may not be totally thrilled with. Delayed reconstruction, a little bit more challenging because it's a heavier set woman, large breast on the left. We got to do a delayed reconstruction. So we're going to use those principles that we talked about earlier. I'm going to take a large flap. I'm going to cone it somewhat. I'm going to assess the perfusion of the flap. So kind of the line that you see where it says, us is just basically what I would expect it to be, but we did some SPY angiography and we actually had a little bit more perfusion beyond that. So we could take even a bigger flap because the goal is to try to match the other side. We fell a little bit short. The left side is still bigger than the right. So the plan now is to do a reduction on the left and nipple reconstruction and try to get our balance. And here she is 1.5 years out. So starting from a very, suboptimal starting point to ending up like this, she was very happy with it. I'm going to go through the last patient kind of quickly because sometimes deep flaps don't work. This was our starting point where we have a flap failure and we have the opposite flap. And that's the end point where we got, but this was 15 years later. So I'm just going to take you through this. So here we are, revision number 1. We're going to go ahead and put in a tissue expander on that left side. So the tissue expander's in. Surgery number 2, 3 months later, we're going to remove the tissue expander, do an implant. We're also going to bury that deep flap on the right side. So we excise the skin paddle, contour the skin. She's still got some asymmetry. So we're now kind of at a good point, but we're not at a great point. So we're going to do another operation a few years later, this is. So we're going to kind of tighten up the skin envelope, do some fat grafting, make some nipples, and you can kind of see the top view and the bottom view. And we're still not perfect. She comes back 9 years later. Now she's got severe animation deformity on the implant side. And now we're in the era of pre-pectoral conversion. So we take that implant out from under the muscle, put it on top of the muscle, make some adjustments to the skin envelope. And then we end up like this a month later where we're much more balanced. And then 2.5 years later, and this is 15 years after. So we're in kind of a great zone. So conclusions, I think deep flap reconstruction clearly on the rise. Our practice, it's, the numbers are pretty remarkable. More and more patients are requesting it. A lot of technical strategies, outcomes are optimized, donor sites minimized, and successful flaps last forever and usually improve with time. Thank you very much.
Thank you very much for your presentation. Any questions from the audience? It's tough to ask a question. You can ask a question. Yes, I have.
A great talk. I have a question about, excuse me, patient expectations.
Yep.
Help us understand, because we saw a previous talk about neurotizing flaps, and now we're offering potentially sensate flaps and aesthetic-looking flaps. And are we not setting the bar too high?
Yeah, it's a good question. Because we can't make promises that we can't deliver. So my philosophy is under promise, over delivery. So when we talk about resensation, I tell them the likelihood of this working is probably pretty low. So I try to lower their expectation when it comes to that. And you and I have studied this before. We've looked at body dysmorphia, and we kind of have to make an assessment how many of these patients really have realistic expectations. How many are happy with their breasts before surgery versus after surgery? So there's a little bit of psychology that goes into all of this. And I think the longer you do this, the more keen you get at picking up certain red flags that make you realize that, wow, this is going to be a difficult patient to manage post-operatively, or this patient's going to be very easy to manage post-operatively. Usually patients that have lived with a deformity are much happier with the outcome. Even if you don't think it's great, they're thrilled. I've had patients who, have attractive breasts who want to look even better, and you may get a great result and they're not happy. And it's just this disconnect sometimes. So there's this psychological component to dealing with breast surgery.
I have a question as well. Do you think you can get the same results in terms of projection only with fat transfer in the patient instead of just putting an implant in?
So my philosophy on, I'm a little skeptical of using fat for volume. It can work, but I use fat for contour. If I need volume, I think, having one of those hug flaps or, an implant just works better. So I know people have, Roger Corey's done all these, delayed reconstructions using fat, and I think it works great, but there lacks that structural integrity. I've seen some of these patients, and they look one way when they're lying down or when they're standing up, but when they lie down, it's it's very interesting what happens to those breasts because they lack structural integrity. Okay. So I think implants are better.
Very quick question. We don't have much time.
Joe O'Donoghue, UK. Thanks, Mo. Great talk. Just a brief summary of your thoughts on immediate symmetrization as opposed to delayed symmetrization.
Yeah, you can do immediate symmetrization. I think my issue is I never really know what that final result is going to be until maybe 6 weeks after. So I wait for everything to settle, and then I can kind of decide exactly what I need to do. So my approach is to do delayed symmetry procedures, but we've looked at that as well, and I've worked with Alberto Roncati on these topics, and he's a big believer in doing everything immediately. So they both work. It just depends on what you're most comfortable with.
Okay, thank you very much for your presentation.
Okay, you can. Next speaker is Steve McCulley, and he's going to be talking about fat-augmented latissimus flaps.
No, beyond Diep flap.
Oh, I'm sorry. Beyond the Diep flap. The print's so small.
I hope I'm not talking about that. Is this the? Thank you very much for the invite. Just for the younger surgeons, in terms of patient expectations, make sure you take pictures of average results and bad results. You'll spend your career taking the pictures of your best results, and then you're really making life difficult for yourself. So take pictures of disasters. So obviously Diep flaps always going to be the main workhorse. I've done all of these flaps, but actually what I thought I'd really talk about more was how it applies to my practice and what I've evolved. Patients who haven't got Dieps really are often, not always, but often small-breasted women with limited donor sites. And in terms of my last 25 years of treating these patients that I can't do a Diep flap on, I'm going to start again with this, let's reevaluate the mastectomy, let alone the need to do a bilateral mastectomy. Extreme breast conserving options in these patients are often a better option. I'm going to then look at tug flaps versus pap flaps, because these are definitely my second choice. And then back to traditional, but also pedicled options, which we mustn't forget. And I'm going to introduce you, for those of you that are not familiar with, the LTAP flap. So it really is always my first question, and particularly in these patients, and it's really can avoid, we can avoid mastectomy and get these good results. And it's particularly important if you have a patient that is going to have adjuvant radiotherapy and you've got limited donor sites, stop and think whether you have to have a mastectomy. And the era is changing. We're seeing increasing numbers of important papers recently that's actually showing survival advantage to breast conservation. So you're going to have to seriously ask yourself questions, particularly if you're taking both breasts off a woman, for probably no oncological advantages and probably even potentially disadvantages. And these results are coming out on both sides of the Atlantic now. So we have to make a stop moment. And, look, these extreme breast conserving procedures are more the domain of the large breasted women. And that's not what this talk's about. But local perforator flaps are definitely a big option for these patients. But I'm going to talk to you about something a little bit more controversial. And actually, if I have these patients classically who are not suitable for Diep flaps, and I re-look at the options of breast conservation, even extreme conservation, taking off half their breast, I will frequently consider the use of a free flap. They're suitable as a standard breast conserving option. They're absolutely perfect for upper, inner, medial tumors. You have considerably less breast undermining. You're leaving a sensate breast. In a busy micro unit like mine, these are 3-hour operations. It's the same as doing a local flap. This is not a big operation. They're throwaway, well-vascularized flaps. And you can use all sorts of versions of the flaps. I've been doing this now for nearly 15 years. I wrote up predominantly using a small tug or gracilis flap. They're incredibly quick, incredibly easy. They're available on nearly every patient, as long as you're now modifying the size of the breast that you're trying to create. But obviously with the tug, it's a shorter pedicle. And really, you do all the surgery straight there. I do put a scar medially, but they're all getting radiotherapy. And so particularly in that patient who's already going to have radiotherapy, you're not changing their adjuvant treatment. So I wouldn't think twice about taking out a significant percentage of the breast because it's still a throwaway flap. You can do it as a single or dual stage, and it's quick surgery. So if more traditionally, I would have done it like this as a small mini tug. You can leave a little bit of a skin monitoring, or I just bury them. And, you know, the scars themselves will settle extremely well because they're all getting radiotherapy anyway. And you've got sensate breast, and you're allowing reconstruction. This woman's had the medial half of her breast removed. She doesn't have great autologous options. Bilateral cases, which I've done similarly. The only thing I've shifted to in more recent years is I tend to not use skin, and I now use the sort of muscular adipogracilis. So I put leave fat on top of the gracilis, and I find it shrinks nicely. These are a lot of upper pole tumors. You actually want the flap to shrink a little bit. You don't want it to remain bulky. So it's a bit out there. Obviously, not everyone is suitable for extreme breast conserving surgery, but there are many small-breasted women who are told to have a mastectomy who still oncologically do not have to have a mastectomy. And I know it's easier for me because I do my own oncology, so I'm making my own oncological decisions, but it's still beholden to us to question whether it has to happen, because this is a great option. These women often will be sent down a pathway of no mastectomy or bilateral mastectomy. If they need radiotherapy, they're going to have either an implant or a deficient flap, which they're going to have problems with that. This becomes a great option for these patients. So, but not everyone can, many patients or some patients will still need a mastectomy. So my second choice preference has become the PAP flap. For those of you that are familiar with it, it's obviously the profunda artery perforator flap. I've moved on from this from the tug flap, mostly because the pedicle's longer. It makes it easier for your shaping, and the scar's a little bit more posterior. So this is a lady I literally did only a few days ago. So that's her early result. But just to show you, for those that aren't familiar, that is the gracilis. And then you come in behind the gracilis, there's a ductor magnus, and it literally 8 centimeters down, 2 to 3 centimeters behind, there's your PAP perforator. It's very consistent, and you can Doppler it out. And as I say, the main advantages of this is that the scar's more posterior. So from the front, the patient sees a lot less. But even with these flaps, the thigh flaps, you will see asymmetry between the thighs, and that's the one reason it would always be a secondary choice for me. And it is more difficult to shape because you've got a long banana or melon-shaped piece of tissue, and you're having to fold this or croissant it round to try and get that. And you can see even here a limited delayed with limitation of the upper pole simply because of that difficulty in shaping. One thing that you can consider, but they've got to have the right thigh, and I don't love the donor site, is a sort of extended tug flap where you can take the skin down on top of the gracilis. This does actually give you a lot more additional tissue, and therefore it does keep the width in the flap. But obviously you're going to end up with a T-shaped scar, a bit like in a certain type of thigh lift. But it is a trick if they've got the right loose thigh to add extra volume. And you can take that skin the whole way down on top of gracilis. It adds a lot of extra volume to that flap. And here's a lady that I've done an immediate on the right. She's had a previous Diep flap. That scar's still early, but you've got to have the right patient to tolerate that sort of donor site. And again, similarly, very short on tissue. I've used an extended version of that just to try and get some filling simply because the upper pole is so empty on the patient. Pedicle flaps, let's not forget them. I know it sort of seemed very old-fashioned and unfavorable, although we're going to hear how to make LDs work even better. But actually, an LD flap is still a great operation, and it's still definitely a get-out-of-jail flap for me. And I think it's almost bizarre now that my trainees come rushing to look at the LD flap because they haven't seen any, whereas, you know, the Diep flaps is almost boring for them. And for sort of more junior surgeons here who won't get to see as many, this is an incredibly reliable flap, and we're going to see other versions of that, I think, this morning. And you can get some amazing results. This is one of my patients who's in my neoadjuvant radiotherapy series. And delayed, I think, more problematic, but it is still feasible. But in terms of pedicled options, this is my new favorite since I wrote up about LTAP flaps a number of years ago. So the lateral thoracic flap is an incredibly expendable, readily available flap for many patients. And for small-breasted women, for a total reconstruction, it's similar in terms of the volume you can get from a TDAP, but you're not having to use the thoracodorsal pedicle. I'm just going to show you a little video, if it plays. It played, yes. Now, this is a breast conserving case, but it's just to show you where the lateral thoracic pedicle is. And there's the lateral thoracic artery and vein. The only thing, that's the perforator from the lateral thoracic vessels. Those are LICAP perforators down the bottom. And the beauty of this flap is it's readily available in 90 to 95. There are a small group of patients who don't have a descending artery, so you do have to check that. Here I'm actually looking at the options of this, albeit a breast conserving case, and I can't speed up the video, unfortunately. So here it is now isolated, and that's on the lateral thoracic, and you can do all your axillary surgery. And the beauty of this, you've got a true pedicle that you can pop into the center of the breast, and you can just do a bigger version of that. That's a breast conserving version. But here is, so basically here is exactly the same operation. You don't have to completely skeletonize it. And that's the lateral thoracic vessels in an array of tissue. And you can take that flap from the lateral chest wall and do a total reconstruction. There's no muscle involvement. You're not having to dissect any muscle. It's really quick to dissect. This is a 45-minute operation to raise. It's a day case operation. And it's become almost my default option for small-breasted pedicled options for partial and total breast reconstruction. And it's similar in concept to the cosmetic use of LTAP flaps or LICAP flaps. And that's a variation of this where you can keep the LICAP flaps, and again, in total reconstruction, if they've got the right body habitus to fold over. And just to finish, although this is a talk about when they can't have a Diep flap, but actually there's lots of patients who you think can't have a Diep flap, but they can still have a Diep flap. And I've just put this in. This is my go-to vascular augmentation method. I extend the main pedicle. I use a contralateral vein, whether it be the SEIA or the circumflex femoral, and just take on another 2 centimeters of the main pedicle, and you can do it all on the abdomen, and you can extend lovely thin flaps and extend the role of the Diep flap. It's also my go-to salvage option. So in summary, look, just question sometimes the need for a mastectomy, particularly in these difficult patients. Thigh flaps are my second choice after Dieps, but certainly don't dismiss pedicle options. And thank you very much.
Thank you very much. Any questions?
I have a quick question. You asked me to push you, and I'm going to. A lot of the women or the patients that need a free flap for a medial defect for breast conservation have relatively small breasts. It's not being that conservative when you're having to do a free flap. How do you justify not just doing something like a nipple sparing and an implant if they don't need radiation therapy?
Well, I would say that there's 2 ways of looking at that. I mean, if you're going to take that argument, why would you do breast conservation on anybody? Because the sensation from a mastectomy and the complications of a mastectomy with an implant are not the same as an autologous reconstruction. So this is allowing me to do an autologous reconstruction in a patient that can't really have one. She still has the benefit of 60% of her breast left, so she's got a sensate breast. I mean, I don't need to tell you the advantages of breast conservation. What I'm doing is inferring all the benefits of breast conservation onto that lady. And then you call it radical. Well, it probably doesn't take you 3 hours to do a nipple sparing mastectomy and an implant, but it doesn't take you 20 minutes either. I'm doing this in 3 hours. Okay, we've got an experienced micro unit. I don't see it. I think we're over it being a big operation. It's just a free flap. You know what? It's just a free flap. We've heard how we've evolved. It's back to the days of oh, let's do a fasciocutaneous flap on the lower leg, and because, you know, it's quicker and it's easier. Well, it's not quicker and easier always, and it's just a free flap. Let's just, so I don't see it as a big option. I think it is extending the advantages of breast conservation to that patient, and I'm allowing an autologous reconstruction with all its advantages, and particularly, now, I think your argument is good if there's no radiotherapy, but I think I could even still argue that with radiotherapy, it's a total no-brainer.
Okay, quick question, Mark. We have only 1 minute.
Thanks, Mark Clemens, MD Anderson. Great outcomes. Thigh and PAP base flaps, I still struggle with that donor site. I still have a high rate of skin dehiscence. A lot of those patients end up packing them for about 3 or 4 weeks. Can you give any kind of insight, any restrictions, how you close that? Even with zero tension, they'll sometimes still come apart.
Yeah, I think we get too greedy. We take too much, and it's really, really tempting to take too much. So, you know, I would always probably say mark it and then make sure you cut inside your lines. It's one of the times I will actually use superficial suction dressings so I have that as standard on my thigh flaps now. And the other thing I would say is get your flaps a bit lower. They heal better slightly lower. We have this obsession with trying to, this perforate is 8 centimeters below the crease. So just accept it's lower. It's not in the crease. And people try and put it in the crease, which I think makes it more of a problem.
Okay, thank you very much. Okay, we're going to move on to the next talk by Professor Santanelli di Pompeo, Fat-augmented Latissimus Dorsi flap. I would like to remind you have 11 minutes for your talk.
Thank you very much. So I'm impressed by the session is on autologous reconstruction. There's so many colleagues interested in autologous reconstruction. This is something quite new for me. So I'd like to present the procedure that we have developed since a few years about the fat-augmented Latissimus Dorsi. And this doesn't work. Okay, that's my disclosure. Good. Total autologous reconstruction has some drawbacks, as we could see. One is that some procedures are demanding, like microsurgery. Not all the facilities are available. Sometimes you don't have microscope in some areas, so not everybody is able to afford microsurgical reconstruction. And then sometimes you need, with other procedures like fat transfer, you need multiple stages in order to reach the goal. So we've been concentrating, trying to find a solution for an alternative for other situations. And then we start using the thoracodorsal system, studying the thoracodorsal system, and we developed a technique which was the lateral thoracodorsal artery augmented flap with fat grafting, immediate fat grafting, in order to achieve the volume necessary to have a good reconstruction. Actually, you can harvest quite a lot of tissue from that side. Still, the perforator is quite thin, and the procedure is more difficult. It's a microsurgical procedure, even if you don't have anastomosis itself. But what we really didn't like, not so much the result, which is excellent result, you can have immediate. What we didn't like, it was the donor area. You have such a long scar that's going from the posterior thoracic wall, continuing into the mastectomy scar, and such a long area that you cut the chest wall of the patient in two. It's too much for aesthetic. And so we end up by chance in a case that was one of my assistants that was supposed to do a Latissimus Dorsi, and he ended up in a congestion of the flap. So they called me, and I went into the surgery. I decided to cut the pedicle because there was some damage. So I took the flap, I moved it on internal mammary artery and vein, and I did it free Latissimus Dorsi. And because I did the free Latissimus Dorsi with anastomosis there, I didn't feel comfortable to put an implant on the anastomosis because I was afraid of this possible compression. And then I let it heal like that. Then I went and I said, well, why don't we try to put some fat grafting? And the idea was quite good. So we achieved quite a good result, fat grafting, secondary the Dorsi. And that was the pre and that was the post-op. after fat grafting with nipple reconstruction. Then I was so happy about the result that we started to think about to use this possible technique. This is not an extended lat dorsi flap. It's something different. The extended lat dorsi flap has a high complication rate because you harvest all the fat around from the muscle, you impair the vascularity of the remaining skin, and then you have to close under tension the skin from the backside of the thorax. So you end up quite often in poor aesthetic results. So our aim was to develop a procedure which could be totally autologous, non-microsurgical, so easy to carry, and immediate or delayed, can be used in a single stage with good aesthetic outcome and a low complication rate. Then we went into the old friend Latissimus dorsi, and we thought about to augment the Latissimus dorsi immediately, because in the patient of the age of the cancer, they might end up, patient by patient, of course, with some fat on the posterior thoracic wall, exactly overlaying the Latissimus dorsi. You may have something like 300 ml of fat, which you can increase with fat grafting. And we carry this procedure as unilateral procedure in 2 hours, more or less, and bilateral in 4.5 hours. And you have bilateral totally autologous reconstruction in 4.5 hours. We work in multiple teams. Someone does the mastectomy at the same time, someone else does the flap harvest, and I'm doing the fat harvest, and then similar for the bilateral. The harvesting procedure of the fat is a standard, and is a standard also the management of the fat according to the centrifugation only, like Coleman described. Well, what is interesting is where we place the fat, because we transfer the fat anatomically. So we give a preference to the lower pole of the skin pedal so that we can expand the lower part. And we use fat harvest and fat transplantation with small syringes in order to have very low pressure. And that's a key for good take of the flap and the fat and survival of the fat cells. So that's what we do mean for anatomic fat transfer. We expand the lower pole of our Latissimus dorsi flap. By expanding the lower pole, when you put it into your nipple sparing mastectomy, you have such an amazing result already on the table. That really looks like to having old anatomical implant, but don't. That's just totally autologous. What I like to stress is this is not an extended Latissimus dorsi fat with fat. It's totally different. It's the extended Latissimus dorsi with fat include vascularized fat tissue also outside the skin pedal and fat grafting. We do not include fat tissue outside. We only take the fat tissue under the skin pedal, and we preserve completely the donor area and the skin. So the fat is transferred, nevertheless, above and below the scarpa fascia of the skin pedal. We transfer some fat between the pectoralis major and the pectoralis minor, and in the superficial fascia of the lat dorsi. So we try to harvest any possible recipient area in order to increase our flap. But it's not transferred between the muscle fiber, because we think that by giving edema of the muscle where the perforator are passing by, we just can risk to impair the perforator and the perfusion of the flap itself. Then comes a point how to harvest the flap in order to have the best outcome also of the donor area. You have 2 chances, of course. You can make it oblique like that, and you can make it harvest. If you make it oblique, you have the maximum benefit in terms of volume that you can harvest. If you make it horizontal, then you have less volume that you can harvest, but the best possible way of hiding the scar under the brow line. But sometimes the patient doesn't heal very nice, and then they have to wear a large brow or a large swimming suit in order to hide such a scar. So, of course, in between, there is always the best. And the best way is to put it slightly oblique so that you position your superior elliptic line under the brow. And then what is going to happen when you close the donor area, you lift up the lower part. And so your scar will end up under the brow line, and you will not have a problem. So this is the flap that you are going to take, and this is the movement that the skin will do behind. So if you have it slightly oblique, this is the best to cover with a normal bra or normal swimming suit. So we investigated our last experience is 206 fat-augmented Latissimus dorsi flap. and 78 unilateral, 64 were bilateral. These are patient demographic characteristics. So we do not restrict for smoking. We operate a radiotherapy patient, immediate, delayed. The type of mastectomy was evenly distributed between the nipple sparing, modified nipple sparing, and skin sparing. Complication rate extremely low with this flap, extremely low. We had only 2 partial fat necrosis, 3 partial fat necrosis, 1 seroma, 2 woundations. So it's really reasonable procedure. The aesthetic results are amazing, especially if you link to nipple sparing or skin sparing mastectomy, because you position the scar in the best possible way. And the skin texture, of course, is much better because you preserve. So I like to show you a couple of cases. This is a unilateral left fold flap. Immediately reconstruct just by putting the lat dorsi and 90 ml of fat, and you have perfect symmetry. You can use it also in bilateral case when you need to correct also a malformed contralateral breast. So this mastectomy was done on the left side, and that was the reconstruction and the improvement also on the right side at the same time with fat grafting. That's another bilateral case with only 85 ml of fat transfer, and you have an immediate excellent reconstruction, very similar to the preoperative situation. So the take-home message of this flap is that you can achieve a total autologous breast reconstruction of small to medium size, but even large if you go on with fat grafting. It easily enhances the final breast volume in one stage, a very low complication of the recipient and of the donor area as well. And it expands indication for autologous reconstruction also to those patients that are poor volume donor areas for free tissue transfer. You may end up. And there is also, as a good outcome, a very good improvement of the donor area because you do liposuction at the same time and the patient enjoy very much to improve it. Thank you for your attention.
Thank you very much, Professor Santanelli. Thank you for giving back 1 minute to the other presenters. Any questions from the audience? Yes, please.
I'm Deputy Mary from Greece. Thank you, Fabio. It was a great presentation on flap. I'm doing a lot of those surgeries as well. Would you like to comment a little bit when you are using this flap in delayed irradiated patients? How do you inject your fat? Do you also fat graft the thoracic skin? Because in those cases are much more demanding and much more difficult to produce a nice breast contour, at least in my experience.
Yeah, of course. I mean, it's all about, I think, of experience. I mean, you can inject the thoracic skin after the radiation because you will improve the texture and the quality of the skin. But then, once again, it depends if we are talking about a nipple-sparing mastectomy irradiated or if we are talking radical modified mastectomy, because when you do a delayed radical modified, then you replace the whole skin. And there is not so much to inject because it goes out from the breast mound. If you do a nipple sparing, yes, with care, careful, as less as possible, I would say, because I feel a little bit scared about to injecting any irradiated long flap like this, although it's already autonomized and there is not a big risk, but this is possible. So we do inject wherever it's possible, including the thoracic skin, but not over-injecting, I would say. Thank you.
Okay. Thank you very much. Any other questions?
I have a quick question. Still my favorite flap, so great talk. Can you talk a little bit about what you quote patients on volume resorption, since it is such a well-vascularized flap?
Yeah. So I apologize. I'm not able to give a data about the reabsorption. To me, it doesn't exist a reliable method than the photography, the post-op picture itself. I can say only that we reach good symmetry in a reasonable number of sessions, which is on average, depending on the patient, how much you really need to augment, because how much is big the flap itself in the beginning. So on the average, we need only one immediate session or a couple, which means an extra session, and you can achieve the the good symmetry. Then it depends also how big is the breast that you have to reconstruct, because you have to start with the D cup, then it takes longer. I mean, in our experience, we've been reconstructing any sides of breast, but of course it takes time and number of sessions. If I may say, very non-scientific, but please do not send it on streaming this information. We have approximately a 75% take, I may say, about that one. So it can be 60, it can be 80, I don't know. It's enough reasonable to do this procedure on my knowledge.
Okay, we accept one last question very quick.
Thank you, Fabio. Just a very brief comment, if you may, please, on transecting or not transecting the nerve.
That's a good comment. No, we do not transect the nerve when we do the total autologous, because this will keep the bulk, help to keep the bulk of the muscle, because of course you keep bulk of the muscle once you have innervation, vascularization, and tension. Of course, we try to reinsert the muscle. So we fold the lat dorsi and we reinsert the muscle along the resection border so that we keep the tension. That will help to keep the bulk of our breast reconstruction, which we do when we have an implant with lat dorsi. Then we cut the nerve. Thank you.
And now we call Guido Paolini, Sculpting Solutions, the art and science of fat grafting-based breast reconstruction. Thank you, Guido.
Good morning, everybody. I wish to thank Fabio and Mark for the invitation. So since Coleman described structural grafting for the breast in the 90s, AFT has become an autologous alternative for breast reconstruction. Ideal candidate should be a small to medium breasted patient with available fat deposits, should request autologous reconstruction and refuse implant. So we searched the literature for the available methods for fat transfer with the three different steps: harvesting, processes, and infiltration. Abdomen and inner thigh are the preferred sources for fat because they show increased structural integrity and vascularized of their fat. Regarding infiltration, the use of tumescent solution has proved better than dry technique because of it enhances adipose cell viability with also in an increased easiness in fat separation. So we found several techniques to perform liposuction that we all know, but nevertheless, handheld syringe liposuction is still the mostly used. And we found that provided that the tumescent solution is used, all the techniques can give good results. Regarding the cannula, we can use a Coleman basket cannula, 2.5 multi-holes, a barbed, or a large cannulas. What came from literature is that large cannulas give greater graft with improved adipocyte viability. We have a lot of different processing techniques from centrifugation, decantation, and filtration, and the recent closed system that have allow also fat enrichment. Cotton gauze has proved to be a good method compared to the others for increased viability. Fat infiltration can be performed with different cannulas, with 1.5 blunt tip cannula, larger single hole cannula, multi-holes cannula, or large bore cannulas. The important thing is no matter what cannula you use, but inject slowly at 0.5 to 1 millimeters per second because it has a better take. This is the main issue, volume retention rate. This is very difficult to objectively assess, even though we have a 3D laser scanner and we have MRI and CT imaging that can help us. Nevertheless, the high number of studies trying to focus on it fail to agree on the best technique or the best method to measure it. And we see that, like with centrifugation, they range from 34 to 68% with a minimum of 54%. Complications at the breast site are mainly composed by fat necrosis, oil cysts, macrocalcifications. The complications at the donor site are very low, and generally altogether they range in between 0 and 6%, so they are very acceptable. Patient satisfaction is an important issue. In a recent paper, FT showed higher breast scores compared to DTI implant reconstruction, with high patient and surgeon satisfaction, around 95%. So by reviewing the literature, we were searching for the best technique. But what we found, agreeing with this work from Landridge, is that all techniques can do a great job, and the new closed systems have promising results in head and neck. But regarding the breast, there is no apparent difference of what technique is used. Our technique relies on the use of a Coleman or barbed 2.4, 2.5 cannula, centrifugation for 3000 RPM for 3 minutes, fat separation, and the use of 10 cc syringe and 1 ml syringe for the injection. We use a multi-point access with the use of 21G Venflon and the stopcock method for lipostructure. Here we see the multi-access holes and the technique of infiltration. Here we see superficial infiltration from a peripheral site and from the periareolar site. We then go to deep plane infiltration to increase volume of the breast. Regarding volume and timing, we usually wait 5 to 6 months after nipple-sparing mastectomy before performing AFT, and then each 3 months we go with the other procedure. While if there is radiation, we wait 6 months from the end of radiation. Regarding volume delivery, we just deliver about 1/3 of a mastectomy mastectomy volume in the first session, and then we increase by 30%. So the tips are to maintain sterility, to use low negative pressures to harvest fat, low centrifugation forces, do not expose fat to air, minimize handling, use slow flow or low pressures to deliver fat, and avoid high interstitial pressures in the recipient area, keeping in mind the graft to capacity ratio that Del Vecchio showed us. So the main issue remain to maximize the infiltration technique, then the factors affecting graft take, the skin envelope expansion, and oncological safety. Regarding the infiltration technique, we plan multi-holes infiltration. We start from superficial plane to firstly correct superficial irregularities and skin retraction. We then deliver 10 cc of fat from each hole on all the different planes to evenly spread the graft, and we stop infiltrating when the cannula penetrates without effort, when the fat is delivered without resistance, and before the tissue becomes tight and the shape is deformed by increased pressure. The factors affecting graft take, mainly radiation, but also smoke, came out from our paper, and surely delayed wound healing from mastectomy complications. Regarding skin expansion, we do perform internal expansion, not external expansion, with the aids of needling or correctomies that aids us in releasing scar contractor and expanding volume deficiency. Regarding oncological safety, recently reported our experience on 1,000 post-mastectomy breast reconstructions, and in our paper, autologous fat transfer was not associated with an higher incidence of local regional recurrences. Risk factors were invasive ductal cancer and negative positive node positive patients. And taking a further look at the literature, we found a lot of systematic review meta-analysis on the matter, and they all come to the same conclusion that fat grafting is a safe procedure after breast cancer, and that there is no any increase in the incidence of local recurrences of metastases and or for overall survival. In our breast reconstruction armamentarium, we reserve fat grafting for partial total breast reconstruction after BCS or nipple-sparing mastectomy, while after modified radical, we prefer to use flaps. We start with a typical case of a patient undergoing a left quadrantectomy, and 2 sessions of fat grafting were performed to achieve a good symmetry and final result. An improvement also of the donor area was obtained. We then go to total breast reconstruction after nipple-sparing mastectomy. The patient had a left nipple-sparing mastectomy through an axillary incision. She had also radiation because of positive nodes, and so she underwent radiotherapy, and we needed 3 sessions of fat grafting to achieve a good looking breast and to improve symmetry and also moving of the nipple, which was retracted. This is an average patient, no comorbidities. She needed 3 fat grafting sessions to obtain a good and natural result. While this is a smoker patient, and we found in our work that smoking patient need more fat grafting, but in 3 sessions we could achieve an acceptable result. This is a bilateral nipple-sparing mastectomy irradiated, so difficult case, and we needed 1 more extra session to achieve a good result. Last case, this is a bilateral nipple sparing. 4 sessions, we achieved a good symmetry. Finally, fat grafting is a versatile technique. There is no ideal method to do it. It's very easy to reproduce good results, provided you perform an automatic technique and low complication of autologous reconstruction, aesthetic improvement of donor site, and oncological safety and patient satisfaction. Thank you.
Thank you, Professor Paolini, for your presentation. Any questions from the audience? Okay.
Jerzy Kolosinski from Poland. Congratulations, very nice and excellent results. Only one comment. After the total mastectomy, I combined this method with internal expansion and later deflate the expander and use the fat grafting. I think it's very useful in such cases. And I found the healing of the fat is better than simple fat grafting.
Thank you for your considerations. Yes, we have used this method also because we have our friend Professor Berrino, who first proposed this technique over reverse expansion. We prefer to use it eventually after modified radical mastectomies in those cases in which patient cannot go to flap surgery, and so we put the expander and we do these techniques. In nipple sparing, we prefer to avoid the insertion of the expander because then you need to have a further step to remove it. So we just use it in those cases. Thank you.
Okay, one more question.
Thanks very much. You showed some amazing results, albeit with multiple stages. How many stages on average do you use in the total reconstruction? And how many of your results are of that outcome? So what would you regard as your failure rate in terms of an end result that need other things to be done?
Yes, thank you. Usually we need at least 3 to 4 sessions. It depends on the volume of the breast at the beginning of the surgery. And another important issue is the scarring of or the retraction of the skin. If you work on a patient that had like an hematoma or a seroma after the nipple sparing mastectomy, and then she developed a retraction, or the skin is very retracted to the breast, then the first section of AFT mainly serves as to relax the skin contracture, to improve the texture of the skin, and to better offset the further fat grafting. So I think it is a matter of selection of the patient. For bilateral cases, we usually select patient with cap A, at least B breast. If you have a unilateral case, then you can go further up, and with 3 to 4 sessions, you can achieve good result.
And in terms of that sort of quality outcomes, are you seeing that in all of your patients, or do you have a failure rate where patients just aren't getting the result after 3 or 4 and they have to have an implant? What is your failure rate in terms of it?
I've had very successful cases starting with lipofilling and after 2 sections then switching to implant, agreeing with the patient, and you have wonderful result and very good symmetry, and you mimic like an hybrid reconstruction, which today is proposed, but that's not the initial idea. We start with fat grafting, and then if we see that things are going too long, then we can switch, agreeing with the patient to put a small implant.
Thank
you. Okay. Thank you very much for your presentation. We'll move on.
All right, thank you, everybody. This is the last talk of this session, and whenever someone has a personal 40-year perspective, they really don't need any introduction. And Dr. Pribaz is one of those. Most recently is from the University of South Florida, Tampa, which is the host for next year. And Dr. Pribaz is going to be talking about evolution of autologous breast reconstruction.
Thank you very much, and thanks to Fabio and Mark for inviting me. And he's given me the impossible task of discussing the future, but also to discuss all the landmark papers that have entered our specialty. So here goes. So, you know, the hardest thing is to predict the future, but because life is a continuum, you can prepare for the future by examining the present, and to understand the present, one has to study the past. So when we're looking at landmark publications, this kind of raises the whole concept of invention and innovation. And I just want to make a few comments about that, you know, necessity is often called the mother of invention. And this is when it fulfills an immediate need and it's readily adopted. But invention is also the mother of necessity, where an invention occurs and it's waiting for an application. And there are many inventions out there that you'll probably revisit by looking at the literature and come up with alternatives going forward for the younger people. One has to differentiate between invention and innovation. You can invent something, but it's really the people that innovate that take this invention and with their creativity, exploit it and develop something that's more useful, such as the wheel, the motor car, and obviously the cell phone. And there's also the concept of timing of invention. Sometimes there's invention and reinvention. And a typical example in our specialty is with Tanzini, with the Latissimus Dorsi flap, and Olivari, who reinvented it some 70 years later. And it's also looking at the contributors to this. Not one person is responsible for medical progress. Joseph Murray, in his book, said, we really have, and this is also in biblical things, we've drunk from the well that we didn't dig, and we've warmed by the fires we did not build. So we really benefit from the dreams and work of our predecessors. So most of the improvements that we'll see in reconstruction is incremental, but there are some eureka moments where, you know, really major breakthroughs and paradigm shifts occur. So when I first started my training in 72, there was no breast reconstruction as a specialty. We had very few flaps. Survival was the key. And my very first paper was actually on the omental transposition in advanced breast cancer treatment. So there was no breast reconstruction at all. But nowadays, we have so many options, and the emphasis now is more on refinements. And the whole new subspecialty of autologous breast reconstruction has evolved. What caused all this to happen was really the introduction of microsurgery through replantation and then through flap development. What this led was for people to go back and look at the blood vessels of tissues and develop multiple flap options. And so, you know, there are many people that contributed to this with the development of the musculocutaneous flaps of McGraw and DeBell, and also Mathers and Nahai with the classification of the various musculocutaneous flaps. Ian Taylor also should be credited for all his work on angiosomes and all the vascularity, especially of the rectus abdominis muscle, which he elucidated, and also the whole concept of the delay phenomenon that he developed. So when we are looking at autologous breast reconstruction, from nothing, we now have all of this. We can take tissues from the back, the belly, the buttock, the thigh, and as well as this, we can add autologous fat transfer. So there's a lot to cover here. So let's go. So starting with the back, the Latissimus Dorsi flap, which in most cases is done with an implant, but we're going to really focus on just autologous, and also the extended Latissimus Dorsi flap. Clearly, Tanzini was way ahead of his time with two papers that he presented, you know, in the last 2 centuries ago. But it was really, the timing was not right. Halstead really put a stop to all of this, really disencouraged any form of reconstruction. So this was lost. And it was really Neven Olivari that rediscovered this and renamed this the Latissimus Dorsi myocutaneous flap in his BAPS presentation in '75, and then later in his publication in the British Journal. Many other people then contributed to this and developed this, and it's a very popular, and still remains a very popular method of reconstruction. When there have been lots of modifications of this. The original method in the high classification was very simplistic. As we know, when we dissect this, there are a lot of perforators coming through for the intercostal, so it's much, much more robust a circulation than was initially described. The skin islands can be oriented in different configurations over the muscle, obliquely, but in line with the muscle, or transverse to the muscle, or more transversely according to placement along the bra line. You can see that these different techniques will give you different results with respect to where the edge of the muscle will end up. So the oblique islands that are vertical transverse to the muscle, sometimes they don't give you enough superior fill. And so back in the day, we used the pectoralis major muscle turn up to give you this. The transverse skin island gives you a little bit more muscle superiority, so you really don't need the Latissimus Dorsi flap. And obviously the scars are where the incisions are made. So a very small breasted patient can have an autogenous reconstruction with nipple reconstruction, end up with a very satisfactory result. Back in the day, then the bigger reconstructions that needed a superior fill, this is before we did fat grafting, I would turn up the pectoralis major muscle, and that actually was successful in filling the superior pole. We've heard a lot this morning already about fat grafting, and Coleman was the one that really introduced this, and then many others sort of proved its safety. And obviously, we can't have time to go into all of these things at this stage. And most of the fat grafting is done secondarily, but as we've seen by Dr. Santanelli's presentation, the felt flap and immediate fat grafting is also performed. With the extended Latissimus Dorsi flap, basically you're taking extra fat in the subscalpal plane, so you can actually carry a lot more tissue with you, and many people have contributed to this. And even the morbidly obese, the extra roll of fat that they have laterally can be transferred to do a very safe reconstruction. And these are a couple of examples of a morbidly obese patient and also a patient with failed implants. This patient had Hodgkin. She was a radiator. She was not interested in implants. So she had a very extended latissimus with 2 rounds of fat grafting to achieve this end result. I've also utilized folded latissimus flaps where you have a large donor site that needs additional skin, and by folding the flap, you can get a nice shape to the breast. The thoracodorsal DTAP flap, initially introduced by Andrew Jani, but Mustafa Hamdi really popularized this, and we've heard some presentations of variations of this morning. I've only used this not for total breast reconstruction, but as an adjunct. And then the abdominal flaps. We have the pedicle and we have the free flaps. Interestingly, it was a free flap that was first described by Holstrom for breast reconstruction, which is unusual that should come first. But then Robbins in the same year also introduced the VRAM flap, and this is one of my cases when I first started in practice as a VRAM flap for breast reconstruction. But then it was really Karl Hartramp that popularized the transverse skin island, and interestingly, Tramp is in his name. With the various zones that were initially listed, but as we found out that this was not totally correct, zone 3 has a better perfusion than zone 2. And then many other people contributed to this, and this is just some examples of a unilateral, bilateral tram, and also the donor site that can be achieved in these cases. The free flaps, as we said, was firstly done by Holstrom, but many others then did the free musculocutaneous flaps, and these are just some examples of free musculocutaneous flaps in patients. The deep flap introduced, and first with the introduction of the perforated flaps, goes back to Kashima. Even though he wasn't really a breast surgeon, he really set the stage for this. And the deep flap has become the mainstay. And Bob Allen in the US and Phil Blondil in Europe, I think, have been the major contributors, although many people have contributed to this. These are just some examples of a left deep flap and a bilateral deep flap, which is familiar to all of you. The perforated flaps in breast reconstruction, there's deep, the gaps, we've already covered some of these, but the other one is the SIEA flap, which was initially done by Grotting, but then Zoran Arnej really popularized this some time ago, and this really does not impact the fascia at all. With the gluteal flaps, interestingly, Fugino did this first, and this was before the Latissimus Dorsi even, so historically it's amazing. Doing free flap breast reconstruction way ahead of his time. And then Bill Shaw with his musculocutaneous flaps contributed greatly. But then Bob Allen, I think, is the person that really developed the perforator component of this. And this is just an example of a superior gluteal flap and an inferior gluteal flap from my practice. I haven't really used the thigh as a donor site very much. And again, this was initially introduced by Youssef, indicating the blood supply transversely is better. But then Arnej, Allen, and others contributed to this significantly. And Phil Blondil did most of the contribution from the lumbar point of view. Looking at the autogenous breast reconstruction in the USA, we can see this 10-year period. We see the way the graphs are going. Initially, the tram flap was more popular than the deep, and now they're going in different directions, and the latissimus is about the same. In my practice, I've still continued to, the day I retired, to do pedicle tram flaps, although I also did free trams, and picking the right type of flap for the right type of patient. And the only contraindication was really a pot belly or a severe chronic back pain. But even thin patients, the muscle can actually be utilized for bulk in these patients to give you a satisfactory outcome. It's very versatile. You can use the unipedicle, bipedicle, delay, supercharge, or you can go free or deep. So everything is possible. To augment the vascularity, you can make it bipedicle, mid-abdominal tram, delay, supercharge this. And just a couple of examples of flap with 2 pedicles and 2 flaps on a single pedicle. So when you have a large skin island that needs to be reconstructed, such as this patient with a sarcoma, a bipedicle flap which can be turned and contoured to this can give you a very satisfactory outcome. And this patient had a double stack flap to give additional projection. And, you know, obviously there are risky patients, and these often have a delay, such as this patient had a delay, and so forth. So really the donor side is the real big problem. And of all the reconstructive surgery we do, we have to rob Peter to pay Paul. But of all the donor sites that we use, it's only the abdominal site, specifically when it's used for breast reconstruction, that's most scrutinized and controversial. And, you know, a normal rectus muscle only exists if the muscle is intact and innervated. A partial excision, such as a free tram, muscle peritram, or a traumatized muscle, whether it's denervated, no longer functions as a muscle. So whether you take a little bit or a lot of it, I think the muscle is really not going to function as a rectus muscle. And the reason why you can get a satisfactory outcome, even with pedicle trams, if it's done properly, is that if you look at the anatomy here, the orientation of the external oblique and the rectus, the vectors of the external oblique match the vertical vector matches the rectus muscle. So in all my cases, I always use an inlay Perlin mesh, and I end up advancing the cojoint tendons on top of the mesh to restore the natural tension of the muscle. And this gives you a satisfactory repair as seen in this patient. There's many comparative data between the pedicle tram and the free tram, and the free tram and the deep flam. Very few with the pedicle tram versus the deep itself. And I don't have time to go into all of these, but there are many papers looking at the abdominal hernia and bulge rate, comparing these various methodologies. So the future, I think, is going to be continued incremental improvement in flap combinations and refinements of current techniques. Transplantation, unlikely. Bob Allen's actually transferred a deep flap from one identical twin to another. Tissue engineered breast reconstruction, the last thing I want to cover. And, you know, although there seemed to be a lot of promise a long time ago about this, it's been very slow progress, and because the problem is the blood supply. So basically you need fat grafts, you need a scaffold, and you need a blood supply and neovascularization. And Roger Curry has done the most work with this, and that he's used his external expansion device, the Eve, using the Brava, where he can expand the skin and the subcutaneous tissue. Together with this expansion, he creates a vascular scaffold onto which the fat grafting can take. And this is just, I've visited him, and he's got some very impressive results of just utilizing this technique, but it's really the regeneration of tissue and the vascular base. And this is a patient that came to me some years ago, 50-year-old, very, very thin, and she had bilateral mastectomies and a tissue expander, and she was interested in this Brava. I didn't do it, so I referred her to some colleagues, Dr. Zostin Del Vecchio. Then she came to see me 10 years later when I was in Tampa, Florida, and I couldn't believe the result. She had had 2 rounds of Brava, and she now came in asking for a breast reduction and removal of the implants. But you can see she's obviously put on some weight, but I was just amazed when I went in there to see that there was a very thick, well-vascularized, soft, 5 to 6 centimeters worth of fatty tissue that had come from nowhere because she didn't have it originally. And it was possible to do this. And finally, another way, I've done a lot of research on flap prefabrication. This is a good way perhaps of introducing a vascular pedicle into this. And my main mentor, Wayne Morrison, and his team have been working with this engineered constructs in these little wound chambers where they added matrix stem cells and a vascular supply. This is the last slide. And they also duplicated this in rabbits where they developed breasts by putting in a wound chamber with a vascular supply and got nice little perky breast. And so a chamber with gel, vascular pedicle, and fat grafting can achieve this. At the moment, the gel is not FDA approved, and they haven't done this in the human situation. I'm sorry I took so long, but it was a lot to cover. Thank you.
So, do you have fast questions? Some questions, but fast questions. Okay.
I have a very fast question. It's really fast question.
Thank you very much, Julian. for your presentation. Excellent and to come here. But why do you call me Santanelli? That's my question.
That's your name.
Okay, thank you very much.
Okay, thank you very much. Now you have the coffee break.
We will be back at 10:45.
we start quickly? No, we have to start. Okay. They're asking us to start. So good morning again, everyone. My name is Luca Grimaldi, and I'm the secretary of the Italian Society of Plastic Surgery. And I'm honored to be here. I want to thank Fabio Santanelli and Mark Clemens for this nice organization of this fantastic conference. So we quickly start the second session, and the argument is to mastering the breast reduction and elevating mastopexy. So a very important aspect for the contralateral breast also. And let's start with Albert Losken. Thank you. Who will talk about striking a balance, achieving efficacy and elegance in oncologic breast reductions.
All right, thank you, and thank you to Mark and Fabio for the invitation. So I'm going to talk about oncoplastic in 11 minutes. These are my disclosures and not going to impact the talk. So we all know the oncoplastic concept. I think this is like a palatal cleanser for a meeting like this. Everyone loves doing breast reductions. When you combine the principles of oncology and plastic surgery, you get superior results. And it's one of those things where everyone benefits. The patient benefits, the surgeon benefits, and the breast surgeon benefits as well. And so whatever model you use, I think it's really important to get a team and have a process in place. And trying to convince the involved parties on efficacy or on elegance is really easy when you understand the benefits of this technique. But find a process that works, and a lot of it comes down to patient education. Lay out the options, lay out the expectations. They're so important in anything you do, but also in oncoplastic. And detail the various steps to the procedure, not just the surgery. Talk with them about the outcomes and the process, because if your patient is happy with the process, it really enhances patient satisfaction. And at the end of the day, patient satisfaction is one of the most important parts of what we do. So I'm going to start with the patient, and often end with the patient, but for this, I'm going to start with it. And there shouldn't be a question mark there. The patients tend to do better when you do oncoplastic compared to a lumpectomy by itself, but even compared to skin-sparing mastectomy and immediate reconstruction. They get to preserve their breasts with improved shape preservation. They get, I think, a better cancer operation. They improve their symptoms of macromastia. A lot of these patients with larger breasts often say they've always wanted smaller breasts, and so they think of this as a silver lining in the management of their breast cancer. And so a lot of defects like this, whether you're small-breasted or large-breasted, you're not seeing as much when you're reconstructing the deformity prior to radiation therapy. And this is what we're trying to avoid with this approach. And so you can see long-term results, and we're starting to see more 5-10-year results at 1 year, 2 years, and then 5 years. And another patient demonstrating the elegance of this procedure at 1 month, 1 year, and 5 years. And so that's a patient who had her breast cancer treated, but also ended up with a 5-year result that's natural and sensate. So what about efficacy? Are we achieving efficacy in these patients? And really, there's no better way to look at it than patient-reported outcomes. And patients who have undergone the oncoplastic approach from a psychosocial perspective are so much better off compared to BCT alone. There have been various papers now using the breast Q. This one was from Tufts, where they looked at the various stages, and you can see patient satisfaction, psychosocial well-being, sexual well-being, all of those significantly better in the oncoplastic compared to the lumpectomy by itself. And we've also looked at it over a year. Women report increased self-confidence, feeling more attractive, emotional health, and improvements in their satisfaction with sex life. So this is a situation where you're not only treating their breast cancer, you're actually improving their quality of life. And so I think it's one of those rare opportunities we have in breast reconstruction where we're not at best maintaining, we're actually improving. And a lot of that's because of the combination of the reduction, likely in part because of breast preservation, shape preservation, and obviously the reduction as well. But when you compare it to skin-sparing mastectomy and immediate reconstruction, the complication rate's significantly less. And I think this, I always put this slide like we like less complications, but really it's a patient benefit. They like less complications as well. And they also have less surgeries. The re-excision rate's much less, mastectomy rates less, and reoperation rates less compared to breast conservation therapy by itself. So certain patients, usually the larger breasted ones, have lower complications, less surgery when compared to BCT alone and immediate reconstruction as well. Have a team, whether it's a single surgeon model or a dual surgeon, which is the way we do it in the US most of the time, and have a good working relationship with the breast surgeon. They like it because they get to resect generously, fewer positive margins, it broadens the indications, and you don't have to worry about the way it looks. So what I mean by broadens the indications. So this is a nice study which showed the quality of life and how it affected the aesthetic result. And there are certain areas in the breast that are very cosmetically sensitive. You can't take very much before it starts affecting the quality of life. And the upper pole is one of those areas. It's very much kind of that's a large defect. This is not someone who you could have just done a lumpectomy by itself. We did an inferior pedicle reduction. It's a quick one procedure, one and done, and there she is post-operatively. Another central defect, often contraindicated in breast conservation therapy. You can see the nipples essentially sitting right on that chest wall. That's not someone who you can just do a lumpectomy by itself. We ended up doing an inferior pedicle. We deepthelialized the entire lower pole and just rotated that skin around, similar to the massive weight loss spiral flaps, and placed a nipple on top of it. And so that was the result we got. Unfortunately, she had positive margins, so I ended up with the latissimus flap, demonstrating that you really haven't burnt any bridges using this approach. So the more generous resection is kind of a no-brainer. We all know that the breast surgeon, especially with a large-breasted patient, can resect a large volume. You can even take skin, and this is a breast surgeon's dream. They love that. Every paper you see on oncoplastic always shows the lumpectomy specimen is so much greater compared to breast conservation therapy by itself. And why is that important? Because the re-excision rate is much less for positive margins compared to lumpectomy alone. And then breast surgeons also like it because this was a patient that she said, well, I really wish I could take more skin because it was close. So I said, go ahead and take it. And then when I'm marking my breast reduction, I just remember where that was resected and I leave that lowest skin. So we do a superior medial pedicle and I left that lowest skin. And then when we're closing it, it's just a little bit of, oncoplastic gymnastics, but we're just, where that skin was removed, I'm using it to reconstruct where that low pole defect. And you have a secondary independent flap, which is great. And so that's this patient a couple months after radiation therapy. So what about from the plastic surgery's perspective? It's important that we're involved and have an understanding of this approach. The number of procedures is much less. Most of the time it's one procedure. If you're doing a mastectomy, it's on average 3 or 4 trips to the OR. It's easier to do. We all know how to do breast reductions. There's very little downside, and the upsides are significantly more. What we think about is simple. Just preserve that nipple when we come in, figure out how to fill that defect, and then reshape the breast mound. And so now it's a very accepted approach with the many advantages that I've discussed. So what about from a cancer standpoint? We all know that if you inadequately resect, increases your recurrence. What about if you excessively resect? Is that better for local therapy? And most of the studies now looking at local recurrence at longer term follow-up show that they're pretty much the same. So there's equivalent local recurrence. But if you looked at the oncoplastic group, they're much higher risk patients. So I think that's important take home. Obviously recurrence is real. This was a large resection. The take home for me is equivalent when it comes to recurrent. In the context of multimodal therapy, it does allow breast conservation in much higher risk patients, which in and of itself is a benefit. All right, what about achieving elegance? I spoke a little bit about auto-augmentation. I like the auto-augmentation technique, extending the primary pedicle or using a secondary pedicle. So if you have a patient like this with the upper outer quadrant defect, a much smaller breast than some of the usual ones, we go ahead and deepthelize a superior medial pedicle and extend it all the way down to the chest wall. We create the pillars just like we do for a cosmetic mastopexy. And then there's your flap. It's still attached to the chest wall. It's got a good blood supply. I'm using that extended pedicle to fill that upper outer quadrant defect and really resecting no more tissue. So you can get an early result like that in an otherwise somewhat difficult patient. And the complication rate for these patients are not higher at all. Reoperation still does exist, though, in maybe 20% of the case, and the most common reason is if you take out margin, everything is aesthetics, which is the primary driver in the first place. But things to think about when you're wanting to minimize recurrence is overcorrect the contralateral side. So make the opposite side smaller because the ipsilateral side is going to shrink because of the radiation. So shrink the defect into a smaller breast to preserve the shape, overcorrect the opposite breast to preserve the symmetry, and I think that's important. And then finally, when you talk about striking a balance, we don't want anything we do from a reconstructive standpoint to interfere with appropriate cancer management and surveillance. That's obviously very important. And now we're looking at that a lot more. People have shown that using the oncoplastic approach, it doesn't delay the delivery of adjuvant chemotherapy, 29 days for both groups. The same thing with radiation. We don't want to delay radiation therapy, although if you do have complications, your potential time to radiation does go up, so you need to minimize complications as well. This is things that you can see on mammogram following a breast reduction. They could mask recurrence or be misinterpreted as malignancy, so I think it's important that you communicate with your radiologist. And this was a paper from this year where they looked at oncoplastic and breast reductions and just the importance of communicating with your radiologist so that they know what to expect. And wow, that got louder. And the same thing with radiation oncologists as well. It doesn't impact the ability to provide radiation therapy. So take-home messages, this is obviously effective. It's elegant as well when it's done right with limited downsides. And we really owe it to our patients to refine your training, your team, and your technique, and demonstrate efficacy and safety for these patients. Thank you.
Bert, fantastic results. If you could just for a second talk about your management of the ablation site. Our breast surgeons come in, push a bunch of clips, and it feels like we've done a disservice if those clips end up all over the breast. Alternatively, if we're taking out several hundred grams, that ablation site may end up in your specimen, and then how do you manage what's left over?
Yeah, so, and I've been talking with your institution about trying to figure out how to mark, because appropriately marking and sending to pathology is important. There are a couple of ways we do it. Some people use the Biosorb, which is a small cavity clip that you put in there and just you close that cavity by itself and then do everything else. If I am going to resect more, it's important that if I take out the margin, the cavity, that I mark that as a new margin, because occasionally the initial margin was positive and then yours could be negative, and minimize the re-excision. If we have to go back for positive margins, I go back with the breast surgeon because you were the last one in there. And then that last paper I showed actually showed when you're radiating patients, it's much more helpful for them to have clips in the cavity so that they know where to go, because the whole initial concern was that we're manipulating that tissue and rearranging it, and so they don't really know where to kind of radiate. But with clipping the cavity, I think it makes a big difference.
Thank you.
Ben.
Hey, Bert.
Ed.
Hey, Bert. Thank you for a great talk. And as I was telling you last night, I think your work on oncoplastic surgery should be required reading for residents. My question is, for oncoplastic surgery to work well, it seems like you have to have a relatively low positive margin rate at your institution to avoid that situation you were just talking about. So is there a certain rate that you would consider to be acceptable for people who are considering doing this in the immediate setting?
Yeah, I mean, the initial concern was always positive margins. And so the oncoplastic training wheels are just to do the delayed immediate, or you just get your margins back and then do your reduction before radiation, which I think gives you a better result. But all the studies have shown that with oncoplastic, your positive margin rate actually goes down. It's not going to be zero. But, you know, if you, you know, Steve, I don't know, Steve can probably comment on this, but, you know, if you're always going to have a, you know, a positive margin rate, whether you do a lumpectomy alone or oncoplastic. So it is a potential risk, but I think one of the advantages of this and the selling point is the fact that it lowers that risk. So I don't have a number to give you, but I think it improves the risk. Steve?
So in the Nottingham series, which is now thousands of patients, so our incomplete margin rate on local flaps is around 5.5%. In mammoplasties, it's slightly higher at about 8 to 9%. But your total conversion to mastectomy is still only 2 to 3%. So you can still re-excise most of them. The really other important figure is that if you look at breast conservation with DCIS, standard DCIS, you'll have an incomplete margin rate of 30, 35% in most international data sets. Oncoplastic takes that back down to about 11 to 12% for widespread DCIS. So it makes a massive difference to margin analysis. You will, at the end of the day, do mastectomies on average in about 3 to 4% of patients overall.
Yeah, and the discussion on DCIS, it's the one area that maybe having a more generous resection actually could help you when it comes to recurrence and also when it comes to not radiating.
Thank you very much.
Thank you.
The next speaker, Professor Portincasa, septal perforation-based approach to large breast reduction. Is that safe?
So I would like to thank Professor Santanelli and for this kind invitation. I'll try to stay in a lot of time, Fabio, so don't be aware. 11 minutes, that is work, like this. Okay, so I have no conflict of interest to show related to this presentation, and we will go through 4 steps. It's kind of magic. We will consider complication of breast reduction, risk factors and prevention of complication, problems of nipple area complex, skin necrosis and adipose tissue, sensitive deficits of nipple area complex, choice of technique, the infracentral based pedicles on the septum and the medial pedicle based on the septum, in conclusion, and some messages to take home. So what does it mean, safety? Safety means what we hope, not having complications. So the main complication, if you go through to literature in breast reduction, you can have, does it work, the pointer? Yes. You can, okay, not so good, okay. You can have acute complication, subacute complication, long-term complication. We hope not to face this, but if you go to the higher rate of complication, you will see that the most encountered complication is delayed wound healing. Okay, risk factors and prevention of complication. Problems of nipple area complex. If you go to the literature and you consider the risk factors, preoperative risk factor, you have to consider body mass index, which is the main, which is here. Okay, body mass index. And you can have also smoking and radiation therapy when you have secondary procedure. How to prevent these risk factors? Pedicle length. So if you increase the distance, you have an increasing of problems. If you transpose and increase the nipple distance more than 10, 11 centimeter or up to, we can say, 18 centimeter, you can have more problems. And if you resect more than 2,000 grams. To prevent this, you have to ensure a pedicle adequate thickness and vascularity. That's the reason why we choose always the septum. The ratio between length and width of the pedicle. Avoid excessive rotation on the folding of the pedicle. Avoid closing under tension. And the truly ischemic neck should always be converted in the full thickness graft. If you go also in our problem that we have faced, we published a paper, a couple of papers, how to save the nipple area complex and how to go through these complications, both in cosmetic, reconstructing, and oncological cases. It doesn't work. Okay. Okay. So the other complication that we will face is skin adipose tissue necrosis. So refrain from smoking, withdrawal from steroid therapy, control diabetes and connective tissue disease, avoid excessive wound tension, and adapt the pedicle with precision. Okay. And as Fabio has shown in his report 2020, septum-based mammoplasty gives always optimal results in terms of knee-parallel complex viability with significant improvement of sensibility, post-operativity, and comparative outcomes on sensibility were also significantly better than not septum-based techniques. So also from the which is not secondary, from the point of view of the sensibility of the knee-parallel complex, this is a good option. Okay, step 3, choice of techniques. I will show you which techniques we've been choosing in the last years. And in our experience, our technique, the septum-enhanced mammoplasty in inferocentral pedicle breast reduction for macromastia and gigantomastia patients, which is a really difficult cases, should be easy in our hands, or we should say in your hands, safe, both for neck, skin, but also for the parenchyma, preserve symmetry, projection, feeding time to consider, sensitivity and sexual function, and ensure, if possible, stable results. So we've shown that comparing to other techniques, we have a significant difference. I don't know why it went no. A significant difference. Okay, significant difference if you take the septum or not. I hope it works. So when you consider in the operative theater, you have always saved all your perforators, the medial, the lateral, the superior perforators on the flaps when you redrape the gland, and you consider autoprosthesis concept, and you will see, you can see also the perforators inside the septum here, laterally, superiorly, and medially. Okay, I hope it works. I'll show you a quick. This is the inferocentral pedicle based on the septal perforator enhanced technique. You sketch the pedicle. Okay, you resect all the amount. First, we used to cut the to have the pedicle. You don't need to see the septum. If you see the septum, it's too late. You have already severed your perforators. Then you redrape the gland over the autoprosthesis technique. So, going on details, you have the pedicle here, you have the septum down here. You don't see the septum, you know the perforators down here. Then you have the lateral perforators on the lateral flap, the superior perforators, and the medial perforators. So, the central mount pedicle septum enhanced is an autoprosthesis technique. The surrounding flap thickness must be kept to 2 to 3 centimeters, so you can enhance the, especially the venous vascular supply and the maximal preservation of vascular and nerve supply. These are some cases in the superior part, the pre-operative and the post-operative. These are all long-term results, more than 3 years, up and down, pre-operative and post-operative, and pre-operative and post-operative. This is 5 years long-term result. What about the supramedia pedicle? Even in this case, you can enhance your vascularity. You don't need to see the pedicle. You know the septum is down there. The vascular supply cross the right at the septum. So you sketch the breast when you do this. Okay, you fix the nipple, alveolar complex, 2 centimeters. Straight on, 5 centimeters, the vertical branch, and you sketch the supramedia pedicle. So, first you cut the pedicle. even in this case, you don't need to see the septum. The septum is down there. And you don't need to see the fascia of the pectoralis muscle. This is the septum. And you can rotate easily. It's not a long pedicle, but up to 20 centimeters, you can sketch your supermedial pedicle. You close the gland superiorly without any tension. We use, in this case, the fibrin glue. And this is the immediate result. So, preoperative and postoperative, and preoperative and postoperative. So, step 4, conclusion, and let's take home some messages. Septa perforated is basically the approach to large breast reduction that is safe, in our opinion. The technique you can tear on the patient is reliable if you resect properly the gland, if you leave enough tissue, if you leave enough vascularity, if you close without any tension, which is the most important issue, and if you redrape properly the gland according to preoperative sketch. You get low incidence of complication, and you have seen long-term and stable result. And you can get good satisfaction patient and surgeon. And in this technique, if you train and you try to do it, you will be the king, and it's kind of magic again. Thank you very much for your attention.
Any question from the audience, please? How often do you perform additional liposuction on the lateral pole?
In this case, it's not so often. We use much more in reconstructive cases. But in these cases, very seldom. I should say 1 to 5 to 2%, not more.
Thank you.
Thank you very much. I don't question for 1 second the improved vascularity of the technique. Over the years, my approach in breast reduction is to leave a bit more than I used to medially and take a bit more than I used to laterally.
Yeah.
Because actually, we often tend to leave too much bulk laterally.
Yeah.
How do you marry that up? Because truly leaving all this lateral vascularity leaves bulk. And I think sometimes we limit our ability to get a good aesthetic reduction.
Yeah. Thank you for your comment, your question. When you raise or you leave the lateral flap, you can also thin a little bit more. You don't need to leave so much tissue. That's my experience in the years. I mean, yes, I say you don't need to see the vessels, but you know the vessels are down there. And if you don't touch the pectoralis fascia, you don't sever the perforating system, the lateral perforating system, because the lateral perforating system, it can come in mostly from the lateral perforator or intercostal vessels. So keep in my mind, I always keep in my mind, 2 centimeters, not more. This is enough. The other part of the flap sometimes is a fat tissue or glandular. You don't have so much glandular tissue in that area. You have fatty tissue, which is which doesn't apport you any contribution to the vascularity.
Maurice Nahabedian, I, again, greatly enjoyed your presentation. I guess the point I wanted to make is just, and this is something I've learned just from doing reductions, oncoplastic surgery, and deep flaps. You know, a 1.5 millimeter perforator can adequately perfuse about 750 grams of tissue, which is actually quite a bit of tissue. So when we're doing these types of reductions, you know, whether you're preserving the 5th intercostal, 4th intercostal Boehringer septum, or 3rd, or the internal mammary perforators, as long as you're aware of what the primary blood supply is going to be to that nipple-areolar complex, I think you'll be okay. Because I think these perforators will do actually quite a bit as long as they're not damaged. So I think it's all about the blood supply, and I appreciate you bringing it up. I just wanted to kind of make that point as well.
Thank you very much. If you keep in mind the vascular supplies, you're perfectly right. You are not scared of anything. I mean, you can adapt and adjust your technique according to to the vessels coming through the septum, which is the main concern. You can also, as Elizabeth Wuringer shows in the past, if you leave just the septum, you can take off the tissue over, behind, under. You can just leave the perforators. The only thing that you have not to touch are the not to do is don't look for the perforators. Don't look for the septum. You know it's there. You can touch. You can feel under your fingers. Is there? Okay. You don't need to see the vessel. The vessel are for safe there.
The last question,
Thank
please.
you for comment.
Yes, Van der Leyen, thank you. I enjoyed your presentation. My experience for years is that I never lose a nipple by arterial problems. It's always a venous problem.
Yeah.
So what I do when you are confronted with it, initially the nipple is very pale, and then later on it becomes bluish and you see the venous problem. I release the blood by just taking off a part of the nipple and let it bleed for 2 days. That's mostly enough to recirculate it. That's how I approach it. So I never convert in a free nipple graft. I always release the blood for 2-3 days, and that's enough.
Yes, you are true. Thank you. And the other option is negative pressure wound therapy. The way we publish our results, that gives you good possibility of the so-called leeches effect. If you make a small incision, you put some heparin inside. That goes with heparin for a couple of days. Your nipple area complex will be safe.
Thank you very much, Aurelio, for excellent presentation and all the answers. We should move to the next speaker, and next speaker is Denise Dayicioglu, and she will talk about mastering contralateral mastopexy at the time of nipple reconstruction.
Thank
Please.
you very much. My name is Denise Dayicioglu. I'm one of the professors in the University of South Florida. I've been also working at Moffitt Cancer Center for 14 years doing breast reconstructions. I'd like to thank Dr. Santanelli, Dr. Clemens for inviting me, and I'd like to also invite you to next year's Tampa meeting. Looking forward to that on the 10th breast workshop. I have no disclosures. I'll be talking about mostly autologous reconstruction. According to SPS statistics, mastopexy is about 10% of all cosmetic procedures, augmentation 20% of all cosmetic procedures, and abdominoplasty is 10% of all cosmetic procedures. In our world of reconstruction, we are also trying to treat the same concerns when we're doing a reconstruction on a patient to improve the symmetry, existing looks by giving them a lifted look and an augmented or reduced change. Also, the goals of deep or muscle-sparing free tram is to have an elevated breast and a flatter abdomen. The mastopexy planning starts in the mastectomy. Actually, the mastopexy effects in the mastectomy planning, where you're doing a vertical design and closing the skin island vertically, and then creating a mastopexy effect during your autologous reconstruction. You're trying to elevate the nipple, and that should be considered in the planning phase during the mastectomy. Also, the abdomen is closed, like presented by Dr. Nahabedian and other speakers, by plication and improving the abdomen in your reconstruction. When you're doing an immediate breast reconstruction with a mastectomy and autologous direct reconstruction, you're elevating the breast, so nipple to a higher location, and you're closing vertically, improving the abdominal look. This can be combined with 3D tattooing or nipple reconstruction, where you can control the nipple location to a higher position. The nipple elevation is an integral part of the planning in a mastectomy, and that's where your mastopexy effect kind of starts. Also, the abdominal plication doesn't increase the complications. We were able to publish this and further saw it in patients that came later after this publication. At the time of planning, you can improve the asymmetries, and then you can leave some loose skin of the skin envelope and then trim it later during the inset of the flap, keeping the perfusion. But over the years, if you look at your deep flaps, they also tend to descend, like your autologous or like your original mastopexy tissue or your original breast tissue. So you have to consider a different technique, or where you can lift your autologous flap with a flap mastopexy. And this is basically a simple removal of a vertical wedge, where you can elevate your deeps or autologous breast reconstruction by taking a wedge of skin from the middle of the breast, and also using that excess redundant skin to use as a nipple reconstruction. So these are some patients that had this procedure. We were able to also publish this as a flap mastopexy, where you can elevate the existing autologous flap reconstruction. And you simply use the excess redundancy. This is just simple markings for just like a mastopexy design, where you're actually lifting your reconstructed deep flap while preserving the vascularity. Our inset is usually contralateral 90 degree. We know where the pedicle lies. And then this way you can preserve the circulation of the breast. And then with the excess redundant skin on the skin pedal, if you have a good location, you can use it for nipple reconstruction, basically like a bell-shaped flap, and then basically tailoring it to a nipple location while you're lifting your breast and creating a nipple reconstruction. Again, the concepts are nipple elevation and then a flatter stomach, where you can control these things in your secondary procedures where you're doing the nipple reconstruction. You can adjust the breast by just simply lifting the autologous deep flap without jeopardizing the blood flow, simply by wedge excising the central vertical component and then creating our nipple reconstruction. We usually use skate flap skin graft technique, and then usually take the skin graft from sometimes the contralateral breast if there is one. But again, the concept is to elevate the breast. I had a chance to observe this patient for 10 years. This is her 10-year result after the first picture for a bilateral bilateral deep flap reconstruction. You can see the descent. And just like a normal breast, we were able to elevate even her reconstructed nipple to a higher location by keeping it still attached with a superior sort of pedicle, by elevating the breast with a flap mastopexy as a vertical direct excision. So for nipple reconstruction, it can also be combined with some other adjustments of your deep flap, where you can do a breast augmentation at the same time, where you can improve the projection and then also control the abdominal plication or abdominal looks with the abdominal plication technique. So some other examples with the breast augmentation after deep flaps, where you can augment your deeps at the time of nipple reconstruction. So these secondary procedures allow us to improve your results. So should you do it simultaneously when you're doing a unilateral, or should you do it delayed? We usually do it delayed, but there's different resources that state different things. Basically, the revision rate is a bit higher when you do it immediately, and then it takes time during your longer operation. And then some studies say that the complication rates are a bit higher when you do it at the same time. But you can, if you're going to do it at the same time simultaneously, you should do the lift first and then adjust your reconstructed breast to the lifted size according to the literature. Basically, when you're doing the unilateral reconstruction, the planning starts again at the mastectomy phase, where you have a vertical design, and then you're trying to match your mastopexy to your mastectomy site. At the same time, you're trying to match your nipples, and then you can augment the other side at the same time. Again, secondary procedures can be done at the nipple reconstruction phase. Usually we use skate flap skin graft technique. We sometimes take skin graft from the other contralateral areola to match the color. When it's the delayed reconstruction, that's where the challenge lies. And as you see, like getting the symmetry, considering the future changes of the deep flap and considering the future changes of the mastopexy site, should all be considered. And then you're going to see the descent on your mastopexy side, not so much on your deep side. So you can potentially put the nipple on the deep side slightly lower, assuming for the future ptosis. Otherwise, you can see that the nipple can be laying a little bit higher on the deep side or on the autologous reconstructed side. Or you can just do it in stages. You can just do the contralateral mastopexy first, and then do the nipple reconstruction at a later stage where you can have a better match, perhaps. Or also you can adjust with your tattooing techniques to get a better symmetry of the nipples. This is a massive weight loss patient where we have also more descent, and that should also be considered in those patients as well. some other examples of the same unilateral breast reconstruction with the nipple reconstruction. But the mastopexy effect can be also achieved with control of the skin redundancy at the time of nipple-sparing mastectomy. I'd like to talk about a short topic about how to improve it. I feel like this is a useful adjunct to patients where you have a redundant skin and you can control it with external taping. This was published by us, years ago. We called it, no conflict of interest, but this was a useful technique by using a hydrocolloid dressing, where you can improve the ptosis slightly with some elevation of the nipples during the first 2 weeks, where you have redundancy of the skin and where you can drape the skin up at a higher location. And then this was like a 5-year follow-up where some fat grafting was done. Again, for the immediate direct to implants with pre-pec, this was also useful to position the nipples in a good position where we had good flaps to start with. Also to improve the nipple migration during the expansion in a submuscular expander. You can improve your nipple positioning with external taping when necessary. So again, remember to come to Tampa next year. It's going to be the 10th workshop. And then these are my kids, my little helpers, and then my residents and my coworkers also help out a lot. This is my email. Thank you so much.
Thank you very much, Denise, for excellent presentation. Any question or comments from the audience?
You can go.
Okay, then we can continue.
So, next speaker is Valerio Cervelli. Thank you. Lifting a new autologous post-implant mastopexy-reduction. Thank you.
Thank you very much, Fabio. And thank you, Dr. Clemens, for organizing this meeting that is a milestone in breast surgery. And doesn't go. Ah, okay. Okay. Going on with the time, we have a lot of this kind of result due to the fact that we are now positioning prosthesis since 40 years. And so that after a long time, what happened that there's a wide diffusion of breast implant made such patient quite common in everyday practice, due to the fact that we are positioning implants since 40 years for aesthetic results. So that what we have to do, we have to do a tire change. Often an implant change could solve the problem, obviously, but sometimes patients want to get rid permanently of their impairment implant. They regret their choice, so they don't want more to have breast implant. And even we have an increase of percentage of people that want breast implant removal since the last 5 years. This happen all over the world, but more in some place than in others, as you can see. The main reason for patients give up on implant is capsular contracture, pain, implant rupture, fear of future implant complication, as for example BIA-ALCL, and tomorrow we will discuss a lot about this in the consensus conference of BIA-ALCL. So that downsizing could be a delicate issue to deal with, and which one is the solution? How can we replace the missing volume? Obviously, with fat grafting is a pivotal technique in both reconstructive surgery of the breast and gives excellent result with low cost, with an efficacy due also to the stromal vascular fraction. But sometimes there is not a predictable graft survival, and we need more than one procedure to have quite good quality of result. So that the fat grafting helps in filling the breast, even for adipogenesis effect, but also for vasculogenetic effect and pro-adipogenetic effect, so that we can use this also in case of post radiotherapy problem. And as you can see, as you know very well, and so that is a good chance. And our surgical approach is to volume remodeling and fat grafting. With a wise pattern design, obtaining a purified fat with we use to take the graft from the lateral part from the culotte de cheval, even because we have a large amount of fat disposable, and also because we tend to avoid problem on the abdominal wall, because in the future can be helpful for oncological problems to replace the breast. And after having the fat in the Coleman way, that is the most used and is the largest amount of meta-analysis studies, we isolate the graft in little syringe of 1 millimeter, and we try to have a dermoglandular flap design. Even in case of obviously of pathological subglandular capsule, we do an en bloc capsulectomy, and sometimes we leave the thoracic part if it's very much attached to the thorax and in a submuscular way. And in case of healthy capsule, we decide to have preservation and biopsy of the capsule, obviously to stay safe. And then after we used to put in opposite way in the insertion of the fat in the two direction, to use this flap like an autologous dermoglandular flap and an autologous prosthesis to replace the volume of the prosthesis. And then after also fat grafting can be done in the following time to ensure a quite good quality of the result, that obviously the most of the case cannot be the one of the with the prosthesis, but sometimes we can reach a quite good quality of the result, obviously with more than one procedure to put fat to enhance the volume of the breast. But many issues are debate how to deal with the capsule. We see that there is an increase of remove both capsule and implant, going up the age of the surgeon. So the surgeon that used to do this work since a lot of time are more prone to do a complete capsulectomy and extraction of this prosthesis with an en-bloc capsulectomy, more obviously when the prosthesis is in the subglandular plane, and with the total capsulectomy. And we see that also when there is a major number of capsulectomy en bloc with prosthesis, for example, in private practice, than in academic practice, probably due to the major attention to the rules and to the result of the literature. The pro and con of capsule removal is a reduction of risk of retraction. We have a dead space closure and increased oncological safety, but we have a vascular impairment because the plane of the capsule is a good place to put fat, and there is a good vascularity, and this fat tends to have a good attachment. We have obviously a risk of reduced fat engraftment if we take off the capsule, and we have also an increased operative time and risk for complication. In our experience, we tend to be conservative, as I told before, with the capsulectomy in asymptomatic patient presenting thin and normal capsule, obviously with histologic thinning, but we are more aggressive, obviously, with capsulectomy in a patient presenting symptoms or dystrophic capsule. as I told before, we will discuss about this much more tomorrow during the workshop. And there is an oncological risk in fat grafting to the breast. The scientific literature says that most of the paper evaluate breast cancer patients, but a few prospective studies, many retrospective, and lately a few matched case control studies. So that even we have also 2 meta-analyses that have been published recently, and with the similar conclusion that there is no difference in local recurrence rate and disease-free survival. And a few data in patients without a history of breast cancer undergoing aesthetic fat grafting. The limitation of the surgical approach is that the volume reduction loss in cap size compared with the augmented breast, and we have an unpredictable graft take rate. The addition of another surgical site with a possible increased risk of complication, prolongation of the surgical time, and possibly quite frequent multiple procedure could be needed to reach a quite quality of result that is sometimes difficult to reach with a skinny patient. Implant removal mastopexy with auto-augmentation could be a satisfactory option in this quite selected patient, and the fat grafting could help to minimize the volume loss, but patient could benefit from additional reconstruction and have a fully autologous breast. The main drawbacks are the possible need for multiple procedure and the increased property time and cost. As I told before, very skinny patient could benefit from most increased flap thickness, but they are poor candidates for the lack of donor sites, obviously. Thank you very much for your attention.
Well, any question from the audience? No one by me. Which is the largest volume that you injected, and how? In 1 step, in 2 steps, many steps?
Even in more than 1 step, it depends obviously from the desire of the patient, and depends on also from what technique we use, we decide to use, because we can infiltrate. The main problem is the donor site, obviously. In patient, in non-skinny patient, obviously we have a major amount, and we have to purify this fat, and I think that the major quantity that I put is no more than 100, because, and I prefer not to put very much altogether, but to have multiple procedures to reach the result, and depends also from the desire of the patient that decide if it's sufficient or want more volume.
Thank you very much.
Do you use drainage, and how often do you have a problem with hematoma or seroma formation?
I use Penrose drainage in a case like this one, in the majority of the case, not a vacuum extraction of volume loss.
Okay.
Thank you very much.
I'm very glad to present you Paolo Persichetti to talk about tuberous breast.
Thank you, dear friends. Thank you to Professor Santanelli di Pompeo and Mark Clemens for the invitation and for the topic they gave me. This picture by Picasso shows us the problem of tuberous breast. And then we also know the ideal breast measures, and what it is difficult to understand what happened, but we can say that tuberous breast is an acquired malformation to do the normal development or normal breast. This was first described by Rees and Asto in 1976, and could be shown with very different patterns, all going to the tuberous breast, which is characterized by this topics. So the reduction of both vertical and horizontal diameters, alteration of areolar shape and size, moderate to severe hypoplasia of the skin and glandular tissue. So many classifications were proposed. This is one of them by Grolot, which is very useful in my opinion. And we also had the opportunity to give our contribution relating the severity of deformity with the asymmetry between the two breasts. So our principle were going to evolve with the time, and we have to achieve several different procedures during the operation. And we do that doing this kind of surgery. And basically, we have to correct the envelope and also the core in order to get a normal shape of breast. To correct the envelope, we have to lower the inflammatory fold, allow the expansion of the glandular tissue, release the adhesion, and reestablish the correct vertical and horizontal dimension of the breast and reduce the areolar diameter. On the contrary, to correct the core, what we have to do, we can do absolutely glandular remodeling, but also we can use implants. And also we can use autologous procedures, or many of the time combined techniques. So normally when we have a problem to correct, we are driven by several considerations: the degree of asymmetry and the degree of malformation, and also absolutely, of course, the patient expectations. So in case we have to correct mild to moderate asymmetry with any kind of deformity, we are driven by the body mass index. If we have a body mass index above 23, then we move to autologous. On the contrary, below 23, we go to implant-based. And this some examples, yes, you can see we have a very mild asymmetry with a severe deformity, and with implant we can have such very pleasant result, a pleasant outcome. The same here. It depends about the footprint of the breast, like in this case, where we was impossible to do with the same size of implant, which recommend very much by us, but we can put a different in volume just on the projection part of the implant. And so on, you can see here where we can do some maneuver utilizing the implant either in anatomical or round, either pre or post or retropectoral. But you can see here, then we have also sometimes the necessity to use a secondary or intraoperative lipofilling to touch up and to get more symmetrical outcome between the two breasts. In the case where we are obliged, or better, I prefer to use autologous correction, then we have to do several different maneuvers in order to get the tuberous breast to become a more natural position and shape. Here, for example, in this case, we had the unilateral tuberous breast where we used the reversal expansion in order to get more space, a better tissue to uptake the lipofilling. And also in this case, where the asymmetry was very mild and the correction was, the deformity was not so big, so we had the percutaneous tissue releasing and lipofilling. Like in this case, where we did glandular flaps and lipofilling, or even in more severe cases, the same glandular flaps and small reduction in the larger side to get better control of the symmetry. And also here, you see, we did this radial incision to open the base of the gland. We released the base of the gland, and we did the glandular flap to cover the inferior pole. And also in this case, where either are not tuberous but more tubular breast, we can get some satisfactory result doing the same. In this case, we did a sort of hybrid because in the beginning we used the permanent implant as implant with a different volume of the variable part, but then we decided to remove due to the rupture of the implant, and we went on with multiple steps lipofilling. And in this case, when we have a very severe asymmetry between the two sides, then we have the same critical point to take into account, the BMI, and then we go directly to autologous when the BMI is above 23. So some cases we did some hybrid where we put an implant bilaterally doing this kind of maneuver on the right side with the normal reduction mammoplasty. In this case, for example, we started with autologous due to BMI, but then we decided to put the implant due to the patient desire, which would like to have a better projected implant, a better projected breast, like in this case. Here you see with different technique, we are looking for having a more symmetrical breast with a normal shape. And this is the last case. As you can see, a very severe tubular breast on the right and tuberous breast on the left. And we did autologous correction doing lipofilling in order to get more symmetry, a strong reduction in the major part. So we can say that the complication in our experience were higher in implant-based group due to implant dislocation, animation, and sometimes double bubble deformity. Overall satisfaction in both group anyway was similar, and autologous correction should be proposed to young patients with body fat deposit and grade B and C of asymmetric volume with mild type of deformity. Implants are still the quickest method to fill the bra, but are better indicated in thin patients with severe malformation and the grade of asymmetry very low. So we can say that from the Picasso, we have to go back to Raffaello. We depicted this Fornarina that you can admire here in Rome. And as you can see there, the shadow on the left breast mimetized a previous tubular breast. Thank you so much for your attention.
So thank you very much for excellent presentation and excellent result. Do you know maybe what's the average age of your patient?
Average age, it's a very young patient normally. Yeah. We started when they are in the majority, normally at 18, but sometimes due to the severity of the malformation, we can start even earlier. Okay. And we decide to go to autologous whenever possible, but we also listen to the patient wishes, and sometimes we move directly to implants.
How often you need to make a redo after pregnancy and breastfeeding, especially when you use the implants?
Yeah, implants, if we can not using implant, is better for us. At the beginning, we use this called permanent expandable implant, which gave us the possibility to use the same diameter vertical and horizontally in order to get better symmetry with a different volume inside. But those kind of implants, unfortunately, after a while rupture, the rate of rupture was around 60%. So we try to do this with the permanent implant, and it's very difficult to assess a good symmetrization doing the same implant, either if you do removing in one side and putting fat in the other side. So after a pregnancy, many things can be modified, and we are more prone in these cases to use autologous reconstruction.
Thank you, Dr. Bersachetti. Really amazing results and very challenging cases. But I was struck by how young the patients were. Many almost look in their teenage years. Do you advocate early surgical intervention, or do you wait for full breast and glandular development? What's your timing wise based on their age? And were all of these one stage, or is there any times when you might do an implant or a tissue expander in a different stage from the areolar mastopexy type work?
Yes, normally we used to wait the mature age of the patient, unless they are so affected by the malformation in the puberal era. But in that case, quite seldom we go straight forward with the implant. We try to use implant in the mature phase of their life. And the second question you did there was about the. We normally would like to go with a one stage. We use implant expander in a reversal fashion nowadays in selected cases. In those cases, unilateral malformation where we need to get more volume despite the several sessions of lipofilling. But the outcome are very encouraging, and then we are going in that direction now.
Thank you. Any other question? No, okay.
Then we will finish this interesting session with the last speaker, Professor Parodi. Elevate your choice, selecting the implant in augmentation mastopexy. Please.
Thank you, Mark and Fabio, for the invitation and for organizing this fantastic meeting. We saw before that the breast augmentation and mastopexy is one of the most frequent operation in the United States and in Italy, but they are also an operation related to litigation with the patient and with some difficulties in obtaining a good result. Spears are saying that more or less 15% of the augmentation mastopexy in the primary situation are going to be reoperated. So the reason is very easy to understand, and it is very difficult to solve, because you don't need only to choose the prosthesis, but to consider all this kind of situation in your surgical planning, and you must be very confident to all the situation, all the techniques that can improve the quality of your result. So the choice of the prosthesis is only one part of the problem. And the algorithms are very useful, the techniques are beautiful, but there are 100 techniques of mastopexy published. That it means that there is no one technique for all seasons. And also the algorithm, for example, this beautiful example of Dr. Swanson is focusing the attention on one aspect that it is quite difficult to follow, that the algorithm, all kind of algorithms in any situation. And don't forget that the idea that you have of the good result is quite different. This lady had quite a reasonable result, but they complained about the shape of the breast, some light difference. You can see the type of the breast on the right side of the screen. It was an anatomical one. Or the different scars if you are planning 2 patterns of reduction. And it is a very dangerous situation, long-term follow-up, because you can have a change of the shape during type. And again, the position of the nipple is sometimes related to the position of the shoulders. So you have to explain to the lady which is the trouble, or irregularity of the shape of the nipple. All these conditions are very important to discuss pre-op with the patient in order to prepare and to treat, if it is necessary, in a secondary stage, the patient. So the information consents and the photography, all the clinical documentation is very important. More complex is the situation in secondary cases. In these patients, of course, you have the previous characteristics related to the gland, to the skin, and to the position of the nipple, but you have also the biological consequences of the prosthesis that has very important consequences to the fibrotic tissues, to the retraction, to the capsular formation, and so on. There are many points that you have to focus on. The first one, if you are treating secondary mastopexy augmentation, is to preserve the viability of the neck, especially if you are moving to the subpectoral plane. It is mandatory to maintain the vascularity of the perforator and to use small prosthesis, because huge prosthesis reduce the venous flow to the neck, to the areolar complex. And the choice of the pedicle is so important that you have to individualize your choice according to the situation that you are meeting, and also according to the report, because if you have the report of the previous operation, you can follow the same pedicle as in this case. Again, in some situation, it is necessary to move from subpect to prepect, or from prepect to subpect, according to the characteristics of the patient. But the choice of the implant, it is not based on evidence-based, but on the characteristic of the patient, and also the experience of the patient, of the surgeon. In my opinion, in secondary case, I prefer to use round implant, because the rotation is a problem in many situations, especially if you have to do a total capsulectomy or radical capsulotomy. Again, I don't want to discuss about the difference in between capsulectomy and capsulotomy. There are beautiful lectures tomorrow, but of course it is important that the incision in this situation is large in order not mortifying the skin margin, and there are many strategies to do that. For example, to use a bipedical flap in order to protect the situation. If you are doing a secondary operation, you must manage capsular formation, capsular flap, and in many situations to reinforce the inframammary fold, especially if there is a great difference. There are precapsular plane to cut the capsule, to cut the gland, in order to try to symmetrize a situation that sometimes is very difficult to solve, as in this case. And of course, probably it is the most difficult operation in aesthetic surgery, and you have to try some kind of symmetry in all the aspects of the breast. But as we saw before, is lipostructure a very important weapon that we can use in primary and secondary case in order to have to symmetrize it, to have a better shape of the breast. Don't forget the possibility to use it to do two-stage surgery in high-risk patients. But one of the topics of my lecture was how to choose the ideal breast prosthesis. There is no an ideal breast in my experience. The trouble is anatomical, round, texture, smooth. And my generation saw many crises about the prosthesis, and the choice is not related only to the topic that we discuss in this meeting, like ALCL or BII. it is related to other aspects if you are discussing just from the surgical point of view. And many of them are based on the experience of the surgeon and the personal choice, that it means that the literature data have an evidence-based medicine level that are 4 or 5. So there is something that is not very well defined. In my experience, I published in the last time a lot of paper on smooth implants, but it is not true. My experience is probably 80% in reconstructive surgery. In reconstructive surgery, I'm still using anatomical one. But in aesthetic, I moved many years ago to the smooth implant due to the type of the breast that I have in my practice. It is very difficult that I have patient with a request of prosthesis more than 300 cc. So in this situation, it's very difficult, especially if you are putting the prosthesis below the muscle, to distinguish the anatomical from the round shape, as in this case. But if you are using in aesthetic surgery or in mastopexy larger breast, it is necessary, in my opinion, to use anatomical one, because there are better definition of the inframammary fold, a more natural upper pole aspect. Of course, the lipostructure has changed also this topic, because you can transform a round implant with a lipostructure in something similar to the anatomical one. Why I prefer smooth implants? Because they are soft, they have less wrinkling, but especially there is no rotation, especially if the pocket is larger. And the better feeling is related also to the type of the gel that it is inside. But it is important to remember that if you are violating the inframammary fold, it is very easy in smooth and nanotexture implant to have a mobilization, inferior mobilization. So it is necessary to plan and to understand in the planning of the surgery this aspect. There is an increase in that it is more or less the 50-20% of the length of the vertical incision, but also to reinforce the inframammary fold in double layer with a strong sutures. Don't forget the necessity that if you have gland, you have to reduce the gland to accord to modify the shape as in order to reduce the bottoming down of the gland. This is very important in polyurethane implant. I mean, my experience is very small, but I don't want to discuss the pro and the cons of polyurethane. But look at this case. It was a case of reconstruction. She received radiotherapy on the right side. I put an implant in both sides, and I did many mistakes in the planning. So you can see the superior border of the prosthesis in both sides and the migration of the gland, because I didn't reduce the gland tissue. So I had to operate again to convert a polyurethane implant in anatomical one, but there is still a modification. In conclusion, we have to understand the biological consequences of the surface, and the paper of Fabio Santanelli is very important in understanding the soft implant, a smooth implant reduce the deformation and inflammation. In a new study, we are doing the same, but we are using all kinds of surfaces with or without the ADM and the ADM in order to understand which are the markers of the capsular formation. Thank you for your attention.
Any question from the audience?
Congratulations, nice presentation. But you talk about the mastopexy augmentation and implant selection, but you didn't tell, I didn't hear the words about one stage or two stages of the surgery, because there is always controversial. Some doctors prefer one stage, someone would prefer the two stage. Before asking the question, one comment, I did a study, I compared the group of two patients. one stage and two stages. And what I found, then in the second group, 40% of the patient whom I performed first, the mastopexy and fat grafting, postponed the second stage. So what is your opinion about to do one stage or the two stages?
I totally agree with you. There was a slide discussing this topic. It was the point 6 of secondary augmentation. If there is a high-risk patient, or if the patient agreed to have two operations, I prefer two stages. So I prepare the field with the lipostructure and the mastopexy. I have a stable situation, and then I move to the position of the breast, of the prosthesis. But of course, the cost of operation is higher. So you have to discuss with the patient very carefully in advance about that.
But you talk about the high percent of the complication when you do it once. So finally, because it's higher for us, for doctors, because we correct the patient by our own cost. So maybe it's better to do it in two stages.
Yeah.
Okay. So I think we can close this interesting session. Thank you to all the relators for being in time. Thank you.
Thank you very much. I have two information. So please don't be afraid to raise and stand up and go to the microphone for questions. It's extremely important to discuss any topic you disagree. Doesn't matter. I mean, we love disagreement in order to find a consensus. It's extremely necessary. The second is enjoy the lunch. After the lunch, if you please can come in time, because we will have the authority that will give the welcome. And we have a special authority, which is the president of Region Lazio. And he is also president of the International Red Cross and is the most important person about healthcare in the region. And so we will be happy to welcome him. Thank you very much. Enjoy the lunch. Okay, thank you very much to everybody to come back after the lunch. So I'm pleased to introduce now the session of the authority welcome. I'd like to invite first the health director of my hospital, the Sant'Andrea Hospital, Dr. Francesco Stella. Thank you very much, Francesco, for joining us and give your introduction.
Thank you, Professor Santanelli. Thank you, Fabio. Good afternoon to everyone. First, I apologize for my English, bad English. So I bring greetings from the General Director of Sant'Andrea University Hospital, who was unable to be present here today due to her illness. So today we have an international conference on breast surgery. Now it's the 9th edition that represents an event of extreme interest for not only for the professionals like you, but also for the managers of the health system organizations like me. I'm sorry. We have day by day to evaluate, to take decisions, strategical decisions or operational decisions to enhance the professionalism of collaborators or to improve sustainable investment programs. Our organizations, Sant'Andrea Universal Hospital, represents an oncology center recognized internationally. Thanks to the integration with Sapienza University of Rome and in the field of breast surgery, thanks to the work, to the dedication of Professor Santanelli and his staff. Therefore, as far as possible, I will follow the works today, and I wish you all good work and a fruitful investment in the program work. Okay, thank you.
Thank you, Dr. Stella. Now I'm pleased to invite Professor Di Biase. Will give the welcome from the University of Sapienza. Thank you.
Welcome, dear colleagues and friends. I'm very happy, I'm very proud to testify the interest of our faculty. The name of our faculty is Medicine and Psychology. And from the beginning of our activity in the teaching hospital Sant'Andrea in Rome, we were very, very committed to surgery and especially to oncology. So this is the interest of our presence here today. And the problem that we now front is to have so many patients who suffer from untoward complications after surgery and after oncological therapies. In this hospital, we had the work of Professor Santanelli about the complication of mastopexy. And you know that this is a very important issue because we have so many patients who had this kind of operations. In the same time, we are very committed to the psychological, to the quality of life aspects of our patients. So we recognized that it was important to support the patients, and we support the association Sex and Cancer, who is in some way connected to your topics, because many patients suffer from breast cancer. They have a breast reconstruction, and so they have the need to a complex and complete therapies, not only about the cancer surgical therapy or the cancer oncological therapy. So the presence of our faculty is very, very interested here. So I wish you the best work, and I wish also the best stay in our city. Our university, Sapienza University, has a broad interest in surgical, oncological, and cardiovascular therapies. And so we are connected and we are committed to the same work together. So team working is one of the most important aspects of medical interest now for the future of the medical affairs, for the medical work. Thank you for your presence.
And now I have a very special introduction because when Sant'Andrea started, we had the general manager of the hospital, and I had the opportunity to talk to him because of some problem related to breast reconstruction. So this general manager was the main responsible for what is happening now here in that session, in that Congress, and is responsible for giving me the possibility to perform 2,300 consecutively systematic breast reconstruction. Without him, that wouldn't be possible because the main problem at that time was that everybody was trying to do breast reconstruction. Well, this man has a clear idea how things should work, and he said, no way. Breast reconstruction are done by plastic reconstructive surgeon. Thanks to him, that now is sitting in the most important chair for health in the region of Lazio, is Francesco Rocca. Thank you very much, Francesco, for all you have done.
Thank you very much, Fab. I assure you that I didn't pay him for what I just told you. But sincerely, it's my pleasure, first of all, to welcome you all in this beautiful region, and I hope you will have time also to enjoy the beauties. Let me underline, not only of Rome. This is really a magnificent region with a lot of beauties to discover and to be discovered in many aspects. But by the way, I'm here because, as Professor Santanelli just mentioned, I'm in charge now. I have this new responsibility. I took my office 1 year ago, and I have the responsibility of the health of 6 million inhabitants of my region. And of course, breast cancer is something that has been always close to my heart. It couldn't be different. Unfortunately, and maybe you know better than anyone else, that sometimes entire families are exterminated by this cancer. And this happened to my family. My mother, sister of my mother, their mothers, the nephews, my cousins are under treatments. So you can imagine how important is this, and is close to my heart. And this is why I decided when I had this opportunity to run this hospital together with extraordinary colleagues. So I'm not colleagues as you mentioned, I'm not a medical doctor, I'm a lawyer by profession, but in terms of working together to invest and to create the pillars for what then has become a real breast unit in Sant'Andrea. Now in the region we have 16 breast units, and I'm very proud about the outcome. In 2023, last year, so during my first year on duty, we had the lower rate of mobility in other regions of women affected by the breast cancer. This is a reason of a high satisfaction. That means that in these 16 breast units in the region is a work well done with professionalism and accompanied by something that I learned on the job during my experience in the Sant'Andrea. The breast unit is something that to every day, we must fight with the egos. While the breast unit is something that only if the ego is put aside and putting at the center the human being that we all must serve, then they can succeed. This is what we try to achieve during my period. This is what I'm trying to achieve serving in this new position. And so this was the reason I couldn't miss, just to pay respect to you all and for your work, to pay respect to my great friend Fabio Santanelli. Welcome, welcome again, and I wish you all the success for this workshop, but also I'm really looking forward to receive the outcomes just to improve the quality of the breast unit in my region. Thank you very much.
Okay, we'll move on with the next session now.
Ecco.
Are you from Sao Paulo? Yeah. Okay. Good afternoon. Let's start to the third session this workshop. Professor Valerio Cervelli from University of Tor Vergata and Professor Munoz from University of São Paulo are with me as moderators. And could you introduce the first?
Thank you very much, Adriana. And this section, third section, is about the clash of the titans, pre-pectoral versus retropectoral implant-based breast reconstruction. And we give the word first to Dr. Cordeiro, Beyond the Horizon, Long-Term Outcome in Two-Stage Implant Breast Reconstruction.
Thank you very much. Thank you, Fabio. Thank you, Mark, for the invitation to speak here. It's always a great pleasure to be in Rome. I was asked to talk about long-term outcomes in implant-based breast reconstruction. I have no disclosures. It's pretty much known that two-stage prosthetic reconstruction remains the most common form of breast reconstruction. Now, there have been numerous studies that have examined outcomes, including complication rates and associated risk factors. However, the majority of these studies are limited by short-term follow-up, lack of evaluation of aesthetic outcomes, and lack of patient-reported outcomes, or PROs. Traditional concepts surrounding long-term outcomes following implant-based reconstruction have formed from what I call surgical dogma rather than objective data. And these are things that I learned when I was a resident, and I think people still propagate. And the dogma is that implant reconstruction deteriorates over time. There's a decline in aesthetic outcome. There's an increase in capsular contracture with time and a decrease in patient satisfaction. However, there are no good long-term outcome studies to support these statements. And as a result of this dogma, autologous reconstruction has been pushed as a more sustainable form of breast reconstruction. And although it's been pushed as a more sustainable form, some patients are not appropriate candidates. Some patients may not want an extended recovery time and additional scars. And many of them need to proceed with chemotherapy, radiotherapy, for which autologous reconstruction may be inadvisable or delayed. So the question becomes, what are the actual long-term outcomes of implant-based reconstruction? This was a publication we recently published looking at implant-based reconstruction over a 12-year period and looking at accurate patient-reported outcomes, and both in radiated and non-radiated patients. So the objective was to critically and objectively examine long-term surgeon-reported outcomes, SROs, and long-term patient-reported outcomes, PROs, in patients undergoing two-stage implant-based reconstruction. So my personal experience with implant reconstructions over about a 30-year period, over 7,000 implant-based reconstructions, of which about there are about 3,500 patients with textured implants that I'll talk about tomorrow in the BIA-ALCL section. But in all my patients, I see them once a year on a yearly basis for the first 10 years, and then every 2 years after that. So they all come in, I assess them, aesthetic outcomes, et cetera, are recorded and have been maintained prospectively in a database since 1992. So I'd like to share with you some of that experience. So over this time period, we looked at consecutive post-mastectomy implant reconstructions, uniform technique, one surgeon. All the patients pretty much underwent submuscular fascial two-stage reconstructions. The long-term follow-up, as I said, every year for 10 years and then every 2 years, and then the data accumulated prospectively. The long-term SROs that we included in this study are aesthetic scores. I have a categorical 1 to 5 scale ranging from poor to excellent, and I always grade the patient every time I see them. That data then goes into the database. Capsular contracture grade based on the modified Baker scale. And then PROs on every patient, every visit using the BreastQ. So we looked at the SROs and PROs from each outpatient visit, collated and analyzed over a 12-year period between 2009 and 2021. And you say, why was it only the 12 years and why didn't you go back to 1992? We started using the BreastQ routinely in my patients starting in 2009. So we thought to get complete data, we'd look at this period. Very hard to read the screen, but you can see that about half there were a total of 2,284 patients in this cohort. About half were saline, half were silicone. About half were unilateral, half were bilateral. A total of about 15% of the patients had received radiation either before or after their reconstruction. A total of over 12,000 outpatient visits. And the median follow-up for these patients was 66 months, so about 5.5 years. So a little difficult to follow this, but if you look at the top two curves, one's for all bilaterals and for bilaterals non-radiated. The next curve down in green are bilateral radiated. Then below that would be unilateral and unilateral radiated down at the bottom. I don't think this pointer works. And the bottom line here is that yes, there's a difference between bilateral and unilateral for sure. There's a difference between radiated and non-radiated. But the key point here is that if you look at it, the aesthetic result remains very stable over the entire 12-year period. Now, when you look at capsular contracture grades, at the top in green are the radiated patients, and you can see they also remain, this thing doesn't work very well, they remain very flat over time, and below it, the non-radiated. So the average radiated scores was between 1 and 2 capsular Baker grade, and average of about 1.5 in the non-radiated. Now, when looking at PROs, the BreastQ, you can see satisfaction with breasts remains flat, and there's no statistical difference between actually radiated and non-radiated. So this is what patients think, and that remains totally flat. Satisfaction with outcomes, totally flat. Psychosocial well-being, and these are all the different segments of the BreastQ that you can analyze. Sexual well-being, also totally flat. Physical well-being, also total flat. And really, essentially, there was no statistical significance between radiated and non-radiated. So to conclude, prosthetic breast reconstruction outcomes do not deteriorate over time, even in radiated patients. I have patients that are 30 years out, and they still have a very good result. And we take photos every time. And if you look at the photos, there's really minimal to no change between 1 year and 30 years. Long-term SRO data remains stable. Concurrent PRO data remains stable. And in fact, in some of these, if you looked at the curves, improve with time. And I think significant consideration should be given to these results when counseling patients on options for breast reconstruction. Since I have 3 minutes, I'm going to use just a minute to talk about this program, which we just started. And it combines Memorial Sloan Kettering Cancer Center with the WSRM. And this is a program, the worthy recipient is somebody who's at the associate professor level, less than 15 years out. And we will fund them to come to New York and to Sloan Kettering for 1 to 3 weeks, fully funded. And then the WSRM provides a stipend to allow them to go anywhere in the world to visit programs that they're interested in. And the idea behind this was to provide a valuable educational experience on both sides, to exchange ideas and to create long-lasting relationships. And if anybody's interested, you can go to the WSRM website. There's an application, or just contact me. Thanks.
Some question, please.
Hi, Amy Colwell from Boston. Peter, excellent talk as always. I think I may know the answer to this, but maybe you could just comment on whether these were total muscle coverage, dual plane, or pre-pectoral reconstructions, a mixture of them, and if it's one type, could these results be applied to the other types as well?
These are essentially all, they're submuscular fascial. So in the lower pole, it's usually fascia. Everywhere else, it's muscle. And it's the way I've been doing this to a large extent over, I have a few pre-pecs, but they're not far out enough, et cetera, to be included in this. But I think probably you can extend this. I mean, if you have a longer experience, my pre-pecs they don't change either. I think really when you're looking at a patient, what they look like at about a year and a half is what they're always going to remain at. And there's a rare patient who might get a contracture that develops over time, et cetera. But at least in my cohort, they remain very stable.
Peter, nice job. A few years ago, me and 5 other surgeons, all breast surgeons, tried to come up with an aesthetic score scale where we really tried to determine what constitutes a good aesthetic result and what constitutes an average aesthetic result. And it was really hard to get consensus. So I was kind of wondering what your criteria are for, giving somebody a 5 or a 4 or a 3 or a 2 or a 1.
So clearly subjective. In this group, obviously they're all assessed by me. So that at least it's one surgeon based. That doesn't vary. And certainly what I call a 5, you might call a 4. But, it's a general aesthetic, and symmetry is very important. The shape of the breast, if there's a little bit of ptosis, et cetera. And it's totally subjective. But that's why, I think, and it definitely comes out, bilaterals always look better. And even if you have a radiated bilateral, it'll generally score higher than a unilateral, but very subjective. And I don't think there's a good way to assess it. One of my colleagues is starting to utilize, we have 3D photos on everybody to try to figure out whether there's a way to do that eliminates the surgeon's bias, I guess.
I have a question. Dr. Cordero, in your fantastic and very well documented casuistic, what is the percentage of use of adipose tissue for lipofilling around implant?
For me, it's very low, probably less than 5%. I don't do it routinely, and I will only do it on a patient who has a significant deformity that is bothered by it. So I have lots of patients, we deal with some very thin, poor mastectomies. They have a defect usually in the upper pole. They might have rippling, but if they're happy, I don't necessarily offer it. So the ones that are bothered, I'll do it, but it's a very small portion actually.
Thank you very much.
Congratulations, Peter. It's a huge experience. I think it's one of the largest in the world. And about the problems and all the limitations that we have in terms of aesthetic evaluation. and quality of life issues. In your experience, based in your data, there is no impact of the radiation in the satisfaction and outcomes in immediate reconstruction with tissue expander following implants. But this is from the patient's point of view. In your experience in the last 20 years, did you feel that you have the same impression, or your staff, when you analyze the results are the same in terms of from the plastic surgery point of view?
Well, definitely there's a difference between radiated and non-radiated. And
Yeah.
if you look at the SROs, my evaluations, statistical difference, the interesting thing is in the PROs, there's very little difference. And much as I'm a big proponent of the breast Q because I developed it with Andrew in my department, and we've been pushing it, and it's a good method, it is not that accurate. And the problem is that patients don't really know what they're looking for. So they fill out the breast Q, and for them, they still have a good result. And it's not sensitive enough to differentiate.
Yeah.
I mean, if you have a terrible result, yes, it'll show up, but for the finer differences, it doesn't really pan out.
Okay, thank you so much. We are going to move to the second speaker, Dr. Berna, that you talk about the pre-pectoral Italian ravioli. I don't know what I mean, but we are Italian, so let's see your ravioli. Thank you for coming.
Thank you. Thank you to Fabio and Mark for kind invitation, even if I expected to find ravioli in the lunch, but I didn't find. Anyway, doesn't matter. All of you knows the Italian excellence, but I think that all of you knows that on Treviso, we discovered tiramisu, that means getting up. And this cake was offered after a sexual performance to the men. And so we are famous for this in my town in northeast of Italy. Not for sexual performance, of course, but for the cake. And also we start first in the world with the pre-pectoral breast reconstruction with ADM, covered with the ADM in pre-pectoral plane. I think that all of you knows the reason to put an implant in pre-pectoral plane. And also, I think that you agree with me that this is the enemy of the big issue for people that do breast reconstruction, the capsular contraction. So if we want to avoid this issue, we have to use something between the implant and the body. Breast implants are all the same. Ravioli are all the same. ADMs are all the same. No, they are not. Doesn't matter if you don't know the ravioli ingredients. Doesn't matter, really. They are delicious. And they have to taste this, but it's not important. What is really important is to know what we implant on the body of our women. It is completely different, the behavior of a synthetic and inert implant with a natural implant. Because in the first time, we have just an exclusion, and the end an encapsulation. In the other hand, we have inclusion and complete remodeling and integration with new soft tissue. So after 12 years of experience, we can affirm that we want to avoid capsular contraction in breast reconstruction in pre-pectoral plane. We have to use ADM. This started in 2012. This is me in Treviso with Simon Cotter, a really friend of mine from Bristol. And this is the first article in 2014. Nowadays, it's also easier. We have this new tool that is fast, really safe, controllable, and really effective. Know-how makes the difference, of course, in our job. This is our experience. At the beginning, we haven't not idea of what we are going to do with the implant in pre-pectoral plane with ADM, so nothing was new. Nowadays, we are most comfortable. At the beginning, we have a hard selection, strict selection of the patient, and now we are more soft, including also people that need the skin reduction. And I want to focus just in this kind of procedure, nipple sparing, wide pattern, and pre-pectoral implant. Why? Because patients want this. Patient really appreciates this kind of procedure. There are a different approach have been described in the past. We have just published in JPRAS 2 months ago this article that includes our techniques and our experience. This is the patient selection. I think that more than the thickness of the subcutaneous fat, the important is the blood supply. Some tips and tricks. Neck lift less than 9 centimeters. Vertical limbs about 7-9 centimeters. L-shaped mastectomy incision and smaller keyhole compared to the contralateral breast reduction. But you see in the movie. This is my drawing. Nothing new for the right breast. In this kind of breast, I use a medial superior pedicle. So nothing new for you. Some difference are on the other side when we are doing the mastectomy. So neck lift, in this case, about 5 centimeters. It's important to do a wide dome to embrace the neck. Otherwise, you have a lot of difficulty to put the nipple in the new position. And vertical limbs about 7 centimeters. We are using the test because we have some patients that after this procedure say, I feel. So we are testing now before and later the surgery. So some tricks of technique. Cold blade mastectomy is possible. Dermal flap internally connected, pre-pectoral implant, and so on. And this is the movie in the operating room. We are plastic surgeon. We don't do the mastectomy. The general surgeon does for us. Scissor and cold blade dissection is very important to preserve the flaps, of course. To check the neck vitality, to check the right position of the nipple after surgery in the patient with seat position. And this is important, according to us, because we have to consider the ADM like a skin graft. So as soon as possible, we have to have an integration. Otherwise, we can have seroma and other problems like infection and so on. We are ending. We are to check the vitality at the end of the procedure of the neck, of course. If it's necessary, we have to change our technique, but nowadays don't happen. And this is the patient. I want to focus in about the complication of this technique, how the complications are connected with the weight of the mastectomy. So nowadays, this is our statistics. We have done 95 patients with wise pattern and some clinical case sharing with you. I think we always perform the contralateral breast because we hope to have one-shot surgery. Not always is possible, but a lot of time, yes. Patients are very satisfied. We have not animation with this patient. They feel natural, and we are happy too. Okay. So complication, of course, we have had minor complication treated with ambulatory surgery, like this one, and this recent case with the sharing of the contralateral nipple. What's happened if we have a patient that have had radiotherapy? A very skinny patient, skin flaps. What we can do? We can use a pre-pectoral expander, obviously covered with ADM. We are implanting international studies with a lot of centers of Italy, and nowadays this is what we do: expander totally wrapped with ADM, filled with air at the beginning. In second stage, when we remove the expander, we put fat grafting. And what you can see what happened when we remove the tissue expander. We found new tissue, really integrated. There are this preliminary result from September 2022, 29 patients, 8 bilateral, in time with preparatory radiotherapy. Some cases. I see they are not too easy to resolve the problem of breast reconstruction with this kind of patient with implant. So, with the support nowadays with a big literature, we can confirm that according to us, the pre-pectoral breast reconstruction with ADM is our first choice. Ravioli technique, so, is really food for chance, and I want to thank you for your kind attention.
Well done, Giorgio. Fantastic work.
Thank you.
What is, in your opinion, the real advantage to use pre-pectoral ADM towards, for example, polyurethane implant? Because also polyurethane implant can be used for immediate pre-pectoral reconstruction.
I think that we have to answer this question with our patients, because nowadays we have not sufficient literature to affirm that pre-pectoral with the polyurethane implant in pre-pectoral plane works, because the follow-up is too short to affirm. We have a follow-up of 12 years. So nowadays I think that the first choice is with ADM. And also, in my experience, I removed some polyurethane implants because they don't work in the subcutaneous fat. If you have a thick fat, you can put what you want. But you have a thick, soft, without a good blood supply, it's difficult. It's
possible to put fat around.
It's very difficult after implant with ADM. With polyurethane, it's very easy with ADM.
After how many time?
We use to put implants of fat no less than 6 months.
Okay, that is the time of complete
integration,
yes, of the ADM. Please.
Very nice presentation. You did sensory testing, looked like before surgery. I'm curious, how many patients, what was the percentage of patients that had preoperative sensation versus those that had postoperative sensation?
We are studying. I can answer now. It is my impression. I think it is about 30%, but it's nothing, my impression. So we are testing now.
And there is a real advantage to use the preformed cupular ADM rather than the ravioli.
Yes, it is, because it is easier, it's faster. we started with a custom made, and was so difficult, so long time, and so a lot of exposure of the implant with the air, so with the risk with the infection, so it's better.
So that's 100% use the custom made.
At the beginning?
Now.
No, now, no, 100% done by the factory.
Yeah,
The
no,
new
no,
one,
no.
the new-
But the capsule,
Yeah.
the custom made is completely used this one rather than the one that you have to placate and to cut and.
I see. No, nowadays we use the fast at the end, the fast fraction. Yeah.
Congratulations for your work. It's a very nice, interesting talk, and I think I realized that you expand the limits and you expand the boundaries during your learning curve with this technique. And did you see any difference between in the beginning where you work with moderate volume implants for 150 cc, and now with the last casuistic that you have 650 cc in terms of complications? Once the weight of the specimens is a potential risk factor for severe complications and reoperations, did you see any difference?
I will say before, we have seen more complication with big size. In the wise and the normal, I don't speak today of the normal pre-pectoral reconstruction that we use a lot. And so that's true. At the beginning, we had a lot of rate of complication linked to the way that we washed the pocket. We didn't put stitches, and so we have a lot of rate of seroma and so on. We leave the drainage a lot of time with the risk of infection. I have no time to speak of all, of course, but you are true.
Okay, thank you very much. Now the third one, Dr. Venturi, utilizing perfusion imaging to quantify arterial and venous perfusion in Diep flap breast reconstruction.
Sorry if I steal few seconds. I like to inform, especially the young surgeon, that they have the opportunity of try the new microscope of Zeiss, trying to put stitches and see how it works. They have a simulation for microsurgery, and especially the new robot for microsurgery. So there are two locations where you can sit and try and experience yourself. So don't miss the chance. Thank you. Please.
Okay, thank you. First, I'd like to thank Drs. Santanelli and Clemens for including me in this outstanding program. It's a pleasure to be here presenting in Rome. A few brief disclosures. So my practice these days is almost 80% breast reconstruction. That is split 50-50 between device-based and autologous. Autologous, we mostly do deep flaps, the occasional S-gap, but mostly deep flaps. And I still managed to do 20% cosmetic. So our goal today is much loftier than when we started. It's to do a reconstruction that creates a breast that is arguably more aesthetically balanced than the one the patient started with. More often than not, we're able to achieve this goal using the nipple sparing technique, inframemory approach, and pre-pectoral placement. Usually we can deliver reasonable results. So then the question became, we were happy with the results we were delivering for our implant patients. How to extend the same aesthetic outcomes to our deep flap patients? We like the inframemory approach, but sometimes we'll do a vertical if necessary. But the real question became flap monitoring. If you bury your flaps, how do you monitor them for venous congestion? And according to the literature, venous congestion can contribute to 2 to 15% of the deep flap reconstructions and result in a significant take-back rate and flap loss. So in order to tackle this question and solve this problem, we turned to ICG perfusion imaging.
not only to look at inflow, but also to look at outflow from the flaps. So let me demonstrate this technique and this technology in what I would consider a high-risk patient. This is a patient who failed reconstruction elsewhere and came in looking like this, radiated on the left, lost a lot of skin, has an open wound, and has an implant reconstruction on the right. So this is the first step, which is the inflow using ICG perfusion imaging. This is not as important as the outflow, but in order to do the outflow, you first have to do the inflow. So what we're just looking at here is that the flaps are lighting up. That's the one on the right. You can see I've saved a skin paddle, not just a dermis paddle, but epithelium there, because that's really what we want to monitor. I'm also checking out the nipple to make sure I didn't kill it, since the breast surgeon didn't. And then we go back to the other side and we look at the large skin paddle we're going to need to replace the skin from the radiated breast. This is quantification. This is a neat adjunct where you can say, okay, I'd say that this, right there, this is perfect perfusion. It's off the breast, it's off the reconstruction. What does my flap look like relative to that number? So you can assign a relative perfusion when you decide which part looks good. So 10 minutes later, this is the important one, you do a second video with the ICG perfusion imaging. You don't give any more ICG. What you're looking to see is that the ICG has now completely left the skin paddle in 10 minutes. What this lets you know, you've already inset your flap. You now know that you have good outflow. So those tiny little radiated veins on the left are adequate. And on the right, I'm able to bury the skin underneath the nipple-sparing mastectomy flap. You can also use quantification for this, where I say, okay, well, how does that look relative to normal skin that is draining without a tiny radiated vein? Well, as long as you're within 20%, you're good. There's a clever way to do this all in one step, where when you do the first perfusion imaging video and your skin paddle lights up, you say, okay, I'm going to say that's 100%. That looks perfect. And you'll assign that value with the quantification technology. Make sure that it's the same on both sides, because it's a bilateral case. And then you're just going to stop. You're just going to put the handheld device down and come back in 20 minutes. In 10 minutes. And in 10 minutes, you can see 80% of the perfusion from the skin paddle has left the skin paddle. So now you know you can safely bury these flaps. You have good venous return. You do not have any problems with venous outflow, so they can be safely buried. So this is the patient before and after, and you can see I was able to use a large skin paddle on the left to get rid of a lot of that damaged radiated skin, and also do a nice nipple-sparing reconstruction on her right side, all the time knowing that I had good inflow and good outflow. So this is another example of how the technique and technology work in a larger breasted patient. Now this patient has a BMI of 39, so this brings me back to my days in Houston, and she has BRCA1. So we have the luxury of time. We can set her up with a breast reduction to make her a candidate for nipple-sparing mastectomy. You can see after her breast reduction, we have a little bit of a problem. Her abdominal flaps are larger than her reduced breasts. So we're going to have to reduce the abdominal flaps in order to better match her breasts now that they've been reduced. So this is on the table. The flaps have been raised on their perforators. And my goal here is to keep the well-perfused tissue and remove the tissue that's suboptimal. So we do the perfusion imaging and you see what lights up is good. What does not light up is expendable. So I can then take a marking pen and draw on the flaps and sort of whittle them down on the abdomen before we transfer them up to the breast. So I'm just marking out the areas to be reduced. And then we will also use this opportunity to look at her nipples after the nipple-sparing mastectomy, because even though we did the reduction first, still a bit risky. So I don't want to remove a lot of skin if I need it up top to fix a nipple necrosis. So the nipples look good on both sides, so we know we're ready to proceed. So now we've done the micro, the flaps have been hooked up, the artery, the vein. We want to just see if we've got good inflow. Again, not nearly as important with outflow. You could listen with a Doppler and get this information, but it's the venous component that you need to assess, and you cannot do this until you do the inflow. So, vai avanti per piacere. So you see the inflow comes in. This isn't really a big quantification. You just want to make sure that the flap is adequately perfused. So when you, 10 minutes later, shoot the outflow, you'll know that you have a good comparison. So this is the important one. Now I'm 10 minutes after I've done the inflow. I want to bury these flaps. They're big flaps. The veins are okay, but you never know with a deep flap. The flap to vein ratio can always be a problem. There could be a kink, there could be a twist, it could be positional. So the 10-minute video will let you know you're good. You look at the skin paddle there that we've preserved, and the ICG has left the skin paddle. The dermis is not reliable. The dermis still stays lit up, so you can't use that. You have to keep skin there in order to do this assessment. And when we do the quantification, 11%. So from 100% to 11%, we know we've got an adequate reduction in 10 minutes. This is the before and after of that same patient. And we did large flaps in a nipple sparing session with all the time knowing that our inflow and outflow were adequate. I've been doing this for a little over a year. I looked at my 2022 flap loss rate. It was 2% from venous congestion. We're definitely so far so good. I know I'm jinxing myself, and as a microsurgeon, we're the most superstitious people on earth, but I'll take a chance. So in conclusion, ICG perfusion imaging is allowed for real-time confirmation of inflow and outflow. It helps define poorly diffused zones so we can downsize them on the flaps, and it allows flaps to be buried very safely and improve our aesthetic outcomes, getting us to the levels we were achieving with implants. Thank you. I'm just thrilled that I didn't get the gong.
It's coming. Really nice technique. I love this adjunct in addition to just looking at the perfusion, but looking at the outflow. It seems like slight venous congestion is most difficult to achieve or appreciate in heavily pigmented skin, Fitzpatrick 5 or 6. And so I just wonder if there's an extra role for this, perhaps in certain races.
No, well, I think that's where this really is helpful, because assessing venous congestion, even on a skin paddle in a higher Fitzpatrick category, is challenging. So the ICG doesn't see color. It just sees perfusion. So this is actually where that's very, very helpful.
So one extra parameter that I'm hearing more people talk about is that you said 80% is sufficient. Some people have suggested that the time to get to 80% is just as important as the number.
So it's
getting
80%
to
at 10 minutes.
But even the initial perfusion, getting to 80% at 5 seconds versus getting 80% and it taking 20 seconds, some people would suggest that that's another marker of how well the perfusion is working, and that we should use that second component, not just a strict number, but a time to that number as a extra data point. If you, I just wanted to know if you had any comments on that.
Well, usually we do these as a team. For example, I'll do my flaps with Dr. Nahabedian, he'll do them with me, or Ms. Bahi or Piccolo, and they tolerate me for 10 minutes. So that's how we've arrived on this 10-minute time, because we give it time before it should adequately drain. That's an excellent point. I wish I had those data points. I don't, but the time to get to the 80% would be an interesting value to know.
Thank you for a beautiful presentation. My name is Latko from Zagreb, Croatia. I would like to ask you, did you compare that with, let's say, spectral or thermal imaging? Could be less expensive and more easy to do.
We don't have that technology, but so I don't have any experience with thermal imaging. We just use the ICG. That's what we have in our institution, and it's been very reliable for evaluating nipple necrosis. So we stuck with it for this technique.
Dayicioglu from University of South Florida. Can you please comment on your post-op monitoring protocol?
Sure. For deep flaps?
For deep flaps.
So we just monitor arterial flow with an external Doppler. We listen right through the mastectomy flap or, wherever to get the arterial flow. And then we just assess for softness. We trained the nursing unit extensively, and our flap patients only go to a 6-room area in the women's hospital. So there's been a lot of training on that. But this has been something that's evolved out of the fact that it's really hard to tell when you have an early congestion or not. So if we know we have good data intraoperatively, we're maybe less likely to take someone back for a perceived swelling.
And you can reliably, you can rely on the arterial Doppler signaling when it's over the mastectomy flaps, when it's a totally buried flap.
Oh, yes. Where I come from, our mastectomy flaps have no arterial signals.
Okay, thank you.
Okay.
All right. Yes.
Congratulations for interesting presentation. You work in a high volume center. It's almost 6 or 7 DIP flaps per week. Do you have a historical comparison before this technology in terms of the cost benefits, like reoperation rates or even LOS, like a length of stay, before you have this technology, the impact in your hospital?
I don't have a number in terms of financial advantage, but a lost reconstruction is in the U.S. is in the hundreds of thousands of dollars. So avoiding that and avoiding takebacks, I think, more than justifies the cost of ICG. The big cost is the machine. The little cost is the die. It's in dozens of dollars, not hundreds of dollars. But if you can avoid a take back, that OR time is extremely expensive.
Okay.
Thank you.
Congratulations. Yeah. So we are moving for the next speaker, Dr. Rebufo, in core performance, the second act for 2-stage breast recon.
Thank you. Thanks to Fabio for the invitation to this very important conference. And my talk is basically on the DDI and on expanders. So DDI, of course, is an important technique. And if you look at the literature of the recent years, of the last 10 years, there are a lot of papers on DDI, and often we tell our patient that we are able to do a definitive reconstruction, bilateral reconstruction, and this will be the only operation. But I don't think this is absolutely true. It can be true in some situation, but not always. And my consideration in the last years is that we should recall an old ally of us, which is the expander. Of course, the DDI has some ideal cases, like this one. This is a young patient that had a BRCA pathology, so she had to do a bilateral mastectomy with the ravioli technique. And in a patient like this, not a smoker, young patient, good tissues, this is for sure a case in which you can do the DDI, but I don't think it's always the best reconstructive option. So I think we should consider a lot of situation, a lot of different situation, and tell our patient that this will not be the only way in which we can reconstruct a breast. And so if we look to a publication also on breast expanders, we see that Italy has contributed in the last years a lot. So this is a technique that, in my opinion, we should consider in several situations, because every patient is different from the other one. Of course, in complete retropectoral cases, the expander has a good indication like this one, so reconstruction with tissue expanders and anatomical breast implant. And then the second stage with the expander substitution. A lot of these patients, really, they don't have one operation. They have 1, 2, or 3 operation, maybe with lipofilling. So expander can help us in several situations. Like this one, when you do a reconstruction with expander and you discover that the patient should have radiotherapy, you can add to irradiated expander a protective lipofilling, changing from a situation like this one. This is the moment in which we substitute the expander with a definitive implant without protective lipofilling, and in this case when you do the protective lipofilling, and this is something that we have published some cases, of course, but also in other situations like in pre-pectoral reconstruction. And we have published this some years ago. And I think also in this situation, the use of expander can have an important place. And this technique, the use of expanders, help us to in some way increase the application of pre-pectoral reconstruction. When you have smokers, when you have patients that have a thin envelope, in this case, the DDI is not always the best option. You can put a pre-pectoral expander and then change it in a second stage in a safer situation. Also helping you with, of course, with the ICG technique that we saw. And this is a case, pre-pectoral tissue expander, and then the definite result. Other situation like this, also above the pre-pectoral tissue expander, and then the implants change in a second operation. But expanders are also useful in other situations, like the Latissimus Dorsi reconstructive technique. And this is something that we are using often, more often, because a lot of time you have to do a second operation with mastopexy on the contralateral side. So putting an expander can help you to achieve a better symmetry, like in this case that you see. And even in the Diep flap, of course, in the delayed Diep flap, tissue expanders can help you. As in this situation, a patient that had a failed reconstruction elsewhere, and she came to a hospital and she wanted an autologous reconstruction, but she didn't want the patch that sometimes we know is not very nice to see of the abdominal skin. So we put a pre-pectoral expander, and we reached a nice volume. And then we went back and did the Diep flap without the patch of the island. So also in cases like this, I think the expander can help us. And of course, in the reverse tissue expansion technique that's is now raising again in the use. So in conclusion, I think that sometimes old is gold, and I think we should not avoid to consider using tissue expander in breast reconstruction, because it can help us a lot sometimes. Thank you.
There's some question? What is the percentage that you use in your casuistic of direct to implant and two-stage reconstruction?
Now I think that in 30% we use tissue expanders, but we passed from a time in which we pushed a lot the DDI, and then I realized that it was not the best option. So we're going back now, and we're using tissue expanders a lot more.
Perhaps the use is related also. I saw in some cases a quite good result, a really good result with the reconstruction of the fold. When you have problem with the fold of the breast in this kind of case, which is your philosophy?
When we have problems with the fold, probably it's the only indication when I still use the dermal sling. This is the only case when I use it. But using tissue expanders, of course, it can give you time to get a better result, because when you do the second stage and you take the expander out and put the implant, you have time to recreate.
Congratulations for the fantastic result. Okay.
Excuse me,
Yeah.
Diego, do you use an expander also when patient is undergone to radiotherapy?
Yes.
Yes.
Yes. In this case, I put the expander under the muscle. But of course, as you know, sometimes the patient does the mastectomy and she discovers after that she will have radiotherapy. But I use it. I do.
Thank you very much. Okay. Now from the School of Palermo, Professoressa Toia, leveraging a wide-based bipedical flap for reliable neck transposition.
Thank you, Chairman, and thank you to Professor Santanelli for this invitation. So I will present you this technique of the wide-based bipedical flap, which is indicated for nipple-sparing skin-reducing mastectomy in ptotic breast with excess skin. We started applying this technique to patient candidate to nipple-sparing mastectomy some years ago with a medium or large breast with a 3rd-degree ptosis and the BMI inferior to 30. Well, now you will see we are expanding in indications. The preoperative marking is a Weiss pattern with a T-shaped scar, and all the marked area is deepitalized, so including the 2 triangular areas. And mastectomy is performed through this wide access, leaving the nipple bipedicled. Actually, recently we're shifting to using the lateral part only of the incision, which in most cases is enough for getting a good access. Reconstruction can be immediate with autologous tissue or implants, or delayed with the use of expanders. Then for the technique, you suture the nipple complex in its new position, and then the skin flap are folded and closed together in a typical inverted T fashion. So here is a short video of the technique. So the skin incision according to markings and depitalization of all the marked area. Then incision of the lateral and medial pillar, but as I was saying, often the lateral part can be enough. Elevation of the flap, and then the mastectomy is performed through this access. So resection of the parenchyma, which is done by the general surgeon. And so this was a case with a pre-pectoral implant placement. And the immediate postoperative results, and the 6 month. So the one of the advantages of this flap is that it supports the perfusion of the nipple complex and adds an additional protection at the lower pole of the implant, at the junction or the T-junction, when there's a higher risk of dehiscence, so especially in case of reconstruction with an implant. So we said we could use this technique both for autologous and implant-based reconstruction, which is often a preoperative decision. but also concerning prosthetic reconstruction, it can be an intraoperative choice if using an expander or an immediate pre-pectoral reconstruction. So let's see some cases of the different options. So this was a case of autologous reconstruction, which still is a small part of our cases with this flap. So there was a patient with an intraductal carcinoma, which it was planned a nipple-sparing mastectomy of the right breast, and a left symmetrization with an upper pedicle reduction mammoplasty. So here the whip flap, which allow also for a good access to the internal mammary vessels. Although in our unit, we prefer the circumflex artery for immediate reconstruction. And this is the postoperative results. So the second option, we can use the flap even if we are putting an expander. So this is usually the case when mastectomy flaps are thinner than 8 millimeters, or in case of mandatory expander positioning in the contralateral breast. So this was another case in which the use of an expander in one side indicated its use in both sides, with a nipple-sparing mastectomy, a whip flap, and the placement of a submuscular expanders. With this postoperative results, the implant can be exchanged through both a vertical or a submammary incision at least 6 months from initial surgery. That gives the time to the dermal flap to integrate into the breast. And the other option is with pre-pectoral reconstruction, which is often the case when performing risk-reducing mastectomy, or when we have good mastectomy, a thick flap, radiotherapy is not planned, and if the tumor is at least 1 centimeter away from pre-pectoral fascia to prevent the need for radiotherapy. So this was a case, so with a right therapeutic and the left prophylactic skin reducing mastectomy, and a direct to implant pre-pectoral reconstruction. And here the result after 1 year. Another case with pre-pectoral direct to implant reconstruction, and here you can see how we started in the last period to use only the lateral incision, which especially in case of important significant ptosis is often enough and allows for a good breast remodeling anyway. And this is the pre-op and post-operative result. So maybe we can start to call it whip with 1B in some case when it's not bipedical, but using only a single lateral incision, as it was the case in this other patient undergoing a direct to implant reconstruction, and this is the early postoperative results. So we are moving to use it also in patients with a higher BMI of 30, and we have used it up to 40 of BMI. Of course, these are difficult cases because we have to consider the risk for complications, especially with patients that we already know that are going to adjuvant therapy, and we want them to finish the reconstruction as soon as possible and without reconstruction. For instance, this was the case that due to a massive involvement at the axillary, this patient, we decided intraoperative to postpone the contralateral surgery. So we wanted something easy on that side, no expanders. And in this patient, when they are obese, we have enough tissue with the skin during this flap to perform a breast reconstruction, so with a whip alone, that can be implemented later with lipofilling at the time of the contralateral symmetrization. So, and this is another case, and we're working on that right now. So as you can see in a small part of the case, which are the last one, we are using the whip flap alone without any other reconstruction. So it's another option in this obese and complicated patient for autologous reconstruction. We only had minor complication with exception of one case of exposure and the removal of the pre-pectoral implant, which was due to probably to a bad indications. So concluding, we can say it's a good option for nipple-sparing mastectomy, which improves the vascularization of the neck, with a good protection of the lower pole, especially in case of implant reconstruction, and could reduce complication in a ptotic breast. Also, in most cases, we can only a lateral incision is enough. And we can expand indication also to obese patient and patient with a severe ptosis, giving another option for autologous reconstruction. Thank you.
Any questions for the audience?
Thank you, Francesca.
Congratulations, Francesca. It's a nice job, and 8.4% of complications in this kind of patients, and with this technique, for me, it's too low. So it's very acceptable complication rates. You answered before why you excluded the body mass index more than 30, and I totally agree. Do you have any experience to change the pedicle, the superior pedicle, in order, like the superior medial and not totally superior, in order to incorporate the second space perforator vessels, because it's the pathway, and increase the vascularization in a higher risk patients? Or
but what we're doing now is leaving all the skin.
Yeah.
So we're just making an incision on the lateral part and only the vertical part,
Yeah.
which in this large breast gives often enough space to perform the mastectomy. So actually vascularization.
Okay. But I mean, when you maintain only the superior pathway,
Yeah.
and you cut the whole area of
Yeah.
the medial and medial superior aspect, maybe if you incorporate a little bit of more dermis in this area, not in your whole casuist, but in higher risk patients, maybe it will be an alternative
Yeah,
to
that's
reduce
true, but it's
complications.
also true that in the last case, we're just doing on the lateral side. It's true, and this also came from some suggestions, some meeting where we presented it, that people were saying, why are you cutting also medial? So we started to try, and we realized that especially in ptotic breast, you really can fold it and have a good shape without the need of this accessory incision.
Okay, congratulations.
Thank you.
Maurice, you got a question? Okay.
Sorry, Paolini from Rome. Congratulations, fantastic work. We appreciate this technique when one of your junior colleagues came to Rome. So it's very nice. Works very well. I wanted you to stress how do you behave with the intraoperative evaluation of the ducts, because that's an issue. Like the cynologist surgeon usually perform intraoperative evaluation to see if the neck is interested by tumor and if can preserve or not.
Yes, they do the histological examination.
Yes.
They always
Meaning-
take a biopsy
Okay.
from the retroaureolar area, and they send it.
Meaning that in that case, you wait to perform the deepitalization of the.
No,
of the-
usually we do it at the beginning. So we start, then they do the mastectomy, and they.
Because I mean,
they-
if you lose the nipple because they have to remove the nipple,
yeah, we remove it.
how can you
Otherwise,
close?
we close. Yeah.
With a round block?
Yeah.
And then I want to know what are the limits of the for the indication of this technique, like the distance from the inframammary fold of the nipple. The nipple to come up needs to have a certain length.
Yeah, we
there
said a
some
minimum
case-
of 8 centimeters,
that-
and then not really a maximum, because then you can fold it, so you just get more tissues.
Okay,
by
thank you
folding
very
it.
much.
Very nice work, Francesca.
Thank you.
The ptotic breasts, have you ever experienced by folding the dermal pedicle some venous congestion issues? Or is that not a problem?
Yes, we experiment a bit of the nipple complex, but till now that's always solved conservatively.
Okay.
So just maybe some depitalization.
Okay.
But, yeah, no.
And another question maybe to you and all the previous speakers. As I can see, all DTIs, pre-pec, are all wrapped into an ADM.
Yes.
If the ravioli would have been invented by Englishmen or Germans where the food habits are different, would you also use it? Because some flaps are really very, very thick. So I don't really get the point why to use an ADM. Additional foreign body, additional costs.
Yes, but the idea is always to get an interface to reduce in the future the risk for
Capsular contraction.
Yeah. So.
So this is a great technique. We do a lot of this where I practice as well. I think the key things with this specific technique is to work with the right breast surgeon. Not all breast surgeons who do the mastectomy are capable of doing this, because if you undermine below the inframammary fold, you will divide the blood supply to that inferior pedicle, which is the dominant pedicle. I don't think that superior pedicle is contributing much, because you're really, with the mastectomy, you want to preserve that fifth anterior intercostal. The fourth, the third, the second, the first, they're all cut. So there's very little blood supply that's coming from above. And I bet you if you were to do some of the imaging like Dr. Venturi showed, there would be very little blood flow through that upper pedicle. But the key thing, I think, is to just make sure that you're working with the right breast
surgeon.
surgeon.
we always work with the same breast surgeon. We stress a lot the inframammary fold to leave it attached. And yeah, we're in a good team. So.
Good.
Last question.
Last but not least, Zlatko from Zagreb again. We do the similar stuff all the time. Just about the terminology, why don't you call it Mekisog with pedicular technique?
Because you keep the lateral triangles. And well, I mean, it's not exactly the same, but it's true that it's a variation, and of course we don't invent anything. Things
quite similar.
Yeah, the things return, but
Okay.
it's a different application.
Thank you, Francesca. We are moving to Dr. Colwell to share her experience with natural results after pre-pec recon with mesh. Thank you.
Thank you, and thanks to the organizers, Dr. Santanelli, for inviting me to give this talk, and Dr. Clemens. And my disclosure is I do receive some royalties from Wolters Kluwer. So we've seen that contemporary breast implant reconstruction involves nipple-sparing mastectomies. We've seen an evolution of better quality mastectomy skin flaps. We've seen how acellular dermal matrix or mesh can improve our results. We've got more cohesive and overfilled silicone implants. We've got fat grafting. We've got targeted radiation, all great tools for us to make nice breast reconstructions. This has led to coming back to pre-pectoral device placement, which is the most natural position. We have little or no animation, an improvement in pain, at least in the first week, improve outcomes with radiation in terms of fold elevation and pain, and definitely a better match for a unilateral reconstruction. So, you know, in the US, some of our earliest studies were done by Steve Sigalov and Alan Gabriel, who really led the way for us. And what they showed us is that they could do this reconstruction with very, very few complications. Their rate of infection was very reasonable at 4.5% and really no capsular contracture. And that was a real eye-opener for us. And then my old medical school classmate, Steve Jacobson, was at the Mayo Clinic, and he was doing the same thing that these guys were at the time. And again, you know, 135 breasts and 79 patients with successful reconstructions in 96%. So since then, I've seen a couple of different trends. Some people, like Dr. Cordero, you know, stay completely subpectoral. Others go completely prepectoral. So what is my choice? Well, I'm a little bit different in that I do both subpectoral dual plane and prepectoral reconstruction. And the reason is that we don't really have a perfect reconstruction, do we? So for the subpectoral dual plane reconstruction, the results are certainly smoother. You've got the muscle in addition to the skin. You get more lift of the breast, which for us and some of our patients is an advantage. You have more control over direct implant reconstruction in a large breast, but in contrast, you get mild animation and more pain the first week. In contrast to prepectoral, as we all know, has no animation, definitely more comfortable in general the first week after the reconstruction, less pain with radiation, but of course there's more rippling visibility and less lift. So again, neither is perfect. And so about half my practice is still subpectoral dual plane. So that's another disclosure for this talk. But now I'm going to focus on getting natural results in a prepectoral breast reconstruction. So how do we do that? Well, it depends. What does it depend on? What do you mean? Well, it depends on the quality of the mastectomy skin flap. So, what we're left with, we're going to have to decide how then to proceed to get the best breast reconstruction. The amount of native subcutaneous fat the patient has, the extent of the lateral dissection. Most of the talks I've seen today, we put the implant in and it stays there. So that's different than in a lot of my reconstructions where the dissection goes out to the LD and undermines it. So I need better pocket control, whereas not everybody needs that. The size of the breast, easier to do a small breast reconstruction, right? Availability of ADM mesh, what is it you have to use, and type of implant. So a lot of the talks we've seen here are using textured implants. That's kind of disappeared in the US because we have a litigious society. So we're doing most of our reconstructions with smooth implants, which do have some different characteristics, and we need better pocket control. And so the technique I'm going to show you is going to show you what we need to do, I think, to get that. So what do I think is important for prepectoral reconstruction? I think we do need ADM or mesh for long-term support and pocket control for most of our patients. Second, I typically sew this to the chest wall. So I want to use this to my advantage to create a very strong pocket. And then I also think, again, particularly with smooth round implants and direct to implant, I anchor the ADM to a slip of pectoralis muscle superior. And that helps prevent sort of that step off that you see with smooth round implants. And it's also better for pain. Some patients, when I wasn't doing that, would complain of some pulling sensation in their upper chest. This has essentially eliminated that. And this is, one of my earlier reconstructions. I do think that the shape textured implants give you the best long-term results in breast reconstruction. We just can't use them. So this was a patient right-sided reconstruction with a porcine ADM and a textured device. We can still get reasonable results with smooth round implants, and this is a patient right-sided reconstruction with human ADM and a smooth, round, moderate cohesive silicone implant. So how are we going to try to do this? Well, I do a complete anterior coverage technique for mine, and most of the time I'm using human ADM. So the first thing that I'm going to do is I'm going to pick out my implant. So I already know the base diameter that I want. I put the sizer in to determine volume and to see if they're a candidate for direct to implant or if we need to do a two-stage approach. Then I'm going to measure my pocket, and this pocket's going to be tight. So if the diameter of my implant is going to be 14, I'm going to make a 13 centimeter pocket. So it's going to be a really, really tight fit. I'd like using 2 pieces of contour alloderm. It allows me to tighten the pocket and really control it. But I'm going to show you both ways. And in general, I use a permanent stitch to sew this in. Why? It's because that I don't want in 6 to 8 weeks implant to sort of be falling out to the side. Remember, I've got a big dead space to the lateral side in my reconstructions, and I really want to really hold my implant. Immediately, I'm going to sew it to the chest wall, and here I'm just raising that slip of pectoralis muscle superiorly so I can inset my ADM into it. And so that's what it looks like there. Medial, as I mentioned, I think, one of the advantages of prepectoral reconstruction is you can get the implant a little closer to the midline. So take advantage of that and don't restrict your implant from getting there. So I just sew that to the chest wall, or to the skin flap. And then this is another stitch. So when I'm sewing it to this slip of pectoralis muscle, can you push play again? Oh. Could you fast forward that? Is there any way? Keep going, keep going. no, back a little bit. Sorry. Well, anyway, I sew to the pectoralis muscle superiorly. I usually bury those stitches so the patient doesn't feel them. And then I'm going to place some tacking sutures, medial and lateral, before I put my device in, just to kind of hold the contour pieces in place. Once that's complete, I'm going to put my drains in. I'm a big fan of drains. I use two. One goes inside the pocket along the inframammary fold. The other goes into the axilla up over top of the muscle. I want to completely drain the space. I also want to help the ADM incorporate to the skin. And then you can use a Keller funnel. You don't have to. It sometimes can be helpful in very large breasts. And then once that's complete, here's where I can set my tension. So I'm just using a Vicryl stitch here. If it's a large implant, I'm going to oversew that with PDS because I don't want that coming undone. But this is really here, the reason I like the two contour pieces for a direct implant is really being able to completely control the tension. And then once that's complete, I deepithelialize the skin edges and close them in layers just like you all do. Now, if instead I wanted to use a rectangular sheet of ADM, what I'm going to do is I'm going to pick out my device and then I'm going to see how this wants to sit in the pocket over top of the device. So this was a porcine ADM, which I will often pie crust. You don't really need to do that in human ADM, but see, I'm just measuring out exactly the amount I need. And then if I have extra, it's sometimes very helpful to have a little gutter. And I learned this from Dr. Sigalov. So you can sew your ADM to a cuff of the you can sew it to a cuff of the ADM inferiorly so that you have a little gutter for the implant to sit in. And that's just where it is. And then I'm going to go ahead again and raise that slip of muscle. I think that's really critical. It takes a little bit more time, but not that much time. And then the ADM is going to go in there and I'm going to sew it medially to the skin flap and laterally to the chest wall. And generally I'm preferring horizontal mattress sutures here laterally. Again, just want a really snug pocket. You can see part of the dissection there, right? You know, that's a lateral border of where I want my implant to be, but you know, chest wall sort of skeletonized there. And so we really need some good support. I'm sewing it medially, and then I'm going to sew it up top again to the muscle. This is a little bit better view of showing it to the muscle. So I start from underneath the muscle with the ADM, go through it, and then go back again. So the knot is sort of buried underneath the muscle so the patient doesn't feel it. And then you can put your sizer in, you know, before you put your implant in. Just make sure you've got a nice, tight pocket. And then the implant goes in with the funnel along the base. But the closing is basically the same. And this is a patient I use that technique on. And, you know, the implant placement usually is pretty good. It's particularly good for unilateral reconstructions where the implant just falls to the level of the other breast. Laterally, you know, in the US, when we have these dissections that go all the way out, there are some contour irregularities we just can't fix. So taking everything in together, you know, how will we treat a patient like this? 47-year-old female with left breast cancer with a skin-sparing mastectomy. Well, this was a problem we couldn't fix with a dual plane technique because a dual plane would lift the implant up too much. Here, a pre-pectoral device placement, this time in 2 stages with a contralateral mastopexy, gives her very reasonable symmetry. Another patient with a right-sided pre-pectoral reconstruction. What about this patient, a 52-year-old female, bilateral mastectomy and wants an uplift? Well, she has very thin skin here. So in my hands, a dual plane reconstruction is going to give her a more natural result. So part of the natural result for pre-pectoral is picking the right patient. Another patient, very thin skin. In this case, we're going to do a dual plane reconstruction. And in terms of animation, we all have patients with really bad animation, but this is what I see for the majority of my patients. So yes, her implants move a little bit when she flexes, but it's not as deforming as we typically are seeing in the presentations. A last patient, a 42-year-old female, planned for bilateral mastectomy and radiation. So she gets bilateral direct to implant. Implants a little tight and high at first, and then she gets her radiation to the left. And overall, not perfect, but reasonable symmetry. We presented our results at the European Association this past year with nipple-sparing mastectomies, and the one thing I wanted to point out is that complications is not a factor. Pre-pectoral and subpectoral reconstruction in our hands, as well as many other hands, have a similar rate of complications, so that's not really a reason to choose one over the other. So in conclusion, pre-pectoral breast reconstruction yields a natural breast shape. The pre-pectoral pocket is ideal for unilateral reconstructions, and also I do it when post-mastectomy radiation is planned. Pocket control can be obtained with ADM or mesh, a tight pocket, and anchoring superiorly to the pectoralis muscle. And finally, patient selection is important. The pre-pectoral plane may be less ideal for patients with thin skin, minimal fat donor sites, and those desiring more uplift of the breast. So thanks very much.
Quick question on the uplift. So are you saying that when you do the dual plane, the muscle's pushing down superiorly, creating more projection inferiorly, or walk me through the uplift?
Yeah, it's kind of like the difference between a subglandular and subpectoral breast augmentation, right? There's something about the implant being underneath the muscle that just tends to hold it in a higher position. And the same is true for reconstruction. Something about the muscle, it kind of holds the implant up higher than it does for pre-pectoral reconstruction.
How does it hold the implant up higher if it is?
I think it's a tighter pocket. It's a stronger pocket. So right now, you have a complete pocket with the muscle attached to the ADM. That's one pocket. And it's just something I've routinely seen. And it's just very similar to what we see in cosmetic surgery as well.
This sort of anchorage to the upper part of the pectoralis push the prosthesis down in some way. But what kind of prosthesis do you use? Only round, anatomical, or?
Unfortunately, in the US, almost everybody now uses only smooth round implants. And, our population in general is very educated, and, even if you tell them the risk is pretty rare with the microtexture, they're convinced they're going to be that rare one. That's one thing. Second, the US is a very litigious society. So, if you're using these textured implants, we know that ALCL has been reported with all of them, right? Just takes the patient, there'd be a lot of surgeons in the US who'd say, I would never use a textured implant. There would be no problem getting a lawsuit against you. So even though I think it would be better in some patients to use them, particularly in the pre-pectoral plane, we just can't.
But this sort of anchorage to the upper part of the pectoralis helps you to put to anatomize the prosthesis. And
I think so. Yeah. I think that for the smooth round implant, we need something. We've all seen people show their results, and it's a flat chest and an implant comes out. It's hard to control a smooth round implant. So I think it does give you a little bit more of that anatomic incline and better support.
Okay.
I have a question, sorry. We learned from the Italian ravioli technique that we put stitches between the mastectomy flap and the ADM. Do you do that, or you don't put any stitches between the mastectomy flap and the ADM for integration?
I put none. No, I don't put any. The exception to that is if I have a very large breast, I'm worried about the skin flap falling off the device. And so inferiorly, I will put some sutures from the skin flap to the ADM to prevent that space from creating a space, having a seroma pocket, that kind of thing.
Okay, thanks.
I somehow agree with Dr. Venturi. I think the more we go away from the texturization in the subpectoral plane, we won't have any more on the long-term uplift problems, but we will have problems of bottoming out and lateralization of the implants. And this is why now we are discussing about how to support mesh, sling, ADM. But I personally don't see any issues of uplifting, having a smooth implant below the muscle.
Mm-hmm. Yeah, it's not an issue. It's actually a good thing. I'm talking about the final implant position. So just something I've noticed with the dual plane is that if you have a really good tight pocket, you've got great support for the device. And that was one of the problems with unilateral reconstruction in the past, right? Because the implant would sit up higher. Meanwhile, you've got a ptotic breast on the other side. Whereas if I'm doing a unilateral reconstruction, I showed a pretty ptotic breast, the implant tends to fall down and stay at the same level as the other side.
Okay, thank you very much. And the last speaker is our friend Corrado Rubino, the challenge of the autologous coverage of the implant. Prego, Corrado.
Distinguished chairpersons, ladies and gentlemen, I would like first to thank my friends Fabio and Mark for having invited me to this 9th international workshop, which has now become an appointment for the excellence in breast surgery. It's disappearing. Solo lettura. Just click. Huh? Okay. I'm going to speak about the problems of autologous coverage of pre-pectoral implants in large and product breast reconstructions. I have no disclosures. Yeah, I'm clicking, but nothing happens. Okay. As you know, alloplastic breast reconstruction in big breasts, large emptotic breasts, is challenging because we have got large flaps, and in patients with known risks, there is an increasing complications rate. In such patients, as we have seen, and I thank also the previous speakers, the using of skin-reducing mastectomy using the classical Wise pattern or the modified Wise pattern type 5, as shown by my friend Professor Santanelli di Pompeo, improves the aesthetic results. The use of what is called a dermal flap or dermal sling to cover the lower pole of the implant associated with a subpectoral implant coverage has been widely described and reported in literature. And with the advent of pre-pectoral implant reconstruction, we have got other possibilities. We have seen that we have got other possibilities. ADM and also autologous dermal grafts from the contralateral breast reduction, for example, has been described. In this presentation, I will report my experience with certain innovations with using the classical inferior dermal flap with the pectoralis major and serratus fascial flaps to obtain coverage and pocket control, as the previous speaker said, of the pre-pectoral mammary implant. I report a series of patients operated in 1 year with 1 year of follow-up. There are 25 patients with large emptotic breasts operated for uni and bilateral breast reconstructions. And among these patients, in 8 patients, the implant was covered with a dermal flap and pectoralis muscle, an already reported technique. In 7 patients with a dermal flap and ADM. And in 10 patients, the implant was covered with dermal flap and fascial flap. How do we choose this? Of course, the patients are eligible for this kind of technique if with the large emptotic breasts with external notched nipple distance equal or above 26 centimeters and the nipple to submammary distance equal or superior of 8 centimeters. Of course, the patient with a history of radiotherapy are excluded. And the other question is, does upper superomedial or superolateral quadrant skin need to be removed? Because sometimes the tumor is too close to the skin, and the surgeon says, I have to get rid of some of such skin. And this gives us the possibility to choose a different kind of skin pattern, skin reducing mastectomy. Intraoperatively, if we have got a skin flaps thicker than 1 centimeter, we go for a pre-pectoral reconstruction or and also a viable skin flaps. Otherwise, we go for a subpectoral. Now, the last choice is to have a look to the fascia of the pectoralis muscle mainly, and also of the serratus. If there is intact and good fascia, we go for an implant coverage with fascial flaps. If not, with an ADM. In summary, the inclusion criteria are a sternal notch to nipple distance greater or equal to 26 centimeters and a nipple to inflammatory fold distance equal to 8 even or more than 8 centimeters, and of course a good skin flap thickness and viability. Exclusion criteria are inflammatory breast cancer, previous radiotherapy, heavy smoking habits, obesity, morbid obesity, of course, and uncontrolled diabetes or vasculitis and collagen disorders. We have got, as to the technique, we have got two possibility of skin pattern. The classical type 4 mastectomy with a Weiss pattern, of the type 4 modified Weiss pattern that you can see onto the right. Then, if the fascia is intact, we raise two fascial flaps from the pectoralis major and serratus muscle, and then we cover with these two flaps and with the dermal flaps, inferior dermal flaps. We normally cover first a sizer to the side, which is the sides, and then we put the implant. These are the intraoperative view. Starting from your left-hand side, you see what is left after the mastectomy. Then you look at the two muscles. In the third, sorry. Oh my God. How can I go? Backward? Okay, then we raise the two fascial flaps, and then at the end you can see the coverage of the implant with all three flaps. 10 patients were eligible in this 1 year with the described surgical techniques. 6 patients had unilateral mastectomy and controlled Weiss pattern reduction mammoplasty, and 4 patients bilateral mastectomy. Overall, 14 breasts. Nipple sparing mastectomy was performed in 7 patients, and nipple removal in 3 patients. Main patient, you see here the anthropometrics. What's interesting is that we have shifted now almost entirely to round implants, round smooth round implants. The first were shaped implants in particular patient, but I prefer now using only round implants. Complications. We had in 3 breasts problem with the skin, with the nipple areola complex sufferings, 1 implant loss for infection, and 1 rippling. As for after 1 year, all patients, all reconstructed patients undergo a breast screw measurements and also aesthetic validated questionnaire, and you see that we can have a good satisfaction with breast. It's significant, the item satisfaction with breast and satisfaction with implant. Also, with the validated aesthetic scale, we have got reasonably good after 1 year in this. This is a first case series to validate the technique, and we see that overall is 4.2, or considering that the maximum score is 5. Let's see some patients. This is the first patient is the patient we have seen the intraoperative views. It was a bilateral case with a type 4 classical Weiss pattern, and these are the postoperative views. In the second case, we have got a patient. This patient needed to have a removal of the superior lateral part of the skin, and so we use the modified Weiss pattern of type 5 mastectomy, as our friend Fabio described. You see, we have got a large pocket, and the two fascial flaps can cover almost entirely, but the problem is that it's important to cover the parts under the sutures, and actually the most important thing is to stabilize the implant, avoiding that it moves. I agree with the previous speaker, because we also have the problem of controlling mainly laterally the pocket. And this is the post-operative after 1 year. You see good symmetry. Of course, the pattern of scar is different because it's different, the pattern of skin. And this is another type 4 mastectomy, the classical Weiss pattern. With another thing is, even if you see that the marking is a sort of is like a keyhole, you have seen in the diagram that I never deepitalize. I've learned not to deepitalize the keyhole, but rather only a triangle, because after so I had some bad news, and I never ever now deepitalize at the beginning of the operation, only afterwards, because in the old times we were used in the reductions to have a triangle and then to pop the areola out, so it's not easy. It's not difficult to do it afterwards. After we know that the nipple areola complex is okay. This is the postoperative views, and actually I think that this is another choice, because it's cheaper, and if nowadays the general surgeons, breast surgeons have learned that it's not always necessary to remove fascia. There are only some cases where fascia has to be removed, and in this case we will use another technique. Thank you.
Question?
Corrado, what kind of prosthesis did you use with this technique?
I told you I'm now using round, smooth implants. The cases when we use the anatomical implants, we use the micro-tested implants.
And what kind of implant of drainage do you use?
I use a suction drainage.
Suction drainage.
Yeah.
How many times do you leave the drainage?
Well, in these cases, we don't use, there is no IDM. With IDM, I use a very long time just to keep suction. But in this case, it's autologous. So just when the drainage is below 40, 30 cc for a couple of days. I mean, the usual.
Okay, Zlatko from Zagreb. We have published that maybe 5 years ago. So we call that dermal cage to support the implant on the pec-mac for those kind of the procedures. And for that, we found like, I'm not sure about 8 centimeters nipple to IMF distance is enough for overlapping the dermal flaps. We used to use like 11 centimeters, like determination, to use the dermal cage technique. You think 8 centimeters is enough of the nipple to IMF?
8 centimeters is the minimum. It's below that, I would not do that. But 8 centimeters can be for a not very big implant. But one of the good thing of the techniques of the skin reducing technique is that you do bilateral surgery, so you can choose the actual volume. And therefore, in my experience, 8-9 centimeters for a not very big implant is all right. I mean, it's the minimum, of course. If you have 10, 11, it's 12, it's better.
Very nice presentation. One remark. This kind of patients are very challenging, not only because of the risk of necrosis of the nipple aureola complex. You have three cases of necrosis, but the patient with higher risk of deep vein thrombosis as well. We have to reduce the time of the surgery. So please consider the option to perform the surgery another way. Simply excise the full nipple aureola complex together with the breast tissue, transplanted the nipple to the inguinal region, and it is much quicker surgery. And 3 months later, retransplant the nipple and use the tattoo. Now we have 3D tattoo, so it's very nice, and even the aureola is better than the original aureola. But we have advantages. We are we reduce the risk of cancer, because we remove the all glandular tissue, even the area below the nipple aureola complex. We reduce the time of the surgery, and for sure, we finally obtained the very symmetrical position of the nipples because we transplanted them 3 months later, and we have no risk of necrosis.
Thank you. Okay, it's actually were 3 cases overall. There was also 1 case of very partial necrosis, which healed with just dressing changes.
Last question.
I just wanted to comment when you said that you cannot control the lateral side of the pocket. This isn't a technique that we describe, because you take the whole skin, which is usually thrown away, and deepitalize it, and you can use those wings to control the pocket on the lateral and the medial side, and that way you have better control of the whole breast implant from the end with vascularized dermis as well.
Well, actually, I don't do that. I control the lateral part with the same technique I have used for years for to control the lateral part of the expanders. I use the fascia over the serratus anterior. I just do. I have done always with this kind of fascial flap, or even when I didn't do that, when I couldn't do that in the past, I used just the serratus muscle. But in these cases, it's just the fascia.
Congratulations. Paolini from Rome.
Last.
Paolini from Rome. Just now, I wanted to just say a comment on your comment, because we had the former experience of transplanting the areola at the inguinal site, but Italian women just don't like that.
Okay. Okay.
Yes, but they really don't like it. So we stop.
Okay,
we did stop doing that.
Okay, we are late, and congratulations to all.
Thank you
to all of the speakers for the excellent presentation. Let's go to coffee break.
Yes, sure. We have a coffee break, and then there is at the same time, for those who are interested, there's the Integra Symposium here. So please, people that are interested in Integra, ADM, come back and listen to the Integra Symposium. And Yang, you can visit the 2 stations for simulation for micro and super micro surgery.
Thank you so much. Grazie mille. Grazie mille.
Alexander, for your presentation, sorry. We have a Mac computer, so if you want to give your presentation, you can give them. If you don't want to give your presentation, then
anybody
you can check
from
the connection with the guys now.
Okay, yeah.
I managed Santanelli to give me his presentation, but I know you have a lot of nice videos, very loaded presentations. So
You don't have the cable there, yeah?
no, you can
I
work.
can leave my computer
Yes, the
there?
problem is we have to fix also the pointer, but
Okay.
we have an extra pointer. But
So
do it now.
I can record in a pen drive.
And you
in
give
a
it
flash drive, and I give to the
Okay, that's better.
technician.
Yeah, and then I will delete it.
Sorry, I cannot hear you well, but I'm not sure that
someone will connect.
C'est le numéro de Diana, ça vaut le coup d'appeler là pour savoir quand est-ce qu'on se lance. He said they were late, so maybe he's just hanging it over 5 minutes or 10 minutes late, but
Roberto, mettili Zoom, dove sta? Vuoi salutarli tu? Vuoi fare un saluto tu o faccio io?
No, the reason because there is not the presentation.
Hello, everybody. We are ready for this soft tissue reconstruction symposium from Integra, and we are connected and hope you can see them live. Okay, I would like to leave the word to Cedric maybe to introduce this symposium. Thank you very much.
Can you hear me?
Yes, perfect.
Excellent. We were wondering. Excellent. So, good morning, good afternoon, or good evening, depending on where you are. I know it's an international global event. We're very, very happy to be here, and we are very happy to have you all in the session today. I am Cedric Petro. I'm head of marketing for the Tissue Technologies Division at Integra for EMEA region. And without any further delay, I'm going to introduce you to our speaker today, Sunil Saini, who is going to talk to you about the science behind the surgiments and our collagen matrices. Sunil, you have over 20 years of experience in the medical devices industry, specifically in the development of regenerative medicine products. You currently serve as the Senior Director of R&D, Research and Development at Integra Life Sciences. And you're leading product development from the early stage exploration to product introduction. You've received a degree in chemical engineering from the University of Maryland and a PhD in chemical engineering from Georgia Tech. With that said, Sunil, I'm handing it over to you. Thank you.
Okay. Thank you, Cedric, for the introduction. Can everyone hear me?
Yes, perfectly.
Excellent. I'd first like to thank the organization for allowing Integra to speak in this session today. So good afternoon to the attendees. So as Cedric mentioned, I'm Sunil Saini, Senior Director of R&D at Integra Life Sciences. My talk today, entitled Soft Tissue Reconstruction, the Science Behind SurgiMend Collagen Matrix. As far as disclosure, I am employed by Integra Life Sciences Corporation. And Integra was founded on really the platform of regenerative technologies, starting with IDRT, the artificial skin technology, which is used to engineered skin. But since then, we've employed and encumbered other material and biomaterial platforms, including allografts and xenografts, to really establish a portfolio, a platform to help the body repair, reconstruct, and regenerate. And while our products are acellular in nature, that is, they do not contain cells, so we're really relying on the host cell interaction to repopulate the three-dimensional matrices that we have developed. Just to give you a flavor of our technology platforms that we're able to utilize for clinical applications, they come into three distinct categories. So the animal-based acellular or xenograft materials, starting with our engineered collagen. As I mentioned, that was our flagship product for the Integra Dermal Regeneration Template. Moving to the acellular dermal matrix, which is really the focus for today's talk, where we'll be going into the SurgiMend science and technology. The urinary bladder matrix that you see there, that's derived from porcine bladder. That is another embodiment of a biomaterial that helps modulate the immune environment and really move the wound environment into a more regenerative macrophage environment. What you see here in the middle with allograft tissues, these are human-based tissues, recognizing that those are primarily a lot of usage, clinical usage in the US. but with the restrictions in Europe, this is probably less of a availability for amniotic tissues. As we move to the very right of this slide, we also have a portfolio of polymer-based or synthetic materials, starting with our activated PEG technology, which forms the basis for our DuraSeal, which is used for preventing CSF leaks during brain surgery or spine surgery applications and sealing the dura. And more recently, with the acquisition of SIA, a polydioxanone or PDO platform that forms the basis for synthetic reinforcement and reconstruction applications using this resorbable material. So where do these materials play? So regardless of the tissue target that we're trying to repair or regenerate, whether we're talking about burns, nerve regeneration, reconstruction, tissue reinforcement, there's some basic tenets that we think about from an engineering perspective. So when I implant these matrices, these three-dimensional, say, collagen matrices, the one question we have is, how does it interact with the local environment? What is the immune modulation aspects of that? What is that reaction? And are there ways to help modulate that to become more beneficial and integrate with the host tissue? We do rely on the host cells to be able to integrate and repopulate that defect, that repair site, or being able to integrate and reinforce. So having cells recognize the biochemistry of that material and being able to move into that material is essential. Once the cells are there, residing, producing new tissue, obviously we want to keep that integrated construct alive during the lifetime of that tissue. So revascularization is a critical component. And again, engineering a substrate to be able to get the appropriate pore size and porosity is essential. And then probably the more underappreciated aspect of, let's say, regenerative medicine and tissue engineering is really what happens to these substrates over a period of time. And that really drives towards tissue remodeling. So while oftentimes we focus on the near-term outcomes, for this tissue, it's a living tissue, it's constantly remodeling. What is the quality and the functional aspects of that tissue? And gathering that data becomes an important consideration in how we can do better in providing these substrates for clinical application. So this is a very basic slide of host biomaterial interaction. So as I mentioned, these are acellular materials. So you are relying on the patient or the host cells to integrate and allow that activity to happen. So as you see here from the very left, how cells interact, attaching. Once they attach, how do they migrate? Because migrate helps to repopulate that three-dimensional matrix to allow to fill that defect or the area of interest. How the cells proliferate, differentiation depending on the progenitor cell population that is encumbered within the matrix, and the deposition of that new tissue extracellular matrix, and how that interacts and remodels with the substrate. So, as I mentioned, with the acellular dermal matrix, the focus for today is SurgiMend PRS and SurgiMend PRS Mesh, which is pictured here. You can see the fenestrated version, and then on the right here, a mesh version. With the intent here is to provide clinical utility, that is options for the surgeon to be able to use these in the appropriate manner to not only support for reinforcement, but again, for the clinical utility and hopefully for integration with the host tissue. The SurgiMend source material, so this is derived from fetal bovine dermis. So this is controlled source material. We look to limit the waste of this tissue, so that's part of our environmental assessment on procuring this tissue. But once we procure this tissue, it's really about preserving that natural architecture, and that's where processing becomes an important parameter, which I'll describe in the next slide. From a biochemistry perspective, it is predominantly type 1 collagen, which is expected, but there is also a fraction of type 3 collagen, and because of that, it's due to the fetal nature of this, the young nature of this material or this tissue that provides that type 3 component. As the tissue ages, it predominantly becomes type 1 in conversion. But probably the biggest attribute of the fetal bovine dermis is the strength considerations, the physical characteristics. Am I able to process it in such a way that retains the desired properties of tissue strength, tissue handling, conformability, can I take those attributes and provide utility in a variety of sizes or thicknesses? And tissue consistency is essential as we are deriving from a natural material. So we have to ensure that we're getting a consistent material to be able to deliver a consistent product. I mentioned processing is an important parameter. And so there's nothing novel, although we have a patented process that we use to take this bovine skin material, we deflesh it, removing the epidermis and the hair components, removing the subcutaneous components, and then going through a series of washes to remove cellular material, lipids, carbohydrates, and other components or other non-collagenous components. And so really what you're left with is a dermal template with the goal to preserve that structure that will preserve, again, preserve the mechanical characteristics that we desire. Obviously, as part of a safety profile, when you submit this to regulatory agencies, you need to establish that your process is able to inactivate any residual viruses or microbes that could be in the tissue, and certainly with ethylene oxide sterilization, achieving that 10 to the -6 sterility insurance, which is a common threshold for medical devices. I mentioned strength. That is a key component of the SurgiMend family of products. As we think about reinforcement, the forces that it needs to be able to withhold during a time of application, certainly breast reconstruction, if you're wrapping structures, the implant structure, and securing this to the other soft tissue elements, whether that's muscle or skin flap, you need to be able to have something that withstands those forces initially, but also during the period of postoperative of healing. So what you see here in the study by Edelman et al. Was again looking at the properties of this bovine ADM, SurgiMend in this case, of different thicknesses against a porcine material. And what they found was that the bovine material did indeed have significantly higher tensile strength and retention strength properties than the porcine ADM. So what that tells us is the structure matters, where you source this material from, the organization of the collagen fibers that would lead to those mechanical properties. And certainly another component is how you process these materials. As I mentioned, the more harsh your process, you likely will lose some of the properties of the original tissue. So it is very much a balancing act. It's that versatility, is that strength properties, as I mentioned, and the way we process it, that provides the versatility in the configurations, whether it's fenestrated or meshed, as you see here. And this really is an important characteristic, because while strength is important, drapability, conformability, the ability to wrap structures or implant structures and provide a basis for wrapping these structures in a meaningful way and providing that clinical utility is a key hallmark of the SurgiMend PRS mesh. From a mechanism of action perspective, this is not atypical for any other three-dimensional substrate. So when you have an acellular material such as SurgiMend, you apply that into the area of interest to help reinforce or repair or reconstruct. It's that interface between the host tissue that really drives the action here. So once you get blood components in, you get host cells such as fibroblasts or other factors moving into that matrix, repopulating. That's what we mean by cellular repopulation. And it just doesn't mean the surface of the matrix, but certainly throughout the matrix, because the matrix won't be able to fundamentally integrate unless you have cellular repopulation throughout that matrix. And you can see here on the right-hand part of the graph, you can see the capillaries forming throughout the matrix. You can see the cellular deposition. In the lower right-hand corner, you can see that neovascularization occurring throughout the SurgiMend matrix. And that's at a focal point defect where a suture was placed. So extending that the analysis on the mechanism of action. So this is what the action during in an implant matrix of the SurgiMend matrix. And you can see here within a couple of weeks, you see the cells have completely infiltrated and you can see the dermal collagen fibers of the surgement that's shown in the pink here. That's your H&E stain. As you move into the middle micrograph, you see new blood vessel formation. So that's a key component, because as the cells are metabolically active, they need sustenance. So your structure needs to be able to support endothelial cell migration and microtubule formation of new vasculature. A key component that you see here on the right, what we call non-immunogenic. Really what that means is the way we process this material based on that and the output and the way we sterilize it, it does not elicit any detrimental inflammation response. Now, there's always some level of inflammation. Anytime you put a material into the body, the host is going to react to it, and you do need that to help kickstart that healing process, the integration process, to allow cells to move and want to move into this matrix. What you don't want to see is an untoward response where you see a detrimental inflammation response, where you see potentially large inflammatory infiltrate that could cause encapsulation of the material and a loss of integration, which ultimately would lead to a loss of the properties that you're looking for, which is reinforcement over a period of time. Taking that a little further into a preclinical sheep breast model. So, right off the bat, recognizing that it's very challenging to recapitulate what happens in the human condition with breast reconstruction in an animal model. But the sheep model has been one that has been validated and published on. So in this case, what we looked at was really, again, looking further at the question of the compatibility with the Surgman PRS in conjunction with a tissue expander. So that's what you see in implantation in the top left-hand corner. This is done at the aspect of the latissimus dorsi of the sheep. So this, obviously the mechanics are a little different from obviously what you see in the human condition, but it still allows us to look at that interface between the expander and the surgman, and being able to fill the volume at day 0 of the expander up to day 21, potentially up to, I think, 80% of the fill volume. Again, so you're looking at stress over a period of time against the surgman material. So what you see here histologically at day 28, if you go to the top right-hand corner, so if you follow this picture, you can see the letter S on the top of this micrograph. That's where the expander was. And then below that, that's the capsular interface of the soft tissue element. And then you can see below that with the green arrows, that's the integration interface with the surgman. You can see some of the residual surgman material there in the much deeper blue stain, which makes sense because that is more mature than the de novo new tissue that's being formed by the host. If you go to the lower right-hand corner, again, this is Mason's trichrome, a collagen stain. It's just easier to see the collagen in this type of stain. But you see on the superior side of this micrograph with the arrows, the solid arrows, you can see the integration of the surgman, the residual remnants of the surgman, integrating with the host tissue. And then you see below that on the inferior side of this micrograph, you can see the fibroblast infiltration. You can see the movement of these cells into that interface with the surgman, showing again that there's an integration. And you can also see vascularization with the solid arrow points. So what I've shown so far is the sourcing of the material, the mechanics of the material, and some preclinical efforts to understand compatibility, how it integrates with the host tissue. But certainly that information needs to be able to use, and how does that translate into a clinical setting? And so what I'm showing here is some work by Sheffland et al. Where we looked at a number of biopsies from 111 patients at the time of expander implant exchange. So, and what you can see here in the bottom is an image of, which is a representative image of the surgman, how it's integrated with the soft tissue, the host soft tissue. So this also, again, establishes what we observed preclinically in terms of integration with the host tissue. Again, you need to have full integration to be able to really see the benefits of the surgman in providing that reinforcement over a period of time. This work also really takes it to a deeper level with further biopsies. This is work by Gaster et al. And also looking at biopsies at the time of exchange over a period of anywhere from 2 to 23 months. What you're seeing here in the pictures is a 9-month post-implantation at time of exchange. And so starting from the very left, that's a H&E stain. And just to give you some direction as to what we're looking at, if you look at the deep pink fleshy material on the superior side on the right, that is your SurgiMend material, and you can see the integration of that newly organized tissue against the host tissue. So that's really what you want to be able to see is that integration to allow for that stable construct. We did not see a large inflammatory response. So again, this is in line with what we predicted based on our preclinical evidence. And we don't see evidence of contracture. And that's, again, because the mechanics of this tissue, the way it integrates really reduces that aspect. As you go to the middle micrograph, it's the same histology, but now with the immunostain, and you can see with the anti-bovine collagen stain that's shown in the green fluorescent, you can see the remnant SurgiMend there as integrated. As you go to the right micrograph, you can see with a CD31 stain to look at endothelial cell population, which again tells us that revascularization is occurring throughout this integrated construct. I want to thank you for your time. I know we're limited in this session, but please, if there's any questions after this, my contact information is here. And again, thank you for your time.
Thank you very much for this overview, Sunil. So now you have provided quite some backgrounds to help us understand how SurgiMend, how the technology behind SurgiMend can help make a difference for you and the audience, for your patients. Could you tell us a little bit more about the future? Are there any plans to develop new features, new products?
Yeah, thanks, Cedric. So the answer is yes. So we are looking at expanding in the short term the current configurations of SurgiMend with different size options. Again, what that does is provide then a utility for the surgeon, especially in larger aspects of breast reconstruction where a greater surface area is needed potentially. Beyond that, beyond those near-term opportunities, we're certainly looking at the future state of where breast reconstruction is going and what is the role of these ADM materials in that future state. So if we think about the treatment algorithm and whether it's autologous repair or thinking about implant-free breast reconstruction, this is an area of interest. And how does an ADM like SurgiMend, what role does that play in that future state? So that could mean an ADM like SurgiMend in combination with a biologic to help help having an implant-free or more biologic breast reconstruction. Obviously, that's a complex endeavor because it's not just the ADM alone, it's the ADM in combination with another technology or platform that probably brings that biological aspect to it. Now, there's other modalities that we're also looking at in conjunction with the treatment algorithm, such as fat grafting. We know the limitations of fat grafting today, depending on, regardless of how it's processed at the bedside. There's limitations in volume, its viability over a period of time, and retention of volume. So how does that usage with fat grafting in combination with ADM and can the ADM help with other modalities sustain that fat graft and work towards the end goal of a biological breast? So I think there's a lot of opportunity in regenerative medicine. And I think we have a number of platforms that we can bring together to help solve this problem.
Okay, thank you. So I know there are lots of questions in people's minds in the audience, some of them at least. To reassure everyone, we are, as a company, actively working on getting SurgiMend back to market, as some will know. So be reassured on that. Now, in your talk, you mentioned sustainability of repair, Sunil. that's another question we also hear quite a bit lately. What strategies is Integra Life Sciences working on to reduce the environmental impact and to promote sustainability in general?
Yeah, that's a great question. And we're not alone in this endeavor in environmental sustainability, very much social and governance, ESG. Integra is very much on board with this strategy. In fact, starting in 2022, we released our first ESG report that everybody could go onto our website and download and take a look at the efforts we're making. But specific to that question, Cedric, around sustainability, environmental impact, I'll start with animal sourcing. Obviously, we have porcine, we have bovine-derived tissues that make our products. So working with our supply chain on that end of the equation, limiting the amount of waste and making that more sustainable. So that's one aspect of it. In our medical products, now again, keeping in mind that these are single-use products, medical devices, and so when you think about packaging and you think about the associated paperwork, meeting the highest quality standards, so keeping that in mind, and so that's your minimum threshold to as a bar. But having said that, what is the supply chain with the renewables on materials? Reducing PFAS or forever chemicals is an initiative for us, is eliminating that from our supply chain with our components, because those materials, if they end up in the landfill, how do they degrade and how do they interact with the environment? From a manufacturing facility perspective, we're looking at that entire process, not just at the highest level with our facilities as we build new facilities, looking at ways for renewables, reducing aspects of power consumption, using solar paneling to help us become more environmentally conscious and reducing our carbon footprint. But also even things about sterilization. A number of our devices to go through ethylene oxide sterilization. So the EPA has put out standards, as well as authorities in Europe, around emissions of ethylene oxide. So we're working with our vendors to reduce those EO emissions. And so our product development team and our manufacturing team work closely with our vendors to be able to design new cycles that can meet the new standards. And then from a research and development perspective, I showed in this presentation, preclinical studies using animal models. But what we have done, certainly over the last several years within R&D, is look at more in vitro ex vivo models that can help provide us answers without having to necessarily always go to an animal model. Now, that's not just a directive from us internally. I think industry-wide, certainly our regulatory authorities are asking the same questions. So we're all working together to be able to develop those, look at alternative models to give us the answer. But again, keeping safety and efficacy in mind, which is ultimately what these products need to provide.
Okay, and I think that it was implicit in your answer, the state-of-the-art new facilities that are that have started actually already being built on the East Coast in the U.S. To sustain production in the best way are going to help naturally. So with that, I'd like to thank you very much, Sunil. I hope this talk has been enlightening for all of you listening in the audience. I'd like to thank you all for listening in. And of course, if you have any questions, Sunil kindly put his contact detail up on screen. You can naturally get in touch with your usual sales rep or visit the team that's present in Rome on the booth. So thank you very, very much again. Wishing you a great rest of your day.
Thank you, Cedric. Thank you, Sunil. We really enjoyed the presentation and the discussion. Thank you very much.
Thank you very much.
Thank you very much. Bye-bye.
Bye.
Okay, we will move on to the next session, session number 4, Enter the Cyberverse Innovations in Breast Technology. So I would like to invite the moderators and the president. I will just jump from the other side.
I think you're over there.
Huh? Yes. You're right.
She moved them.
Okay. Let's take a picture. Very nice.
No.
Cominciamo?
Yeah, you're the boss. Yeah.
We start? Ok.
Yeah.
Cominciamo? O aspettiamo che stanno rientrando? Cominciamo. Okay, good evening. It's truly a pleasure for me to introduce such an important and timely session concerning the use of technology in the field of breast reconstruction. And I will start by introducing the moderators who will join me. So Professor Perrotta and Dr. Pribaz. So I think that you can introduce the first speaker.
Okay, we're going to start the futuristic aspect of reconstruction. And the first speaker, Dr. Ahan, laser 3D technology to facilitate breast procedure planning.
Good afternoon. First of all, I would like to thank Fabio and Mark for kind invitation. It's a great pleasure and honor to be with you and to discuss about laser 3D technology to facilitate breast procedure planning. I have no conflict of interest, and the main question for every reconstructive surgeon is how to restore body and life and transform a desperate woman to a happy person, mother and wife. From surgical point of view, how to achieve good long-lasting results to match the size, shape, projection, and movement of the breast, and of course creating breast that feels and appears natural and even respond to weight changes. First of all, we should choose the best reconstructive option. That means autologous immediate reconstruction, where we just replace like for like. That's why Diep is a working horse in autologous breast reconstruction. We need well-vascularized tissue and knowledge of microsurgery, and successful rate nowadays is more than 99.6. That is numbers from Ljubljana. And very important, if we want to be fast and effective, we need two-team approach that shortens the overall surgery time below 4 hours, 3.5. In the situation where we have skin envelope present and important landmarks, we just fill the empty space. In the meantime, raise the flap from the abdomen and just exchange the fatty glandular tissue of the breast for very well vascularized tissue from the abdomen of the same volume, and performed so-called well-vascularized autoprosthesis, and in 3 hours restore feminine integrity with appropriate size, shape, volume, projection, and of course inframammary fold. And this is the result. You cannot even see what's the before and after, and you can recreate of breast of different sizes, shapes, ptotic breast, non-ptotic breast, and so on. But then the next very important question is how to optimize the breast reconstruction in patients desiring delayed breast reconstruction, where we have plenty of question marks about weight, volume, contour, projection, where's the right inframammary fold position, and location of the upper and lateral breast pole. So question of answer to answer, and how to avoid additional procedure, additional hospital stay, side effects, and costs. Here's after the first breast reconstruction, and then after 4 additional short surgical procedures, but still. And I entirely agree with Blondel, who was written in PRS in 2008, that recreating an aesthetically pleasing breast is a combination of good measurement, artistic insight, and the experience of the surgeon that are very abstract and ill-defined elements. And that's why many methods of measuring the breast and their clinical application are well described in the literature. Parameters of breast aesthetics, ideal anthropomorphic measurements. Then there's a lot of different stereological methods, geometrical methods, mathematical modeling method, which is quite complicated for surgeon. Nevertheless, three-dimensional techniques is superior to traditional anthropometric measuring in accuracy, precision, and reproducibility. That's why we start with 3D surface scanning in Ljubljana in 2009 and use laser 3D technology to facilitate planning in autologous breast reconstruction. We cooperate with the team from Faculty of Mechanical Engineering in that time, and 3D image of the remaining breast was taken according to the instruction of the plastic surgeon with 3D scanner by mechanical engineer and proceed by custom-made software for breast shape, modeling, and cast production. And according to the custom software, the new breast replica cast, which is a negative replica or mold of the breast, contralateral healthy breast, is initially produced with this big CNC machine from the wood, and then we put plastic inside, sterilize, and use in the operating theater. And in 2011, we published first series of our patient using this technique, which changed a lot, because today we just use Artec 3D EVA scanner and software mesh mixer, and we use also 3D printer called Ultimaker, and everything is done in the hospital. So 3D image of the remaining breast is now taken with Artec 3D EVA scanner and then produce or print the mold, which is used for markings and tissue shaping during surgery. And here's a short video clip. 3D scan and mold production is done by nurses with special education and also this computer work. Then we define key suture points or lines, it's better maybe, and use the Ultimaker printer in my office. And it costs €4 for the mold, which is a complete replica or copy of contralateral breast. On the day of surgery, this is preoperative markings, very simple. We just follow the mold and make a key suture points, marcation, inframammary fold position, and of course we rise a little bit up because of the suturing after the surgery. We use CT scan and Doppler assessment as well before the surgery to mark the perforators, and then continue our work with two-team approach. One is preparing the recipient vessel, mammary vessel, and the other just rise the flap. If the flap in delayed reconstruction is big, I always use more than one, or almost always use more than one single perforator. Then we just put the tissue into the mold. This is the transparent mold just to show you. Otherwise, we use the new one and just remove all the excessive tissue. Very easy. The perforators are on the central position, and then we perform some holding suture to preserve the shape of the flap. Now, in the side table, during the same time, the second team closed the abdominal wall. Then we mark the points, the key suture points. You can see the perforators in the central way, and this is exact copy of the contralateral breast without any mathematical method or any other discussion. So then we performed microsurgical procedure, and according to the key suture points, we just fixate to the thoracic wall on the proper place the new breast, which is again is a copy of the contralateral breast. Just final checking at the end. In less than 4 hours, we can make this result. Well vascularized tissue, very natural and complete symmetry with contralateral breast. This is the next day and months after. So my practice nowadays, if the healthy breast is nice shape and volume is good, and patient desires just one single surgery, I just performed 3D scan of the contralateral breast and performed delayed reconstruction in one single surgical procedure. We can achieve really good results and good symmetry in one single operation. If healthy breast is ptotic or large, we can propose our patient to perform mastopexy or breast reduction first, and then the scan a new breast and finally get a mold of the new shape of the breast and reproduce this new breast and make a result like you can see here. So breast reduction, then mold, and then reconstruction. If the healthy breast is small and empty, we can also suggest patient lipofilling or even breast augmentation, and then make scan the new breast, make a mold, and perform the reconstruction, and you can see the result. And we also use in bilateral cases, in delayed reconstruction on the left side and primary reconstruction on the right side. Again, with this mold, you can get a really nice result. Or even in bilateral mastectomy, where there are no opposite breast, you can scan the implant or just use from the database the molds of previous patient of the same body characteristic, as you can see here. And this is the result. So let's see the last 6 cases that I performed and analysis with Vectra XT 3D imaging system. Here I just performed reconstruction with the mold, and also in this case mastopexy first, then reconstruction. You can see almost the same symmetry. This is 10 days after surgery, and this is 3 weeks after surgery, breast reduction, then mold production and reconstruction. And again, here the opposite breast is nice. Just scan the breast, make a mold and breast reconstruction, and you can get immediate, very good result. So what's the advantages of 3D technology? You can objectively determine breast volume, shape, and contour, predict of key breast landmarks with the help of contralateral breast. It's easier, faster, and safer shaping of the flap because you can see the perforators all the time, and there's decrease the needs for secondary procedure. And I think this method is extremely helpful for young, less experienced reconstructive surgeon. So laser 3D modeling is a powerful tool enabling high quality performance. And we know that modern medicine today doesn't just aim for the survival of our patient, but also sets higher goals, a complete breast cancer treatment, restoring the best shape of the breast, as well as complete well-being of our patient. Thank you very much for your attention.
Congratulations. And is there any question?
Excellent results. I'm incredibly impressed with the results you achieve, as well as how much you focus on the aesthetics of reconstruction. My only question is, I noticed that none of these women have nipple-sparing mastectomies. Can you just comment on the acceptance or the rejection of nipple-sparing mastectomy at your institution?
No, more than 90% of our reconstruction is immediate reconstruction. I just show the procedure that I performed in delayed reconstruction because I think there's no need to use the mold for primary reconstruction because everything is there. The skin is, the landmarks are there. You just fill the empty space with the same amount of the tissue. But nowadays, because it's cost just €4, I use it also for immediate reconstruction just to see the position of the areola or where the area of the skin that it's not depithelialized.
Got it. Thank you.
Thank you.
These are beautiful results, and this is a great innovation that you're adding to our armamentarium. I've always, even in the head and neck where I do more, make models and things that really helps to do the reconstruction. And I think it's good that you continue doing it even on the unilateral because, you know, you can sort of try to shape it according to the opposite mastectomy, but to actually have something that you can, you know, moulage and model the flap inside is very good. My question is, you know, it's okay to get the skin island, the shape, but if you really don't have enough volume, do you also utilize a small implant in the middle to achieve volume correction at the time? And if you get such accurate representation, do you also do the nipple at the same time?
No nipple, no, not yet.
Okay.
But maybe we can do it, but it's simple outpatient procedure of 15 minutes. So it's maybe better to an additional tattooing as well. So maybe there's no need to do this. But I almost never use the implant if I go with autologous reconstruction. Just in maybe 2 cases after radiotherapy, when there is shrinkage of the soft tissue and flap, then I just add volume with, first I try with lipo filling, and if the result is not okay, then I put the implant, but in just few cases. But you can achieve a really good result even with this technique, of course. And it's maybe easier and faster comparing to lipofilling.
Is there anyone in the room that uses such a 3D laser for breast reconstruction planning?
Diep from the Netherlands. We use the same technique. My presentation, it's one of the next presentations. I will also focus a bit on it, but it's a great technique you use, and it's quite simple, not so expensive, and especially
nowadays, yes.
And then we also use it mainly in secondary cases to get the symmetry. And what we try more and more is also to include the nipple reconstruction within one operation, and to make a combination, just one reconstruction. But we also use the planning it for the contralateral breast if we make a reduction plasty, combined also with the free flap on the one side and also with the nipple reconstruction in one procedure.
So it really turns everything around that if you're doing just unilateral, you have to do something to the other breast. You do the operation of the other breast before you do the reconstruction to then make a moulage to,
yes.
Yeah. So it turns everything around.
Yeah.
Yeah. Interesting.
Okay, thank you.
Thank you.
Okay, now we introduce Professor Marco Innocenti from Bologna, and his presentation is robotic microsurgery to the rescue. Can super microsurgery be a daily practice? Please.
Thank you. Thanks to the President of the Congress for inviting me. And this is my disclosure. And my second disclosure is that I am not a breast surgeon. So in the history of surgery, we started from general surgery, then we have many other specialties. After that, we arrived to the microsurgery about 40 years ago. And now we are in the era of the super microsurgery. And this guy is responsible for almost all the innovation that we had in microsurgery in the past years. He inspired us very much. So this is a scientific paper which demonstrates that essential tremor come with age to everybody. You see the graphic here. So the maximum is about 60 years. So everybody is going to have this problem, which is normal. And so a device which can help could be welcome, I think. There have been many attempts with the biggest and most famous robotic platform in surgery, but this platform is too expensive, too big, and is not available, is not able to do microsurgery, real microsurgery. You can manage up to 80, no more. Since 1999, there has been several attempts in to design a platform specifically designed for microsurgery, and you see here a few examples: NASA, Tokyo University, Carnegie Mellon, but none of them entered the clinical scenario, so they were used only in an experimental setting. Nowadays, there are two systems with clinical experience which are currently available, and one is Musa, done in the Netherlands, and the other one is Simani, the platform about what I'm talking today. So like the microscope help the surgeon, help the eyes of the surgeon, the robot helps the hands of the surgeon, but doesn't replace the hand of the surgeon. This is the history of the adventure of MMI from 2015. It was founded in a garage, and then we did the animal study, the preclinical study, the animal study. We had the CE mark in 2019. I did the first free flaps in human in 2020. And then the platform now is has several platforms in Europe And finally, only 3 weeks ago, MMI got the FDA approval in US. So this is the group now, and this is a beautiful small town, which is Calci, where the MMI was founded. The attractive thing of this platform compared to other is that you move your hands very naturally, so it's very intuitive, and it's very easy to learn how to use it. This is the platform. You have one outside, so if you want, you can try it. And there is a console, there is a chart, and the robotic arms. There is a possibility to scale up to 20 times, and there is absolute elimination of tremor. We had a long preclinical study. You see here listed almost all the tasks we did. And the conclusion was encouraging. So we moved to the animal study, and it was a very simple format of study. The same experienced microsurgeon did a manual anastomosis on one side and robotic anastomosis on the other side of the rat. And then we compared the result after 3 weeks. An interesting thing is that because everybody is asking how long is the learning curve, we calculated this, and it is within 5 anastomosis, you are perfectly able to use the platform. Just a few cases. This is the very first one I did, July 2020. It was an ALT flap for a foot reconstruction. And this is the second case. I did the following day because we wanted to test the possibility to use the platform also in more difficult anatomical area like the neck. So we did this pharynx reconstruction. And nowadays there are more than 800 cases done in Europe by several centers, and you see that almost all the free flaps has been done, but also lymphatic surgery, nerve captation, and a small percentage of urologic indication. This is a case of mine, a professional climber with the frostbite both feet. So we did 2 ALT flaps the same day to repair the defect in the foot. And we have an international register, so all what we do during the surgery is recorded, and it is available to everybody who is using the platform. And this is the end-to-side anastomosis. We can do easily end-to-side anastomosis. We can use also the coupler with the robot. The setup is very beneficial to have an endoscope, a 3D system, which allows the main surgeon to stay in the middle of the room, and the assistant is in the better position in the microscope. I'm not a lymphedema guy, but I did a few cases, and for lymphedema, for sure, this is the best, absolutely the best indication, because it's very, very easy. It's fun to do surgery with this platform. Advancement in the knowledge of anatomy push the border farther on, and so nowadays we are in the time of the perforated flap, and with a robotic device like Simani, maybe we can change the paradigm and try to move to perforator to perforator as a routine. And this will have a big advantage in order to be less invasive and even faster at the end. So everybody knows the concept of the perforator to perforator. The theoretical concept is very easy. It's less easy to do the anastomosis in 0.4, 0.5 millimeter vessel. This is a case I did, and it is a perforator to perforator ALT flap for foot reconstruction. This is another one I did more recently, is a freestyle perforator. I found a small perforator raising from the ulnar artery, and so we did a small flap perforator to perforator in the 5th metacarpal area. And this is, I think, the most interesting innovation done by our German champion, Maximilian Kuchenhaus, who did, I think, for you, who are a breast surgeon, a very, very interesting and promising experience. You will see the real presentation tomorrow. So I just introduce him because I think that he did really a great job doing the perforator to perforator Diep flap. He's also using, it's very technological. He's using this new type of microscope, which is quite interesting. And you see the assistant and Max is in the middle of the room, even not scrubbed in. And so the operating field is in the hand of the assistant, which is in the best position. This is an example. You will see more cases tomorrow. I invite you to see his presentation. The concept is simple, and I think it was quite brave to use this technique in such a big flap like the Diep flap, because you have no return if something is wrong. But he will explain to you much better than me tomorrow. And so this is a detail of the anastomosis with Simani. And this is one case. We are doing a post-market clinical study. Involves 8 centers in Europe. So we are comparing our experience in different fields of application, and we mix all the data in a database which is run by the company. So there are some endpoints. The primary endpoints is very humble, just the ability to complete the surgical task with Simani as intended by the surgeon. And then you see that according to the different tasks, free flaps, lymphatic replantation, we have different endpoints. But what is, in my opinion, more interesting is the possible of increase the field of application of the platform, because nowadays it is only a very sophisticated anastomotic device. But we would like to expand the application of the platform, and you will see in which direction we are moving. First of all, there is a continual improvement in the design of the device. This is, we already have the micro and super micro instrument set. All them are disposable, but you see that we improve the quality of the design. For example, the generation 1 super micro had some parallel slot which obliged the needle to be in a fixed position at 90 degrees with the needle holder, but with these pyramids, so you have more freedom. And okay, this is anastomosis. The other thing is we are developing a scissor, and you see this is in an animal study, of course, and they are working quite well. They must be refined. And finally, the monopolar, which is my favorite, is really a fascinating instrument, very precise. You can do even the appendicectomy because it's very low energy, and it's very, very easy and fun to use. You can cut the vessel. Okay, then we have a digital workstation in order to integrate all the data all together. So in conclusion, I think that these are the conclusions. You can read it. High precision is reproducible, enables for super microsurgery. We can do perforator to perforator. We can do lymphatics. The learning curve is fast. And this can improve the ergonomics and also can extend the career of experienced microsurgeon. And this, in my opinion, could be the future of some part of the microsurgery. Thank you very much for your attention.
Marco, it's great innovation, and I just wondered how the surgeon working the robot is remote from the operative field. the interaction with the assistant. And do you have issues and problems that what if the assistant has a tremor? But I mean, is there a problem in working between the two of you?
No.
Okay.
Actually, there's no problem. Also because the assistant is quite happy because he's in the best position. Usually the assistant is not as comfortable as the main surgeon, but in this case, the operating table is for the assistant. So it's easier. And I think that the assistant is important. I always do also the conventional microsurgery with the assistant. I think if you have, you must use it. In this case, for example, the assistant is useful in making those adjustments, for example, with the clamp that is done easier by hand, or even retrieving the line because the workspace of the robot is limited, so you cannot do like this. By hand, you can do it. So there are some tricks. And so there is a very good integration between the manual assistant and the robotic main surgeon.
And the other question, does this you don't use venous couplers anymore for veins? Everything is sutured primarily?
We try to use the coupler just to test. And we can use, it's easy to use with the robot. In my new institution, we don't have coupler, so we do by regular suture, but it can be used the coupler as well.
Yeah.
Really exciting technology. In March of this year, Da Vinci Robot announced the D5 with integration of haptic feedback. So you can actually feel tension and the suture and everything. Any plans to add haptic feedback? It's kind of like that final piece that we need to operate.
This is the most frequent question. So I know how to answer. And I answer with an experiment done by a French, Liverneau, who has been working in Strasbourg in the big experimental center. And everybody was asking, it was trained with the Da Vinci, okay? Everybody was asking about haptic sensation and so on. And he did this experiment. 10 experienced microsurgeon with a small suture, 11-0, I think. They were asked to make the note and tight the note, closing the eyes. 8 out of 10 broke the line. That means that it's a visual sensation. It's not really manual, because if you are an experienced microsurgeon, you know very well when the note is tight and when you break your line, you know it. So this is the answer. I don't think that it's worthwhile to work on this direction. I don't understand intuitive.
Finish.
The next speaker is Dr. Ulrich, Seeing is Believing, Augmented Reality as a Guide in DIEP Flap Elevation.
Yeah, thank you very much, dear Chairman Fabio and Mark. Thank you very much for inviting me. It's a great pleasure here to stay here in Rome and to be here in Rome. I have no disclosures. And when walking to a sightseeing trip here in Rome, you can also use augmented reality. It's very popular. It's getting more and more popular. If you go to a new city, you can see all the buildings, giving some explanations also about the buildings. And even if you want to have a new furniture for IKEA, you can also use augmented reality. And it works very well. And since around about 10 years, we are working in my department with the use of augmented reality for the planning of free tissue transfer for the deep inferior epigastric artery perforator flap. And for us, for the operative planning, we already heard from the first speaker some issues also to get a very nice result. And for our planning, we want to know the size and the match of the healthy breast. We wanted to know the shape of the breast to get reconstructed, but we want also to know where are the best perforators located in our free flap planning. And what we did in our department, we worked together with a medical engineer and also with a technical university in the Netherlands, and we developed an anatomy projector. It's a two-dimensional projector comparable to a very small beamer with a projection of the blood vessels we wanted to know for the free flap breast reconstruction. What you see here is the workflow. I will show you the different procedures here. And we started with a preoperative medical imaging with a CT scan in the patients. And afterwards, our medical engineer in the very beginning was creating a surgical planning here with a virtual plan. And now we try to establish it with using artificial intelligence. The computer is doing the planning preoperatively in our patients. Here you see the patient-specific 3D plannings in the patient. What you see here, the red perforators marked are our favorite perforators. The yellow ones are the less used perforators. We can see where our pedicle starts with an intramuscular projection also here. We can see everything here with the planning, but it's not on the patient at that moment. What we do is we can make the projection on the patient with our device. This is here. We use 4 QR marks for the system that you can see where the projection should be. This is here. It's very easy. It took 2 seconds to fix the QR codes for the system and to make the projection on the abdominal wall of the patient. Here you can see it. It's very easy. You can mark it before patient is asleep at the operation theater. Just make the projection. You know perfectly where your perforators are located. And this is the end result of the projection of the surgical planning in the patient. And we did a lot of work on this, a lot of papers we've written about it. And what we see is that the perforators really matched with the indicated locations intraoperatively here in our patients. And we started more and more also with advanced planning for lymph node transfer included in our flaps. We can perform before the projection of our lymph nodes we wanted to use also here in the patients, that we know perfectly where the location of the lymph nodes is also. What we can also do it, we use it more and more also in stacked flap surgery. We can plan both flaps also with in combination with the CT scan. Also, we try to analyze the volume also, what we can project here. You can see it here. This is for a stacked conjoint flap in a patient. What you see here is the volume of one patient also from one flap and from the other flap on the other side also. Here you can make the calculation of the volume of the flap you wanted to use in the patient. And this is the projection preoperatively for the patient. Here you see a short movie, how we are working together with the preoperative planning also with 3D molds. You have seen it also with our first presentation here. And what we do is preoperatively, we do the projection of the blood vessels with the CT scan on the abdominal wall. You see also the 4 QR codes in our patient. Then we calculated the breast shape and the volume also with the mirroring. It's compared to the first technique we heard today. Then we create a digital breast mold in the patient. You've already heard the costs of the mold is around about €5. And you start with this 3D print at night, and then the next morning you've got the mold for the patient. And in this way, we think you get more symmetry and less corrections also necessary in the patient. And we think this was really the next step in the free flap breast reconstruction. And the next step in our unit was to combine all these projections, the technique of CT scans before, to get it more easy, that not in every patient a CT scan is necessary. And we try to combine our system with a dynamic infrared tomography, with a DIRT system. And what you see here is the projection with the anatomy projector from outside to the patient using a cold package here. And what you see here is the beginning. This is the cold package to get a reduction of the temperature, and it's for 30 seconds. Afterwards, you see with the DIRT, the hot spots here where the perforators are coming from the inside also, and the temperature is getting warmer here from the outside. This is a kind of projected augmented reality using the DIRT system here. Here you see the first two perforators, and if you afterwards make verification with a Doppler also here, you really see the perforators at these hot spots here. And this is for us the next step in projected augmented reality in the patient. And also the next step for us is to use an augmented reality using a HoloLens. You can see here, this is also another example for preoperative planning in the patient. From the Microsoft HoloLens, you can buy these augmented reality brill also from other companies. We use it from Microsoft here. And what we do is to get a fixation, to get a fixed point of the perforators, we use abdominal navi as a natural skin landmark. And before we make the planning, we get an image here with the CT scan, and you get these landmarks then from the outside. And then we do a segmentation here before performed by our medical engineer also. And here you see the projection on the patient. If you look through the HoloLens application, you see this menu. And there's also a landmark registration. You see it in a short movie here afterwards. And this is, you can see here perfectly where the perforator is located, and where it's inside the muscle, outside the muscle, where the nerves are you want to preserve. And this is the movie here coming, hopefully. This is looking through the HoloLens brill. This is performed by a resident from our department. You've got the QR code here with the fixed point of the registration navy. This is a projection then of the muscle and the blood vessels and the nerves. Then the resident is marking it before doing the operation. And I really think that this will be the next step. As a plastic surgeon, for me, it's a great pleasure, and really to work together with medical engineers that will make our life easier also in the future. And I think the future, it's really fascinating. We are inside the future, and thank you very much for your attention.
Hi. Hi.
Yes.
Santanelli from Rome.
Ulrich from Nijmegen.
Nice to meet you. So compliments, Dietmar. Since the first time I visit you in your unit, you have developed this system a lot. First time we had the PhD dissertation, it was very interesting, and I approve it as a recent modern advance. My question is, in deep flap transfer, probably you share with me the idea that the most important is the vein perforator more than the artery perforator itself. And not always the vein is comparable to the artery. Sometimes you have a big artery, small veins. And so how can you quantize the vein perforator, the outflow? Because probably you can do it with the artery, the one that starts first after cooling, or the one with larger spot. But is there any trick to understand the vein side? That is, thank you.
I think your question is about the dirt. What you mean, the projection of the hot spots I've shown here. It's not for the venous system, but for the whole planning. What we always do, or what I always do, is just to take it to also include the emergency vein. We've got the second vein then, but it's not about the selection at that moment. There's no way to find the best vein with these techniques. So.
Yes. Demiri from Greece. Congratulations, Dietmar. I would like to ask you, you said that sometimes you can also visualize the lymph nodes.
Yes.
So you can harvest them together with the Diep. How can this system visualize? I mean, through the CT?
Through the CT. It's through the, you market the engineer, or hopefully in 1 year or 2 years, it really works automatically with using artificial intelligence, that the system will learn it, and it's from the CT scan. You use the CT scan and you mark the lymph nodes then, and it's just to get an idea for you as a surgeon, where are the lymph nodes localized if you include a lymph node flap.
But you don't differentiate lymph nodes from the sentinel ones, etc.
No.
Just the lymph nodes
no,
of
at
the
that
groin
moment,
area.
no. It might be the future anyway.
Okay.
It might be the future.
Okay.
Let me tell you a secret. The point is that in their unit, they have the engineer going in the round together with them. And the medical engineer, which is not the doctor, is the medical engineer, is scrubbing in the procedure with them. So that's a terrific advance that they have. And of course, that can help in doing any innovation.
And I think sorry, Fabio, but I think really the real future will be not to be that you're not depending as a plastic surgeon from these kind of medical devices. I strongly believe it, that your iPhone or another phone in the future, you will use it using some extra software or something like this. It doesn't matter what it will be, but this will be the future. It will be much cheaper for everybody also to use it. I strongly believe this.
Any question? Thank you very much. Very interesting.
So, Dr. Momeni, this presentation is spatial fidelity of microvascular perforating vessel as perceived by augmented reality virtual projection. Please.
Hello again. I took the liberty to simplify the title of the talk. It is obviously a very tough act to follow. The speakers were outstanding presentations. And one of my mentors in the past told me that you learn through repetition. So some of this is going to be repetition, and some of this is going to be a follow-up on what the discussion just was, because I think the future is now using your smart devices, but I'll talk about that in a second. These are my disclosures. None of these are relevant to what I'm going to present right now. We talked about this morning, about the history of our specialty, and 70s, 80s, talked about flap survival. In the 90s, the landmark studies and pioneering work really of Kushima, of Phil Blondale, of Bob Allen Sr., Mustafa Hamdi, and the like, where we focused on reduction of donor site morbidity and focusing on perforator-based flap transfers, and in the extremity reconstruction, Marco Innocenti and others. And what we then realized in the 2000s was that it was actually going to be helpful for us to know the perforator anatomy. Muscle anatomy, you don't need to get specific imaging for, but perforator anatomy, it actually would be helpful for you to know before you make an incision what the vessels are going to be like when you go in. And so Masia published this landmark article leveraging CTA technology to preoperatively plan DIEP flap reconstruction. And obviously there's been numerous publications since talking about the value of preoperative perforator imaging and mapping. Why is it relevant to know the perforator anatomy beforehand? Well, for one, because there is tremendous heterogeneity, not only between individuals, but also between the hemiabdomen. From one side of the abdomen to the other, the perforator anatomy can be vastly different. So if you a priori have information regarding the number, the size, the location, and the course of those perforators, it will facilitate the operation. An experienced microsurgeon will not need this information. The novice certainly will benefit from it, but even when you're experienced, you can just move through the operation faster and with tremendously more confidence. So what are the options for perforator mapping as we have it available today? We have ultrasound-based approaches, something as rudimentary as Doppler. We have duplex, both of which are operator dependent, which is at times a problem. You have CT angios and MR angios, and then it becomes kind of the preference of the institution, which one you take. And when you think about what are the ideal characteristics of a modality to map perforators, you want to make sure that that is operator independent. And so that excludes pretty much the ultrasound-based approaches. You want to be able to secondarily post hoc review those images. So distinctly timely different from the day that the imaging was obtained. You want it to be time efficient. You want it to be cost effective. Those are ideal characteristics. And when you punch in all those variables into the equation, at least in our institution, CT angio has emerged as the ideal modality to map perforators preoperatively for a variety of reasons. Now, the challenge with these images is that it is a 2D representation of a three-dimensional structure. When Urosh or I or any of the other experienced microsurgeons look at this, they can immediately extrapolate this information onto the patient's abdomen. A trainee or a novice surgeon, probably not. So the question was then justified, how can visualization of this information and interpretation thereof be improved? And one way to do it is you cheat. You take the CT angio data and you feed it into a 3D printer and you print out the patient's anatomy. You basically give the residents and fellows a cheat sheet before you even go to the operative room. And so I started getting these scaled one-to-one scale. Every patient has individual anatomy and every patient got this 3D model preoperatively. And so what it allowed you to do is to grasp the patient's anatomy before you even make a skin incision. And so that obviously is tremendously beneficial from an educational perspective because the trainees are able then to look at the CT angio and correlate it with what the positive result is, namely the 3D printout. So we now know that perforator mapping reduces operative time, reduces complications in some articles, and multiple modalities are available. And I also demonstrated that we transition to routinely printing out these models, and printing out these models is very, very cheap. So the next step is to follow up and do what Dietmar just talked about, which is leveraging HoloLens technology and going into the virtual space. Admittedly, at some point, I also run out of space for these 3D models, so you got to find something that is more efficient. Before you go into the virtual space, if you will, you got to make sure that you have high fidelity of these 3D holograms. And in order to do that, we actually have to establish it. So we have to rigorously study it. And in order to do this, we projected the 3D hologram on its corresponding 3D model, manually aligned it using voice command, and then we took a optically sensed needle probe, pointed to distinct anatomic locations on the 3D model, and then removed the model, brought in the hologram, and did the same thing to look at the fidelity and the accuracy of this. And we found that there was really minimal error in translation, rotation, and scale. And so the conclusion is, in layman's terms, the hologram is as reliable and as accurate as the actual printout model. So you really don't need the printout model. So that we were able to establish. So what is the workflow now, and how can we leverage this clinically, not only preoperatively, but actually intraoperatively? And this is live surgery. This is basically the patient in the operating room. So we basically take the holographic image, we project it onto the patient. You can drag and drop this onto the patient. You have the umbo, you have the skin surface, so you have multiple points that you can align this, and then you just connect the dots. You can outline the entire vascular tree in a matter of seconds, and you have your template of where the vessels are going to be. So once we did this, we wanted to make sure that it's actually accurate. And so, well, the first time I will also tell you that when you take this into the operating room, the nurses are somewhat alienated because you put this HoloLens on and they think that you want to launch a space shuttle. But there's actually a purpose to this. And this was part of the study where we wanted to demonstrate that it is actually clinically also as accurate as the 3D model. Now, what this tells you is not only where the perforator exits the rectus sheath, that is simple. You don't really need imaging for that. The true value of this technology is it tells you what's happening underneath the anterior rectus sheath, whether the vessel goes medially or laterally. Can you just drop the blade down, or do you have to slow down? This information is much more valuable, in my opinion, because you know exactly what the intra and submuscular course is rather than what's happening above the fascia. Above the fascia, you see easily. That's not the problem. And so then we wanted to compare, how does this technology compare to Doppler? And in order to do that, the study design was such that we checked the Doppler signals on the abdominal wall and then traced the holodeep markings on the abdomen, compared the two, and then confirmed the locations intraoperatively. And what we were able to demonstrate is that using HoloLens technology, you were substantially faster at identifying the perforator locations, and it was substantially and significantly more accurate. So the margin of error was actually reduced using the HoloLens. Now, what are the next steps? What do you do from here? Am I advocating that we should all go to Microsoft or Apple and buy those devices? I wish I had the conflict. I don't. And that's not what I'm advocating here. But one area where it's tremendously beneficial is in the realm of education. This is, on the left side is me, on the right side is one of my trainees. And when you prep for surgery, these are all real patient CT angio holograms, and you can actually have pre-op conference in 2 remote areas, and you can discuss the operation pre-operatively. What is the benefit? Is this just a gimmick? I don't think so. We came up with the idea during the pandemic where we couldn't congregate. But the real benefit of this is also that it fosters engagement. We're dealing with a new generation of trainees, and the days are over where they love spending time in a library and reading books. So if you have novel approaches for them to be engaged in training, this is one of them. And then you can outline the perforator that you want to harvest the next day and push it into the field, that it can actually then take screenshots of it, so they have the plan outlined, leveraging existing technology. And this is all online, and you have voice command, and it's actually a lot of fun. But what is the next step? And we already talked about this in the discussion preceding this talk, is how can you use this ubiquitously? And what we all have, I think, in this room, unless I'm mistaken, I didn't see anybody today with a flip phone. We all have iPhones, iPads, Android smart devices. You can leverage those today to actually project the image onto the patient. And this is using an iPad, and you can actually take the iPad into the OR with you. So you can just put the iPad, sterile cover. You can use the QR code of a Vicryl suture pack, and that will connect it to the CT angio data, project the image onto the patient. We're still working out minor kinks, but I genuinely agree with Dietmar on this, that this is going to be the future. You just pull out your phone. It's going to be a USDZ file, and you project the image onto the patient without any elaborate technological devices. And so in summary, leveraging the existing technologies allows you for a very expeditious DIA perforator mapping. We're working on other models such as ALT flaps and the like, where you have greater degree of vascular anatomy variations. It demonstrates the entirety of the vascular course. It is operator independent, which I think is important, and is very easy to implement because you already have the source data. You already have your CT angio data. All it takes is implementation thereof. And with that, I would like to thank you very much.
Thank you. I really enjoyed that presentation. I love the CTA for the deep flap because it just gives you the roadmap. And I like the way you did the 3D model. Is it possible, because for me, picking the perforator is always about the one that connects to the superficial venous system. You might have a great perforator, but it doesn't connect to the superficial venous system. Is there a way to model that with this technology?
I'm sure it is. The reality is that not all of them actually connect to the superficial venous
Right, that's
system,
I want to pick the one that
right?
does.
But you can see a very dominant perforator, and when you then scroll on the actual screen, you can then mark the perforator that does connect, because there's just a handful of those on.
You can see it on a CT if you do the sagittal cuts.
Correct. Correct.
So if there was a way to map that, that would be really
ingenious. I mean, I think technologically it's possible. We just haven't done it yet.
Great. Thank you.
Yeah.
Great, Arash. You double check with the Doppler afterwards, always, or not anymore?
No, I don't anymore.
Okay.
The study was just to demonstrate the comparative analysis, but after we were able to establish that it is more accurate and faster, then we don't do it. We still have a Doppler on the field just in case, but I rarely use it.
If you would, so coming back to his point, that you would listen or hear a vein, but not on the Doppler you would like to do, what would you do? Because if you hear the vein, you can't be quite sure that there is at least a good outflow.
So let me help understand the question.
You pick up your dominant
Yeah.
perforator, and then you double check with your Doppler.
Yeah.
But you hear a vein parallel to another not dominant perforator, giving you the indication that it might be a very good outflow there, but a better inflow somewhere else.
Yeah, I probably would then capture both vessels.
Arash, it's probably been answered, but does this help you in selecting the best perforator, this technology, as it is, or does it need further refinement?
It doesn't help you select the best perforator beyond what the CT angio does for me, right? It helps with the topography of the perforator, particularly for the trainee. So just case example, you do a bilateral and you leave the trainee to harvest the other side. You can leave them and leave the surgical site with a higher degree of confidence that they're not going to cut the perforator because they know topographically where it is. Because when the trainees look at the regular CT slices, I have found that they have difficulty aligning what they see on screen with where it is really inferiorly on the patient. But we have these 3D model sessions and we basically know which perforator we take, and then you project it onto the patient to have a green circle around it, so it's pretty easy.
And the other thing experimentally, the Taylor's angiosome concept, can this validate the angiosome concept and the, when you have multiple perforators, will this technique be able to kind of, even in the peripheral type surgery, to pick the perforator that's going to you'll be able to raise a pedicle flap to transfer as a perforator type flap?
I think that's going to be a tough one because the quality of this imaging modality is only as good as the underlying protocol of the CT angio. And we all know that CT angios are not like a CTA is not a CTA is not a CTA. It really is. There is some skill involved from a radiology perspective, which is why we have not been able to leverage MR angiography. But at any point in time, it is really a still image. It is not really a dynamic modality. And if you want to look at gradual perfusion differences, I think then you look at ICG imaging, intraoperative measurements and the like to make sure that your fat necrosis rate goes down and that you can actually establish how much volume of flap can you carry on any given vessels.
How many uses CT angio before Diep flap for planning in the room? And how many don't?
All right.
Professor Santanelli, would you like to share some thoughts about CT angio before Diep? No. It's okay.
All right. Okay. Thank you for going easy.
Yeah.
So we can...
Okay, our last presenter, Dr. Ray, Artificial Intelligence and Predictive Analytics for Breast Augmentation of Tomorrow.
Buonasera. Thank you, Fabio and Mark, for the invitation to come to speak here in Rome. It's an honor to be here. I have nothing to disclose, but I am going to talk about some mobile technology that we're currently developing. Oh, the bottom gets cut off here. As the father of artificial intelligence, Turing said about 75 years ago, a machine would deserve to be called intelligent if it could deceive us into believing that it was human. And I would argue that we're there. I mean, AI is writing poetry, it's driving cars, it's creating content, text, video, audio in ways that are convincingly human. So to remind you, artificial intelligence is a program that accepts input, accepts data, and then learns and adapts from that. And at its core are layered convolutional neural networks. So these neural networks have an input, they have an output, and all the magic really happens in these so-called hidden layers. And what's really interesting is that neural networks are modeled after and mimic the way pattern recognition occurs in neurons in the brain. So how is AI being used currently in medicine? There's actually a pretty broad representation if you look at all kinds of fields, even outside of surgery, in how AI is being used today. In diagnosis and prognostication, AI is very good at recognizing patterns, even very subtle patterns in images and text. And so early adopters were pathologists, radiologists who were using AI to make diagnoses. And as we've heard in the talks this afternoon, virtual planning and robotics rely pretty heavily on artificial intelligence. Generative AI, like ChatGPT, is already being used to answer patients' questions and act as a virtual scribe. There was actually a really interesting study that came out of University of California that showed when patients were blinded to who was answering their questions, the AI platform that they were using actually scored higher in compassion, empathy, and in knowledgeability compared to their human cohorts. So, and of course, AI is a very powerful research tool. So if we look to the literature, the last 100 publications or so on the combined topics of breast reconstruction and artificial intelligence, we go back about 10 years. Of course, early on, as I said, imaging was one of the hot topics, since AI is very good at recognizing patterns, also very good in prognosticating and diagnosing. But more recently, we see papers coming out on generative AI, virtual planning, AR, VR, as we've heard about today, and also a bit about ethics and technology. So we've heard some great talks today, and we've seen a lot of representation of how AI and some of the work that's coming out from groups around the world is really broadly applicable in many ways to what we do in breast reconstruction. So I want to share with you an example, and this is using generative AI, just one subset of what artificial intelligence is, and how far we've come in just the last year. So I'm going to show you a clip here. This is actually a series of clips that were created about a year ago, and these were posted. This was shared with me by Steve Williams, our current ASPS president. And this just kind of shows you where we were a year ago. So the AI was instructed to give us clips of Will Smith eating spaghetti. Seems appropriate for a meeting in Italy. It's kind of entertaining. It's cartoonish, not very realistic, maybe even a little disturbing. But this is where we are today. This is less than a year later, using a different generative AI platform to generate video. We see that the capabilities have really accelerated. So these neural networks are getting better and better at learning. Engineers are figuring out how to make these better. You can see photorealistic images and videos. You can see people who don't actually exist, places that don't actually exist that are created by these generative AI platforms. And my favorite is the last clip coming up here in a second. So, and again, all of this is kind of made up in the mind of the AI. A couple pirate ships fighting it out in a cup of coffee. Okay. All right, so this is impressive stuff. It's rapidly evolving. How can this help us build our practices and help our patients? So at our institution, we also perform gender-affirming surgery, and our first foray into artificial intelligence research was to build an algorithm that could recognize masculine versus feminine features. So, and this was to inform craniofacial surgery. So traditionally, if you were to do this, you'd have to take hundreds of scans of images. You'd have to take measurements, a very laborious and time-consuming task. And you wouldn't even really know if the measurements you were taking were necessarily the most useful. But using an AI platform, you can look at hundreds or even thousands of images, process them very quickly in a matter of minutes. You can take very thick image files. And if you're interested in surface anatomy, as we are, you can generate these surface meshes and point clouds, which take up much less memory to store and also are very useful for AI to analyze and learn from. And then you can generate these color gradients and overlay an image and figure out how to augment or change certain features to make them more masculine or feminine. And a tool like this is great for virtual planning, but it's also good as a teaching and quality control tool, looking at your before and after scans to learn from them. So the same idea can be applied to the chest, and we did this. We used a platform called Vitria to look at male and female chest to try to understand some of the subtleties of the difference in anatomy, and deep learning is, of course, ideal for looking at minor differences in muscle and bone structures. So, but CTs are invasive, they're time-consuming and expensive, and if you're really more interested in surface anatomy, you can switch to photography. And using this technology called photogrammetry, which we've heard a little bit about, you can take a series of images. You don't need any fancy equipment. You can use your phone. You can take a video, and you can then create these surface meshes just like we did for the face. So, and with these meshes, like I said, they don't take up a lot of real estate in terms of storage. You can still take surface measurements. You can get volumetric data. You can assess for symmetry. You can decide how you're going to fat graft or augment a patient. And building a very large database of these images is not difficult to do. So I'm going to take a step back for a minute because the story is incomplete without telling you about a clinical problem that we had that required an answer and how we ended up getting into this area. So as a busy reconstructive plastic surgeon, like many of you, I spent a lot of time trying to choose breast implants for patients, develop my own algorithms based on patient measurements and body characteristics, but it was very time consuming. So with a background in coding, I figured there's got to be a way to automate this process and then study our outcomes and figure out how we can make it better. And if you look to the literature, there's certainly no shortage of papers written on how to improve outcomes, how to increase predictability. But let's be honest, these are snapshots in time. These are written sometimes by single surgeons of their experience. These may not be as reproducible in everyone's hands. So we wrote a mobile application with the idea that we would use some of these formulaic approaches to breast reconstruction and try to come up with a predictive tool to help us select breast implants. In its sort of nascency and in its earliest form, certainly far from perfect at selecting the exact implant that a patient's going to need, but it was sort of a first step in that direction. So we continue to work on the algorithm, continue to build a graphic user interface that was user-friendly, and to our great fortune, at the same time, our institution established a Department of Computational Biomedicine, which is focused on AI research. So we developed a collaboration with them, and then we're able to come up with ways to apply deep learning to looking at surgeons' habits, looking at patient body measurements, and then look at our results to try to better understand how we can improve them. And, this is kind of moving away from the sort of clunky formulaic approach. And in terms of automating measurements and that kind of useful information for implant selection, of course, we turn to photogrammetry, as I just described. So what I'm describing here is a transition from a sort of analog approach using formulas to deep learning. And this learning comes not just from the photos and measurements, but also from surgeons' habits. The AI can go through our clinic notes, can compile data from questionnaires and use all this information to make us better surgeons. So at the end of the day, what we're all really trying to achieve is happy patients. And if we can make our results more predictable, we can set expectations and improve patient outcomes. So next steps, we're building a web-based portal that's going to collaboratively and crowdsource our data collection process. So on the last slide, I'm actually going to give you my contact information. We're looking for institutions to partner with in this endeavor. Without data, an AI is completely useless. So what I'm describing for you here today is an effort to build a platform that is ultimately has the goal of improving our patient-reported outcomes. I want to thank my collaborators and thank all of you for being here today. And if you scan this QR code, it'll give you my contact information. Happy to talk to you about how you can participate in this. Thank you.
Questions?
Professor.
If I'm allowed, thank you very much. Excellent presentation, but I want to answer to Stefan. I don't want to be impolite that you invited me for a comment before, so I said maybe I have to be nice with Stefan and give this comment. So I must confess, I will start using imaging for deep flap perforator, but after he starts. Maurice Nahabedian. When he starts, then I will change my attitude. Otherwise, I'm fine with it. Thank you.
Thank you.
Questions?
Another question.
Oh, okay. All right, thank you.
I have nothing to say because it's excellent presentation. I apologize. I just wanted to go back for a second. Thank you.
All right, thank you.
Finished.
So we can close this very interesting session and go on with the next.
So thank you. We go to the next session immediately, so we have a little bit more time for transfer to the dinner, which will depart the buses from here at 7:50 from the lobby. Thank you. Fabrizio and who else? Amy Colwell. There it is. She's coming. Great.
You want to introduce the session and then we introduce one each?
Okay,
Yes?
sure.
Okay.
An alternate. Sounds good.
You start the session.
All right, we're going to go ahead and move forward with the next session, which is going to be breast augmentation state of the art. I'm Amy Colwell from Boston.
And I am Fabrizio Schonauer from Italy, from Napoli.
And so we're going to go ahead and get started with the first presentation, Approach to Breast Augmentation in Constricted and Asymmetrical Breast by Dr. McCulley.
Thank you very much. And thanks again for the invite. This talk sort of split into two equal bits, really. A few principles over the last 2 to 3 decades of treating breast asymmetry, particularly with how it applies to implants. And then I'm going to talk about the tuberous breast and implants, and particularly avoiding periareolar scars, my pet dislike. I've got no disclosures. Now, whether it be mild or severe developmental asymmetry, constricted breast or chest wall asymmetries, we're faced with many difficult problems. And I suppose in a nutshell, those are my principles. If you want two breasts to look the same, make sure they're made of the same things. Otherwise, they won't look the same over time. Most patients often don't like the smaller breast and want the smaller one made bigger, but it's often better long-term to make the bigger one smaller, and it's often easier as well. And not surprisingly, like in reconstruction, autologous probably stands the test of time. And of course, we can all show lovely pictures of various mammoplasties and differential mammoplasties to help with breast asymmetry in suitable patients. And this lady over here does demonstrate the other principle, that if you put a small breast next to a small breast, it actually doesn't look quite as small. So, keeping this principle, if you want the breast to look the same, make sure the composition is the same. Now look, this lady's obviously got a severe encapsulation, and not all patients will get that at 10 years, but essentially I don't longer do this operation of a unilateral implant and autologous on the other side with asymmetry. I don't think it gives you long-term symmetry, and certainly doesn't stick with the principles. That lady went on and had multiple rounds of fat transfer, which sometimes works for me, but does take multiple stages. And even in the lower patient, she's actually gone up to the size she wants to be, and then she's had a mammoplasty, and now both breasts have got the same composition. So again, keeping up to that principle. Now, I will use differential implants, and I think if you've got small ptotic breasts, we've all got these, even in our standard augmentation practice, and that would be probably the one patient group where I'd accept a sort of 20 to 25% volume difference as a maximum, and that can give you good results. In a world of round implants, don't forget anatomical implants can be very helpful, particularly in constricted and difficult patients, and even in this, with an anatomical implant, you still can't really get the ideal result, but it would be worse with a round. And again, if I've got difference in breast sizes, I would tend to use exactly the same implant on both sides, and I would change whether it be with a mastopexy, a small reduction, or a large reduction. So I've got the same implant with the same autologous cover, and that would keep with my principles. I think there is a debate. I did do this patient on the right as a single stage, but I think probably now I'm a bit older and wiser and less gung-ho than I was when I was younger. I'd probably do it as 2 stages, and I would do the reduction first, and then I would augment her. But that principle, again, sticks with my first major principle. Now, complex cases are just complex, and sometimes you have to think on your feet. But we all historically, and probably will continue to use differential projections of implants for chest wall asymmetries. Again, if you want the breast to look the same over time, try and make the platform the same. And I have now for quite a number of years been using these 3D printed chest wall implants. I think they're fantastic. I went to France and Professor Schlerin, who taught me how to do this. And often you don't even need to do anything with the inherent breast asymmetry, but you can do these, put the chest wall in, and then later bring an implant in. And so now again, I've got symmetry on both sides. I've got the platform the same on both sides. I've got the same size implant on both sides. And I am confident that even if she has some implant-related complications, she will be symmetrical over time. So those are my principles. Basically, do whatever you can to use the same implant with the same autologous in your planning. Now, I'm going to share with you a bit of an evolution of experience in terms of the tuberous breast. A lot of this work initially was in my government practice. And obviously, we've seen talks today with some really complex cases this morning using mammoplasties for much larger and more complex constricted breasts. And there's no doubt in those large breasts, you're going to have to use mammoplasty techniques. But in these very volume deficient Grulu type 2 and 3 constricted breasts with severe constriction, herniated nipple, severe volume deficiency, I do not use a periareolar scar. And they all have a global skin insufficiency, even though they've got herniated nipple areolar complex. So the principle of the technique is unbelievably simple. And there is nothing, I'm afraid, earth-shattering or groundbreaking about this. But what you're attempting to do is recruit the skin into a skin-deficient breast. You're going to score the constrictions. I can go about that in a bit more detail because there is a bit of nuance to that. This is really for patients accepting small to moderate implants, moderate to large implants, and the patients do have to be a little bit patient, which may be a problem. The aim is this. It's to correct volume, remove the tuberance appearance. To your great surprise, try and reduce the size of the areola, even though you're not actually doing anything to it, and obviously achieve symmetry. Now, obviously the herniation of the nipple is a concept of growth through a constriction. But actually, if you remove a constriction, then there is the chance the nipple will return back. Now, even in a patient like this, which is a severe case, with, a difficult tight crease, when you lie the patient down, and I'll talk about this stretch test, there is still an incredible deficiency of skin, I admit, predominantly in the lower pole. And taking skin away is adding to the skin deficiency. So if we primarily are going to start now taking skin away in the primary operation, you're making your skin deficient breast even more skin deficient. You're then trying to add volume, and not surprisingly, apart from in some people's hands who seem to make it work, and they're not mine, guess what? The periareolar scar stretches over time because you're trying to hold something that's deficient of skin and then adding volume. And there's other publications recently citing this. Now, I know that some periareolar scars work, and some people, there's lots of publications, and Dennis Hammerson talked about how he maintains a periareolar scar, but I see numerous results, and I've even seen them at the Congress today of stretched periareolar scars, and I just think they don't look good. So this journey started with this patient nearly 20 years ago. This is in my government practice, and I told this patient, she's so skin deficient, I'm going to stretch tissue expand her first, and then at the second stage, I'm going to do a periareolar mastopexy. So she came for her exchange, and I noticed all her constrictions had fallen out completely. I thought, well, that's interesting. I changed her implant, and this is her 7 years down the line, admittedly following a few children. So this was the second patient I did. So I actually didn't tissue expand her. I just did the scoring, and I just put an implant straight in. And that's her at a year with no signs of her tuberous breast. So I then had a young doctor, actually. This was my first cosmetic case. And I said to her, well, I think you're going to need a scar, because I still wasn't convinced at that stage. But I said, we'll do this, and we'll do the scar later. Look at the size of her nipple areolar complex. And I've done no surgery to the nipple at all. So how do you plan this? Well, you need to plan the ideal footprint. There's nothing complex about that. We're all reconstructive breast surgeons, and so that's straightforward, obviously minus the pinch with relation with your standard breast augmentation planning. You then want to stretch the lower pole a bit like you would for a breast augmentation in terms of working out your length. You really want to try and work out the base of your breast to have a minimum of 8, but ideally, depending on the size of the implant, 8 to 10 centimeters. I have in this experience used predominantly round implants. I predominantly used firmer type implants, are slightly overfilled. What's the bra sign? Well, the bra sign is actually most women with small deficient breasts, their bra sits on where actually the base of the breast should be. So if you look at the patient on the right, it's very helpful for marking because surprisingly, the bra ends up where the base of the breast should be. It's what I call the bra sign. Quite helpful. I will score at a very minimum 3, 6, and 9 o'clock. You don't want to score superiorly because obviously you don't want to encourage skin recruitment superiorly. I will then use a sizer. The sizer then allows you to then do more scoring. You're not just scoring constrictions, you're also scoring parenchyma to allow it to expand out. And you will at the end have a puffed nipple. So there's the markings on this lady. That's how she is at the end. 80% will fall out in 3 weeks. That's her at 3 months. Note the subtle double bubble. You do warn the patients about it. That's her at 12 months. Note how the areola's changed. Those are the nipples over time. So if you look at her at 3 and 12 months, just from no other intervention to the nipple. This severe case, done the marking. That's her in the morning, 12 hours post-surgery. That's her at 3 weeks with a subtle double bubble. 3 weeks, 3 months. That is at 1 year. So she looked acceptable at 3 weeks, good at 3 months. And there she is pre-op and post-op at 1 year. So to finish with, I do think this is an incredibly helpful technique. I have done around about 35 of these patients, so it's not hundreds. I haven't, on any of them I've selected, now done a periareolar scar. And these are a representation of results. This is another patient, but again, the change of the breast with pregnancies. My only little warning, I am now starting to reduce the volume of the breasts. If they've got stretch marks to begin with, go smaller on the volume. I'm sorry about the quality of the post-op. She sent me that because the stretch marks did settle. Thank you very much indeed.
Questions from the audience?
Please, Gianluca Campillo.
Yes, this is not a question, it's just a brief comment. I see the similar effect when I do gynecomastia in patients with a similar breast, exactly the same. You have a big areola, but then once that you reduce, in that case you reduce, you do not reshape the tissue, you have a reducing, an important reducing of the diameter of the areola. So this is very important because often gynecomastia is treated with periareolar scar that are not needed, as in the case that you showed.
Michael.
Hi, I have a question. How do you do the scoring? Do you do percutaneous, only internal?
Everything's internal.
Okay.
So I use the diathermy. So I'd make my pocket. You can feel it, the gross one, with your thumb, and I would do it with a diathermy. I then put a sizer in, and you can feel with your finger on top of the sizer where the scoring in, and then I'll do more precise. It is the constriction. You don't want to go all the way to the dermis, because otherwise you'll overstretch it. So there is a balance here. I don't mind the nipple looking slightly puffy at the end. They do. They all do. But I will score more. And you often find, actually, there's banding in the inferior pole that you can carry on releasing. So I might, you do need to spend a few minutes doing that.
Thanks.
But all internal.
Marco Klinger.
Marco Klinger from Milan. Many compliments. I want to tell you that, first of all, I think that you don't need to score the gland, or to interrupt the gland, because I think that if you're going to detach the gland until the last fiber that keeps the breast, your breast is enlarging without any need of scoring.
Okay.
Second, I think that if you try to do perineal scars, cutting all the dermis around, and then going back, and then make 2 circles, you're going to have nice scars, even with perineal scars, not stretching, not anytime, not every time. Then I want to be critical with Gianluca, because Gianluca, when says about gynecomastia, Gianluca, I think that cutting the dermis, that is possible in any kind of breast, and above all in constricted breasts that are very, very well vascularized, much more than normal breast. But in men, it's difficult for the different kind of dermis of men. So I think that the parallel is lacking, in the sense that for women it's much useful, it's much easier to have perineal scars nice and not stretched. Thank you.
Okay, Fabio Santanelli.
Thank you very much, Steven. It's fantastic, and it matched perfectly my approach. I would say 99%. The 1% of difference is that I try to do also the percutaneous release and the subcutaneous both. I try to do everything I can. And in my approach, I also include some lipofilling, not for volumetric augmentation, but just to improve the release and the best healing by putting some fat grafting under. I'd like to know about this fat grafting for release of the scar, if that could be of help or not, and what is your idea? I find it useful. Not for volumetric, because I agree with you, it's pushed down after a while.
I think the only thing I would say is that I haven't found I've needed it. It's not that I don't like fat transfer, and I agree with you. I think fat transfer can soften things up. This has been an evolution. This is something I started years ago, and then I lost interest a little bit. But I haven't seen the requirements to add something else to it. I've found some of these results, they've even shocked me. I mean, I'll be honest with you, they shock me. But my point is, you don't lose anything by trying it. I think you do lose something by going straight for periareolar scar, in my opinion, because I've seen so many results where you start off with a nipple this big, you see a nice post-op result, and if you truly look at that result 3-5 years down the line, guess how big the areola is? That big again. And I actually think they often end up bigger than sometimes even on these. But, it's... So for me, it's been an evolution where I haven't seen a problem, so I don't see the reason to not try it personally.
Okay, last question.
Yes, Pietro Berino from Genova. I believe that some details could be better if you use a small periareolar excision, like a small round block. This would allow to reduce the diameter of the areola, to invaginate it, correcting protrusion, and also some kind of reposition on the breast cone, and also to give a more round appearance to the breast, which remains a bit triangular.
Okay, thank you for that. I disagree, but thank you.
Okay, thank you very much. Thank you. And we need to move on with the next speaker, who is Dr. Swanson. Is there a role for mesh or ADM in breast augmentation?
Okay, thank you. It's nice to hear people thinking outside the box. I'd like to thank the host for inviting me and also for welcoming a different perspective. So I'm in private practice. I'm in Kansas City. These are my disclosures, just royalties on 2 books on evidence-based cosmetic surgery. Now, the internal bra, we hear about it all the time. Patients ask about it, but it's not a new idea. These South African authors described it years ago. You can see on the right, trying to construct a 3-dimensional like a bra. But if you look at the before and after pictures, they really don't substantiate the claims. You don't see the increased projection or upper pole fullness. Most women are not going to be happy with that result. You may remember Dr. Goes 20 years ago, the second skin technique. These are the pictures that he published, but if you match them for size and orientation, you see that he's really not increasing projection or upper pole volume. This is Galaflex being applied to the lower pole, but the problem here is the lower pole is being preserved using this method. Now, the late Dr. Flowers called this the mastopexy-reduction bulge. And here are the before and after pictures from a publication. Again, I've matched them for size and orientation, and you can see the results just do not bear out the claims. I mean, these results are not going to impress most patients. There's a volume loss, and in fact, the patient does look like she has pseudotosis. And there's a frequent COI of authors, both the authors of these papers. This is Dr. Malucci's paper just a couple of years ago in ASJ. Again, I've matched the photos using skin markings to try to line them up the best I could. Before on the left, 3 months, although there's still some redness and bruising in the middle. 1 year on the right. Again, most patients are not going to be too impressed with that result. And this is with mesh and mastopexy. And Dr. Malucci, he claimed no conflict, but in other publications and presentations, he evidently does have a conflict with the company that owns the mesh manufacturer. So vertical mammoplasty, no mesh, what are the long-term results? This is what I do. And we really need to focus on the correct mammoplasty method and not the mesh. It's surgery, it's not the product. And look at them for over a period of 10 years. That's what's missing. And I actually have a publication on this where I did look at the results over 10 years, and I found that this technique held up well. And this is just a diagram. These are actually real measurements from my study, just showing how the vertical technique, and this is no mesh, holds up well over time. And this systematic review, the authors conclude, available data indicate the meshes do not effectively prevent recurrent ptosis and bottoming out. You really have to use standardized photographs and breast measurements. This is often the missing link. I've been doing this for years. I developed my own 2D system, and most of what I've learned about my own results has been by using this method to measure my results before and after surgery, and I've learned a lot of things doing that. Now, Dr. Parody showed this slide earlier, just comparing the different mammoplasty techniques. Really, the vertical mammoplasty has the best basis in geometry because it trades width for projection. Inverted T mammoplasty trades projection for width, which is why today you see a lot of flat, square breasts. That's just a consequence of and over elevated nipples. Those are geometric consequences of using an inverted T inferior pedicle technique. So this is a method that I use very regularly in my practice combination. I call it all seasons vertical augmentation mastopexy. It gets the job done. The implant gives you the volume, and the vertical lift gives you the vertical lift that you need while minimizing scars. And this slide was presented earlier as well. It's so simple, I don't even know if it qualifies as an algorithm. But basically, in almost all my female breast cosmetic patients, I'm either doing implants or a vertical lift or both. I mean, it's that simple. And now what about ADM? I'm going to switch to ADM now. The first report was from Maxwell and Gabriel, and they reported 100% success. I'm always a little skeptical when it's 100% success. No IRB, and the combined payments to the authors, I looked that up. I'm going to be talking more about this yesterday, but the authors actually were paid over $40 million. That's mainly Dr. Maxwell, mainly for royalties, but still a lot of money from Allergan. Now, what about capsulectomy and ADM insertion, a new paradigm? This was a very popular study published by Drs. Hidalgo and Weinstein and PRS in 2020. I think it might have been the most read cosmetic study. But what they did was they used ADM for women with bilateral capsular contracture, that's primarily, the first time they developed that, or unilateral treatment failures. They used Stratus. The problem was that in their analysis, the follow-up time, of course, was shorter for their more recent ADM cases, and there was no report of complications in the study. So what about ethical problems when recommending ADM? And I'm talking about cosmetic surgery, and this is for capsular contracture. Well, cheaper than failure is actually not true when you compare it to my recommendation, which is an open capsulotomy. And surgeons and patients may not be informed of a much less traumatic and less expensive alternative. Now, if you recommend this to patients, it's going to be financially debilitating for them. Usually it's not covered by insurance, no prospective controlled study, and treatment failures do occur. And, if you're quoting success rates, you have to consider that if you're missing patients that can't afford the surgery, those patients are treatment failures. They're not able to afford the surgery. And again, no IRB approval. So capsulectomy and ADM, it's a much longer, more difficult, expensive surgery. You're taking out the existing capsule and then you're having to reline the breast. It is sometimes dangerous. And I'm aware of one death and one axillary vein injury. You lose control of the pocket, which is why you need to put in new lining. Reminds me of Paul Newman in that old Cool Hand Luke where he has to dig the hole and then fill it again. You're just going to a lot of trouble. So why perform capsulectomies in the first place? Why are people removing capsules? Well, they've never been shown, this procedure has never been shown to provide a systemic benefit, except for BIA-ALCL. Existing capsule is better, it's vascularized. Nobody's ever identified a bacteria or microbiome linked to capsular contracture, and it doesn't make sense to remove part or all of a capsule because you're not changing the microenvironment of the breast in doing so. It's not even known to be helpful for BII compared to a capsulotomy alone. This was just a recent publication. So ADM is actually a case study in problems created by COI, which again, I'm going to talk about tomorrow. They're underreported. Researchers, of course, publish more positive outcomes when they're using ADM. If you're getting a lot of money from the manufacturer, you're going to be more likely to report positive outcomes. It's well known. It's beyond argument at this point. This was a commentary by Dr. Bankston saying that he thinks that withholding ADM is like not offering a curative medicine, and the technique that I use is basically insane. And he received almost $1 million in Allergan payment over a period of 2013 to 2022. So what about the complications? I mentioned complications not being reported. Well, this is just a list of complications that I compiled for these procedures. Dr. Weinstein talked about this recently. Again, did not report any complications or revision rates. But I imagine this surgery is so difficult and it's lengthy. If you're able to do it without any one of these complications, that would be quite an achievement. So what's the alternative? You've got to have an alternative. So what I do is just an open capsulotomy. I published this in 2016. It's largely been ignored. And these are my complications. The recurrence rate, 22.7%, but very few other complications. Now, so what I do is I just take the first rung of the ladder. I do an open capsulotomy. I think we need to dial down the interventions instead of climbing all up the way up the ladder. So comparing methods of treating capsular contracture, you can see capsulectomy and ADM on the left, open capsulotomy on the right. Almost all the advantages are in open capsulotomy. So let's talk a little bit about cost. Dr. Hidalgo was mentioning that it takes up to 5.5 hours to do this procedure. The costs can equate to buying a small car. So I just looked up how much is a small car. $26,000, but I have a hunch at Weill Cornell University, you're just getting started at $26,000. Whereas a capsulotomy, if you're a patient of mine and I've done your breast augmentation, I charge you for the operating room and the anesthesia. It's cheap. It takes 20 to 30 minutes. Patients can be back to work in a few days. So here's an example of this patient. This is just a linear open capsulotomy. Could hardly be easier. Often I put the same implant in, but often there's a reason to replace it. So it's an overlooked but effective treatment, 22.7% recurrence rates. They're easily treated, not to be dreaded, very little recovery time, very little expense, no insurance billing, no pathology. So I've been in practice 35 years now. I have yet to do a third open capsulotomy on the same patient. So I'm not getting an endless cycle of capsular contraction, capsulotomy. And if I did have to do a third treatment, no big deal. Remember, we're not traumatizing the breast. This was very scary for me to see people actually recommending ADM in primary breast augmentation. And why why are the contracture rates lower using ADM? Well, first of all, there's some flaws in this recent analysis. The authors did not recognize the significant selection bias and chronology bias among these papers that undermine these conclusions. But often this treatment recommendation is regarded as the kitchen sink. Nothing more can be done if capsular contracture recurs. Now you've got to have a backup plan. You can't tell a patient, we're going to do this. If it doesn't work well, we did everything we could. That's just, that just doesn't cut it. Again, you look at the payments to the plastic surgeon authors, and it's important to realize that ADM actually contains donor DNA. It's packed with nuclei. It's not acellular. It's not sterile. So in conclusion, mesh and ADM, they're unnecessary for cosmetic breast surgery. Be aware of COI. Insist on standardized lateral matched images, and use mammoplasty, basically use the vertical mammoplasty. And use open capsulotomy alone for capsular contracture treatment, and rarely perform capsulectomies. Thank you.
It's open for discussion. Go ahead.
Thank you. I enjoyed the talk. So you're doing the open capsulotomy, but there's a 22% failure rate. What are you doing for those failures?
They come back and I do it again.
And then what's the failure rate?
13%.
So it goes from there to there. Would you think, I mean, some people can't afford ADM. If you had a failure, I also do the open capsulotomy in round 1, but round 2, I go to ADM.
Don't do that. Just do another open capsulotomy. Save your patient a lot of money.
It's those 13%, they're going to be pretty upset.
No, they're not. It's such an easy procedure, even if they had, but remember, I told you, I have not had a patient come back for a third one. So it's that.
Think they went down the street?
They might have. They might have. That's a good point. But that's true of any study.
True. Yeah.
That's true of any study.
Thank you.
Yeah.
That was an interesting talk, Dr. Swanson, as always. You mentioned a lot about not using ADM for capsular contracture, and obviously there's some disagreement about that. But what about things like recurrent malposition, bottoming out, other reasons that you may consider using a mesh or ADM, particularly like in a weight loss patient, for example?
So I do a fair bit of weight loss surgery. I've never found an occasion to use ADM. I just never use it. I make use of conventional treatments. As you know, I do vertical mammoplasties. I make use of the existing capsular material. Have not had to use a foreign material.
Dr. Santanelli?
Thank you very much, Eric, for your excellent presentation. One simple question. When you talk about capsulotomy, are you dealing with texture capsule or with smooth capsule?
Well, most of these are my patients, and so they had smooth implants. So most of the time they're smooth, but some of those were textured, yes. And I just make a circumferential linear incision, 20 or 30 minutes. That's all it takes.
Thank you.
Thank you.
Last question.
Last question.
Well, it's actually just a comment. Thanks very much. I enjoyed it. Even away from cosmetics and where you think it would be less debatable about in reconstruction, if you actually look at most international series that aren't high quality, single center, single surgeon series, where you're going to get good results because they're dedicated surgeons, the use of ADM in the illegal series around the world from multi-center sites shows increased complications. And so I completely agree. I think ADM's been normalized as this product that you're almost abnormal if you don't use it, but actually in the everyday surgeon working in multiple small centers, it increases complications, and that's what the evidence shows.
Thank you. Some people regard it as the standard of care at this point. Thank you for that comment.
Our next talk is going to be how to make a safe transition from macro-textured to new smooth surfaces. Dr. Munoz?
Okay. Good afternoon, everyone. Thank you so much, my good friends Fabio and Mark, for their invitation again. And I think I deserve an Italian passport 4 times in 1 year in this wonderful country. So next time I need the citizenship, okay, Fabio? But okay. So the organizing committee asked me to talk about a little bit the transition of macro textures, especially grade 3 and grade 4 to a smooth surface. And fortunately, in Brazil, we have only the new generation of smooth. I think everybody know the history, and I go briefly in this situation just to show that we have the generation 1, grade 1 Versa 1 with roughness of 0.2 on the 70s of smooth surface. And since 2010, this is the generation 2 of smooth with a different roughness of 3.6. And this has huge impact in the process of inflammation and capsules. So we have a situation that we have thick capsules, tissue adhesion, and Velcro effect. And with this new generation, we have thin capsules, no tissue adhesion, and maybe problems in terms of stability. And sometimes even macro texture, we have some problems here. It's a grade 4 macro texture in a patient with a double bubble situation. The capsule can hold the implant, but cannot the glandular tissue, or this situation that you were habituated in the past, that one capsule into the elastoma and another capsule in the soft tissue, some liquid, and not very good aesthetic result in this lady. With new generation, this is one of my first cases in 2017. It's a transaxillary reoperation because the patient wants the size change. Here, I just insert some needles to check the new pocket. And here you can see 6-7 years after, the capsule is so thin, almost virtual, something that I call peritoneal-like, as you can see by transparency, the glandular tissue and the vessels into the breast. And how to make an adequate transition to this new generation, having a previous macro texture mindset. I think you have to put in mind some important message, an implant that's suitable for the anatomy, and moreover, a pocket suitable for the implant. To be didactic, I will divide in 3 points, 3 key points. The key number 1, the relationship between the breast base and the implant base. It's very important if you are expecting to have thin capsules, it's very important to have something on the medial and lateral aspect to function as a pillar or a structure and to maintain an adequate stability. So in my hands, I think it works very well. Implant base must be smaller than breast base. I try to maintain at least 1.5-2 centimeters into the bone diaries. The key number 2, we have a customized pocket dimension. The surgeons, the macrotexture surgeons that are habituated with shaped form stable know what I'm saying in order to avoid any kind of rotation. But with this new generation, it's important to play in a pocket like that I call super tight. It's more tight than the pocket that you use in a shaped form stable implant. And of course, if you are working with especially grade 4 or texture, it's not recommended to use this pocket loose or baggy in a smooth one. Here you can see it's a subfacial transaxillary breast augmentation. And this is the definition of super tight. When you insert the retractor, you can see a lot of folds into the implant and no space into the parasternal area as well as in the lateral aspects. This is something between tight and super tight to avoid an adequate stabilization and a nice result. Another important point related to the pocket, which one is better? More superficial or submuscular? Oh, this new fashion of subfacial. I believe in subfacial. The Brazilian school of breast surgery is essential premuscular, and I think you have some advantages. It's a support structure because you have a strong adhesion between the fascia and the muscle, and of course that we don't have the breast animation deformities due to the submuscular planes. It's not a consensus, especially in the US. The pectoralis fascia is really effective for smooth silk implants, or is just folklore? I think, and there are some papers that evaluated this issue, pectoralis fascia is a dense connective tissue. And although it's thin, and I totally agree with you, it's very resistant, more than skin, muscle, and gland. We have different thickness in different parts of the pectoralis area. And the most important, from my point of view, it's not just thickness. It's more stability at the pocket boundaries than the subglandular one. I think the subglandular, you have loose connective tissue, and the adhesions between the fascia and the glandular tissue are not so strong as the fascia and the pectoralis muscle. And if you like axillary approach, it's much easy to find the fascia because we have a conjunction of the deltoid, the brachial, and the pectoralis fascia together, as you can see here, and it's very easy to find this space and perform the whole pocket dissection through the axilla. The third point that I want to mention, it's about to respect the limits. And to respect the limits, you should be conservative in your dissection. And when I mean conservative in dissection, that you have to respect the lateral limit, anterior axillary line, and the parasternal line. Moreover, I usually create, as I mentioned before, the tight or super tight pocket, 0.5, 1 centimeter less than the implant base. And if necessary, you can expand the pocket in specific areas, avoiding extensive and random dissection. It is easier and more predictable to increase a pocket that is very tight than having to reduce one that is loose for a smooth silk implant. Most important, always check the boundaries and expand it if necessary conservatively. And for this objective, I use a personal dissector and also needles. And I think are simple, are available. Here you can see there are simultaneous videos, transaxillary subfacial augmentation, and you can see a precise and progressive dissection according to my pre-op markings. And after I check the limits of the IMF, and I just insert the needle just to be sure that I'm following my preoperative markings and I'm not expanding unnecessarily my subfacial pocket. Here is an example. The markers are simple, medial limit, lateral limit. I always maintain 8% the original position of the IMF. And this is the template showing the dimension of the implant, and the blue one is the dimension of the pocket. It's a little bit smaller in order to create a super tight pocket. This is the patient in pre-op. This is the patient in post-op. It's a transaxillary subfacial augmentation with no fat grafting, just the premuscular pocket, and this is the long-term result. As you can see here, good stabilization, good definition of the IMF. I like this evaluation because we can see the outcome during the post-op. The post-op in 1 month, as you can see, the same position of the shoulder, the nipple, the IMF is the same IMF position, but due to the lower pole expansion, you can see that it's a little bit lower. With control, with MRI, in some cases, we have an adequate tissue thickness to maintain like a pillars and avoid lateral displacement and maintaining the implant in position, as you can see here, and no displacement, as you can check with the artifact that we have in the microchip inside of the silicone gel. If you can move for me, okay, thank you. And how to manage patients with textured implants who are looking to switch to a smooth one. And I like capsules. I try to preserve these capsules for stabilization. I use this capsular sling into the inferior and lateral aspect of the breast, as you can see here. just try to move serotos, I have some problems here. And this is the capsule. I think there are some risky areas for displacement, especially in the inferior aspects and lateral aspects. So I usually perform a partial capsulectomy, and then I preserve this area to maintain the new implant. This is hybrid breast augmentation in a post-op of 7 days with a smooth macro texture to a smooth silk surface. And this is the post-op in 1 year with a nice result. The same result in the profile view with CSPT analyzers in 7 days, hybrid reoperative breast augmentation, the post-op in 3 months, and here the post-op in 1 year with a nice result in terms of volume and symmetry, and avoiding the main problems of this type of surface that is related to displacement. Thank you so much.
Okay, the paper is open for discussion. Is there any question? If not, I do my first one. I have no experience with the transaxillary dissection. Is there a volume issue in terms of what is the volume that you can go through?
The volume of the implant?
The larger volume you can fit.
Yeah. I think it depends of your office and the clients that you receive in your private practice. And, you know, in Brazil, the average volume that the patient demands for a normal augmentation is something close to 300, 350. My biggest implant was 700 cc in taller patients. But with an adequate technique, you can dissect an adequate pocket with no major problems. I avoid to use large implants, especially because the complications and the long-term results. Unfortunately, in my practice, it's not a fashion to have to demand for bigger implants, but with an adequate technique is feasible.
Thank you.
I have a question and a comment. I agree with you. I think that the best pocket for this kind of breast implant is a subfacial, not submuscular, because it's very easy that due to the contraction of the muscle, you have a lateral or inferior displacement of the implant. And this can also explain why ADM and mesh are so popular in US, where they use smooth implant under the muscle. So I agree with you. The best place is under the fascia for this kind of implant.
Okay, thank you for your comments, and I agree with. We have our algorithm. In my practice, I can indicate subfacial in primary in almost 90%, because in pure subfacial in 65%, between 65 to 90%, it's subfacial hybrid with fat grafting. And in very thin patient with donor site, I think it's the only indication for submuscular in my word, okay?
Or you can also, in case of slim patient,
yeah.
the upper fiber of the
yeah.
major muscle.
Yeah.
No need of fat injection.
Yeah.
In that case, you can have a, sorry, just to continue the discussion. In the case of slim patient, you can also elevate the upper part of the pectoralis major muscle, so you have a 4/5 of the pocket that it is subfascial, and the only upper fifth that it is subpectoral.
Yeah, this was recently published by my good friend Ruth.
Ruth Graz.
So,
excuse
yeah,
me.
Thank you for your comment. I agree with you.
Okay.
I completely agree with you.
Excuse me, because of time issues, we need to go ahead.
Okay.
Otherwise, thank you very
Thank
much
you.
for
Thank
your
you.
presentation. And I introduce next speaker, who is Dr. Daniele Fasano from Bologna, who is presenting Friend of Four, Approach to the Capsule in Secondary Breast Augmentation.
Thank you very much. I thank Professor Santanelli for the invitation. It's a pleasure to be with you. I will talk about the capsule. And what is my behavior and what I think about the capsule in secondary mammoplasty augmentation. All of you know what it is, capsulotomy and capsulectomy. I will talk about partially about capsulotomy and partial capsulectomy and complete capsulectomy. Total capsulectomy, for sure, introduce additional morbidity. It's a longer surgical procedure. It is a reconstructive procedure requiring a tailoring of a new pocket. Can lead to less satisfying results. Partial capsulectomy is, as you know, a less aggressive and shorter procedure. The capsule can be useful to add thickness and support soft tissue envelope. Capsular flaps can be very useful to favorably shape the pocket. So when we are dealing with the capsule in secondary breast augmentation, and in these cases, I think about two possible important issues to be considered. First of all, it is the indication to the secondary mammoplasty. And second is what was the implant, the primary implant, and then the secondary implant, the new implant that we are using. The indication of to secondary augmentation mammoplasty are all these. So capsular contracture is the most frequent reason for a secondary mastoplasty. I think it is an indication for surgery when there is a grade 4 Baker. And I think that in case of calcific capsule and grade 4 contracture, a total capsulectomy is advisable. Radial and selective capsulotomies in the superficial plane, horizontal or vertical according to the cases, and capsulotomies are more useful in less severe cases. There are many publications about that in the literature. Some think that capsulectomy, total capsulectomy is always necessary. Others think that capsulectomy is not advisable. And you have heard just before Dr. Swanson talking about his thoughts about this. I think in this case, a total capsulectomy is mandatory, and this is the result of a case. This is another case in which there is a different kind of capsular contracture. And in these cases, I think we can think about what to do. Do a total capsulectomy bilaterally or only on one side, or even a partial capsulectomy. I prefer in this case generally a total capsulectomy. In less severe cases, partial capsulectomy, I think, and the capsulotomies are much more advisable. If there is an implant rupture, it is the most frequent, second most frequent case for a secondary mammoplasty. I think then when there is a significant rupture with silicone embedded in the capsule, a total capsulectomy is to be considered. Radial and selective capsulotomies in the superficial plane in cases of less important rupture. Even here, there are many advice in the literature. What I think it is that, at least in my hands, the rupture I see are generally important, and a total capsulectomy is generally performed. Generally, people say that the change of the plan is necessary in after breast implant rupture, but in my practice, this is not always the case. Generally, it is rarely necessary, because if the soft tissues are enough, are quite thick, I think it's not necessary to change the plane. It adds surgical complexity, and probably it's not, there is no need to that. And these are cases in which I think a total capsulectomy is necessary. This is one case. This is another case. When there are tiny ruptures and a normal capsule, I think that washings and partial capsulectomy is more interesting to do and surely less aggressive. This, for example, is an asymptomatic rupture diagnosed by ultrasound and MRI, and a partial capsulectomy was done with replacement with a new implant. Implant malposition or implant exposures, generally they are early reoperation. And in these cases, generally, selective capsulotomies and capsular flaps are a better choice. This is a case of exposure, almost exposure of the implant, no infection. And in this case, I've done a capsular flap from the thoracic wall in order to put another implant of a smaller size. And this is the case. Another indication is the patient request, so desire to modify the implant size and shape. And even in this case, I think selective capsulotomies and capsular flaps are generally useful to obtain a good result. And this is, for example, a case. Age of the implant. I think in this case, the indication must be discussed with the patient, must be individualized. And there are people saying that a systematic replacement of the implant after 10 years or 10 or 12 years is mandatory. I do not think this is correct. I think replacements must be anticipated to the patient, and the indication is generally individualized. I mean that you have to discuss with the patient, you know the pathology of the patient, the age of the implant, the actual result, and then at the end you can have a decision that you have to share with the patient, when to do the operation and which kinds of operation you have to do. Selective capsulotomies can be useful. Total capsulectomy can be justified in case of a macrotexture implant, considering the data that we all know about FDA and BIA-ALCL. For example, these are two similar cases, mammoplasty, secondary mammoplasty after 12 years, macrotexture implant and microtexture implant, what to do, partial capsulectomy, total capsulectomy. I think every surgeon can have his advice and choose what he really prefers. And then the characteristic of the implant. Primary implant, the shell, macro, micro, smooth, the manufacturer, and secondary implant, what you choose. I mean, here in Europe, very often you choose anatomic implant, and if you are choosing an anatomic implant, probably a capsulectomy is necessary if you want to avoid the rotation of the implant. Then the shell is important. If you choose a polyurethane implant, in these cases, a total capsulectomy is necessary. It's not my general choice. So total capsulectomy introduces additional morbidity, but I think it is necessary if the indication is for a total capsulectomy. We must not avoid a total capsulectomy just because the result can be worse. It is not mandatory in any case for asymptomatic patients. The indications depends on the surgery, why we are doing this surgery. If it is a calcific capsule, Baker IV capsular contracture, evident breast implant rupture, I think that total capsulectomy is necessary. It depends on the primary implant too, and considering the literature, the removal, in case of a removal of an allergan implant, a total capsulectomy can be justified. Depends even on the new implant, and above all, if a polyurethane device is chosen. Partial capsulectomy is a less invasive procedure. it has an indication in many cases of secondary mammoplasty. And in these cases, the capsule can be useful to add soft tissue volume, can be useful to do some capsular flap if you need. So it is, in these cases, surely you can consider the capsule as a friend. Partial and total capsulectomies, according to me, have both indications, and the choice must be customized according to the etiology, to the primary breast implant, and to the new implant. Total capsulectomy has some clear disadvantages, but nonetheless has be performed when indicated. Thank you very much.
We can take 2 questions from the audience. We're running just a little bit late. We'll try to catch up. But does anybody have any questions? I'm curious, we heard from Dr. Swanson that he almost never performs a capsulectomy, but now we're hearing something just a little bit different. Do you have any experience just with an open capsulotomy in treating your grade 4 capsular contractures? Not the calcified capsules, but just grade 4 capcon?
No, if there is Baker 4 contracture, severe contracture, I prefer to do total capsulectomy.
Dr. Santanelli.
Thank you very much, Daniela. And I would like to try to get out from this concept of the macrotexture with an anticipation that I will present tomorrow. There are other surfaces which are at much higher risk than the macrotexture. So we have to be careful when we try to blame at macrotexture. As far as it is now, at least in the data in my process are texture and the other side are smooth. But my question is, sorry, a personal question first, if you allow me to. Do you have only your child, boys or female? Do you have a daughter?
No.
Good, then I can go on with my question. Yes, it was referred to me, a patient, yesterday. So until yesterday, it was 111 cases in Italy. Now we have 112 cases of BIA-ALCL. So she was replaced the implant without doing total capsulectomy, and she was having a microtexture implant. Now she has a mass under the implant, which is invaded the chest wall with the lymph nodes of the internal mammary. And she has to undergo 2 chemo because she's a stage 4 BIA-ALCL. Now, let's put it that I can say, of course, that she was your daughter and you were not doing the capsulectomy. What would you tell her? Sorry, darling, there was not enough evidence?
What I say is that as far as we know, the implants that are involved are 91%. It is what the literature data has, we see. Fabio.
I'm sorry, but depends which literature do you read, because there's a broad literature. Then
no,
it's not like that. Some papers are, sorry.
No, not papers. Sorry.
Papers, it's literature.
Yes, but FDA, I mean, in FDA, it has been reported that 90% of the cases of BIA-ALCL were with allergan implants.
With all of my respect to FDA, this is not literature. If you go on literature, which we are going soon to present again, literature is a case matching. It's not opinion from authority. It's totally different, you know. If authority report that there are a certain number of cases and the highest number, which is the prevalence, it's allergan, it means only that they've been counting the case. They didn't check the market share in that country, how many implants have been sold with macro, how many implants have been sold with micro. You have to do this work in order to be able to understand which one is the risk. So I think we have to be careful to say literature. Literature is literature. It has to be approved by an editor. It has to have a level of evidence. Opinion is different. Sometimes FDA rely, or other authorities rely on literature, but it's not exactly the same. Sorry.
No. Okay, Fabio. Yes.
I think we're going to have to.
Yes, just a new comment. I mean that even literature, even sometimes level 1 or level 2 literature, people have shown that that's not so real.
Thank you. We're going to have to move on. I'm sorry, we're running just a little bit behind. Next talk is paying attention to the IMF and breast augmentation through planning and reconstruction by Dr. Vanderlee.
First of all, I would like to thank the organizer for having invited me here. It's nice to be here in Rome. And my presentation is about the IMF in primary breast augmentation. These are my disclosures. Background. Augmentation mammoplasty is one of the most frequently performed aesthetic surgical procedures. With almost 300,000 procedures, it belongs still to the top 5 most popular cosmetic surgical procedures in the USA, as reported by the HPS in 2022. And the inframemory approach is most versatile and popular. The challenge of the inframemory approach is the IMF planning and the IMF reconstruction. And the question is why? Because placement of the implant has impact on the soft tissues and the skin envelope. And the distance from nipple to IMF mostly increases after augmentation by either stretch of the skin, that means the stretch of the original distance nipple IMF, or by mobilization of skin from the abdomen to the lower pole of the breast. So the incision site should be chosen in such a way that the ultimate scar is carefully hidden in or slightly above the IMF, the new IMF. So therefore, often the incision has to be placed caudal to the original IMF, and then the IMF has to be reconstructed to prevent bottoming out, especially nowadays with smooth and micro-textured implants. In the past, the incision of the original IMF resulted in either a too high position of the implant, with the scar here, or a scar too high on the breast, as you see here, and or bottoming out. The question is then how to choose the right inframemory incision location, which will depend on implant size and dimensions, of course, as well as on skin elasticity and ultimate skin stretch, and on whether the new IMF fold will remain in its position. And then I thought perhaps the Pythagorean theorem might be suitable to describe these ratios of implant incision location variables. What about the Pythagorean theorem? As we all know, a squared plus b squared is c squared. A is half the diameter of the implant, b is the projection of the implant, and then c is the hypotenuse. And this incision location should be then at c distance from the lower border of the nipple areolar complex under skin stretch. How is this then in daily practice? Well, first of all, marking of the patients. I draw the midline, then I draw the current IMF, then I draw the medial border of the incision site. So the incision should be not more medial than the dislocation. It's mostly the medial part of the areola. And then I have to calculate the new incision site, which I do by the Pythagorean theorem. And in this case, we had an implant of Perle with 380 cc. And as you can see, here are the dimensions. So A half of the diameter is 5.8. B is the projection, 5.2. So C squared is 60, which means that C is 7.8. And this should be the distance from the lower border of the areola to the new incision site. So then I draw the new IMF location at 7.8 centimeters, as you can see here. And what I do is then draw the new IMF on the entire shape. And this is then the drawing of the incision, which I use mostly about 5.5 centimeters, depending on the implant size. This is just the incision. In my technique, This is the area of subglandular undermining. Subsequently, I do a subpectoral pocket creation because I mostly use a dual type 2 dissection. And finally, I do a pectoralis muscle release because otherwise you get animation and the implant will be pushed too much laterally and high. As you can see in the small movie here, the pocket dissection subglandular. The next point is do the subpectoral dissection. And a small trick, I just open it at the lower side, mostly over the rib. And then a small trick, I take a monofilament fixed suture, put it through the released border of the pectoralis muscle, as you see now, with a double loop, so that this muscle will not tear off when you have traction on the suture. And what is then handy is if you have some traction on the muscle, you can easily put your light retractor underneath and the dissection is easy. So that's a small trick. I put it on a clamp like this. We have a disposable retractor. And then you can easily dissect it further. And finally, the pectoralis muscle release at the medial side. Next point is I do check the pocket size by air inflation, as you see here. And then insertion of the implant. We use iodine. Nowadays I use a sleeve, but in this movie we didn't. We tried to touch the implant as little as possible. Check the position. Just adjust, but we do a tight pocket because with smooth and microtexture implants, there is a tendency to enlarge the pocket in time, so you have to have a tight pocket. And then I reconstruct the new IMF. And what you see, I grab thick tissue underneath with a fixed suture, a Vicryl 0, stitch away from the implant. So what you see is kind of figure of 8 suture. So you can never damage the implant. Some sound, please.
First of all, Vicryl 0 sutures are placed deep in the underlying deep tissues for accurate hold of the position of the new calculated IMF position. As you can see, the figure of 8 technique is used to place these sutures in order not to damage the implant. Always the needle will be stitched away from the implant. The sutures are held on a clamp and just tied after accurate placement of all the sutures under direct vision. Subsequently, more superficial closure is performed, and finally a running intradermal étalon suture is used that can be removed after 1 week. And finally here you see how much the new IMF has been lowered.
What about the effect of this? Here you see the static result after 6 months of such a reconstruction. And here the dynamic, and you can see the scar is precisely in the new IMF that has been lowered. We did also clinical evaluation in a period of 3 years between 2009 and 2011. We had 155 patients that underwent then primary breast augmentation, and we did a retrospective analysis of 132, which means 263 augmented breasts with a follow-up of 1 to 2 years to see whether the IMF had remained at its place. And in 98.5% of the breast, the scar was in the right position. And more than 98% of the patients were very satisfied with the results. So only in 1.5% of the breast, which means in 4 of the 3 patients, the scar was a little below the IMF. But we never observed any bottoming out. A second period between September 2021 and 2023, another evaluation. 67 patients underwent the primary augmentation with the new Pearl implant, which is a smooth implant. And 63 patients had primary breast augmentation revision with this implant. And we had only one case of bottoming out observed after 1 year. And this was in a transgender breast augmentation patient. As you can see here, after a year, there was bottoming out. And what we did then subsequently, a secondary reconstruction which stayed stable. So good planning and reconstruction of the IMF is of utmost importance for successful breast augmentation with no bottoming out and concealed scars. And I think the Pythagorean theorem is a good practice for it. And I think augmentation mammoplasty will remain still quite an art, especially for the IMF planning and the reconstruction. I thank you for your attention.
Thank you very much. The paper is open for discussion, and I have a first question for you. I've seen that your technique of dual plane dissection is slightly modified in terms of the lower external quadrant, that you are not dissecting between the plane of muscle and
True.
Can you comment on that? Because it looks like in the post-op pictures that it is slightly still constricted. Some breasts are constricted even laterally, not only straight under the nipple and medially. Can you comment on that?
Well, the reason for it is that I don't need it in practice. Initially, it looks a little bit constricted, but in the long run, you won't see it. So I don't do it. Reduce the surgical service area.
You know, you mentioned that you had one patient where it bottomed out on you, and it was a massive weight loss patient. And I just wonder
No,
if
it was a transgender patient.
Oh, a transgender patient. Okay, never mind.
Well, the explanation why it probably bottomed out is there is no real IMF, and I only reconstructed in a small part. Probably it should have been more extensively reconstructive. And it was a severe big implant.
Yeah, I guess the massive weight loss patient, your incision ended up just a tiny bit low. And, you know, Peter Rubin has a paper in PRS where, you know, they had a lot of augmentation mastopexy patients where they lowered the fold and were not very successful. So I wonder if you have any more experience with weight loss patients and sort of purposefully lowering the fold. Is that a problem, not a problem?
Well, you have to be careful in massive weight loss patients because their skin stretches much more in time. And you cannot just simply simulate a stretch by stretching the skin. It will stretch even more. That's probably the reason why it's not so successful in massive weight loss patients.
Okay, thank you very much. And we move on with the last speaker, who is Professor Marco Klinger from Milan, who is presenting the greatest save successful strategies in secondary breast augmentation.
Thank you, Fabrizio. Thank you. Thank you for your invitation, Fabio and Dr. Clemens. I know that everybody is tired. I'm going to talk about 45 minutes, so you'll be late. I want to sum up my opinions regarding secondary mammoplasty. In all cases of mammoplasty, I look for natural breast shape, enough tissue covering implants, correct neck position, soft breast with implant, and minimal scars. The capsulotomies that I want, the techniques that I want to sum up are these 6 techniques that are capsulotomy and capsulorrhaphy, capsular flaps, different planes, different implants, periareal mastopexy to neck repositioning, and lipofilling with needles, as we did in scars. What about capsulotomy and capsulorrhaphy? They need for contracture releasing, redefining the new pocket, enlarging and narrowing if you need, even in breast reconstruction, and coming from breast reconstruction to cosmetic surgery and to cosmetic surgery to breast reconstruction. Capsular flaps, I think that are vascularized healthy tissues. I don't want to move into the argument of the LCL, and they are useful most of the times to cover thin areas. Different plans are important, pressing from the retroglandular pocket to retromuscular pocket, with more natural results, better implant coverage, intermammary distance reduction. But sometimes you can even come back from the retromuscular space to the retroglandular space. Different implants we can, the more suitable that you need, wide, projectile, rigid, and periodic mastopexy for neck centralization and sometimes for skin excess reduction. Fat and needles with for partial volume augmentation, scar releasing, and lengthening with of retracted areas in the same way of treating the scars. This patient has two different, two wrong sulcus, one too low, one too high, and you have to fix the right sulcus with the capsulography and to slow down the left sulcus with the capsulography. She probably was not symmetrical at the very beginning, but now it's quite symmetrical, fixing the two different sulcus. I think that I stole from Piero Berrino and I worked with him many times, that capsuloplasty is the sum up of capsulotomy and capsulography. And when I say capsulotomy, I say even partial capsulectomy in the place where I need. Rather than the classical Baker classification, I think that the different varieties of areas of uneven fibrosis and laxity should be considered, even in the vault and not only on the basis of the breast. In this case, we can, with capsulotomy and with capsular flaps, to fix the new position of the implants. And in this case, the periareolar with capsulotomy and capsulographies, but the periareolar transportation of skin permits to reduce the volume of this bed breast, closing the envelope of the implant without doing any other scar, but just periareolar. And you can fix again with capsulography and slowing down with partial capsulectomy and capsulotomy, making more round this bad result. Again, this is a reconstructed case, and you can fix the new sulcus with capsulography and enlarging the right one with capsulotomy. Capsulographies provide support to the implant in the areas of capsular laxity, while capsulotomies or minor capsulectomies carried out perpendicularly to the lines of capsular resistance provides release and roundness where the profile is flattened. So when we say capsulotomies, we don't need just on the basis, but we need in all the areas of the breast when we need. Change of plane is very, very important because sometimes passing from the retroglandular space behind the pectoralis muscle, you can have nicer result even without any kind of a contracture, even in the movement. Again, changing plane. And again, and most of the times, this is a nice case because you can see that you can change the plane passing behind the muscle from below the muscle and move up the breast with vertical scar just to change. You see the inferior sulcus of the lateral breast that is too low and too round. We need to have too shorter. Again, change of plane with bigger volumes and change of plane in this bilateral pre-pectoral reconstruction with good result at the beginning and then bad result. Sometimes it's possible to change the plane on the contrary, passing from the retromuscular space to the retroglandular space, like in this case, to create a new envelope and a new pocket for the implant to have a round situation. Even in reconstructed surgery, it's possible to use different kind of implants round in the contralateral breast and anatomical on the reconstructed breast with fat and capsulotomies. And again, changing the type of implant, gaining volume, or changing broken implants and gaining nice shape, or changing volume and position of the implants for the patient wanted bigger volume. What about periareolar? Periareolar not means just move the areola up, but means to change the rapport with the areola to the breast, and can be perioral toward the up, but even slowly shortening the inferior pole, or moving together the upper pole and the inferior pole. Sometimes we need, as I told you before, we use normally to cut all the dermis, but in time, the situation when you keep some dermis on the vertical pole, you can move up the gland and fix the gland in different way. So you can slow down all the implants and moving up the implants and fix the areola up, changing the orientation of the breast. Again, in this stenotic breast, corrected, moving up the breast. And again, same situation, capsulotomies, changing the implants, slow down the sulcus, moving up the areola, cutting all the dermis around the areola. Fat. What about fat? Is the last maneuver. With fat, we can gain volume, but you can release a scar situation and make it round what was not round at all. But I think telling about fat, I use every time fat with needle, with long needle, angiography needle, to move up and down and to correct the scar situation, making it round again together with capsulotomies and changing the implants. Again, even in reconstructive situation, fat, capsulotomies and capsulorrhaphy permits to have a round result. And again, the use of fat, you can gain volume and change implant situation of scarring. Important situation. This is an aesthetical case, and you see how you can round with fat and needles, how you can round the gland in the flat situation, even in movement. Then the last very particular case, we have to take off the implants in this patient, but the expansion produced by the implants permits to use fat, and you have a similar result just with fat filling up the gland and the muscle after the expansion of the implants. As in this situation was a mammoplasty, was a very bad mammoplasty. She lost the implant. We had to work with an expansion, with an expander, with fat, and then substitute the expander with fat in the second time to take off all the sign of scar, of all scar. And this is another particular situation. She was a breast reconstruction, failed. She didn't want any kind of major surgery, so she didn't want any kind of muscle, and she wanted just an expander. The terrible expansion was the picture you see on the right. But at the moment of the substitution of the expander with the implant, working with fat and needles permits to round what in the past was possible just with helping with the Latissimus dorsi or some new tissues. And you see, moving up the arm, how can come back to be round with needle and fat this breast. So I think that it was studied and mixed these 6 techniques using together. That means not just one techniques, but 1 technique, 3 techniques, 4 or 5 techniques of these allows the solution and improvement of 100% of our cases. I think that the response of mammoplasty, secondary mammoplasty, in my hands, is becoming at a demand, in the sense that it depends which is the problem, where I have to cut off, when I need capsulotomies, when I need capsulorrhaphy, and when I need at the end to use my needle and my fat to make it round. Thank you very much.
Do we have any questions from the audience? You know, Dr. McCulley was advising us against using the peri-areolar mastopexy, but I noticed you used it in a lot of your cases. Any tricks for trying to keep the nipple diameter relatively small? Like, what do you use around for your stitches?
Yes, the tricks are, first of all, to cut off all the dermis and to go deep and to make 2 rounds. 1 round with not absorbable stitches. The first round is to project the areola and not to make a flat areola. And the second one is to close and to tie the circle. And I think that we are improving with the periareal scars, but it's difficult for Zubi breast, for tuberous breast, because it seems that the areola is so large that can be again just a little large. But all my patient knows that if we need, we are going to pass again to have a new periareal scar, but nice, and just this. But I think that without the periareal scar, it's impossible to put the areola in the real top of the breast where I want to look.
Okay. Okay. There is another question? No. Okay.
Okay. So, Mark.
I was just going to say that's going to close out day number 1. I just want to thank all of the speakers and particularly the moderators keeping us on time. We're only about 1 minute over, which is unbelievable. So hopefully we'll replicate that tomorrow. Tomorrow morning is going to start at 8:30 a.m. The title is going to be Without Consensus. We're actually going to be tackling the biggest controversies right now in breast plastic surgery. Then at 10:45, we'll transition into the ALCL consensus conference. Fabio, can you tell us about tonight?
Yes. So thank you very much. Remember that there will be the transfer for the networking dinner where I will be waiting for you if there is not a traffic jam. Otherwise, you will be first. At 10 to 8, there is the shuttle departing from the hotel. So you can catch it, come to the dinner. We will enjoy, relax, casual rock, the outfit, and then you will have a transfer back to the hotel. So thank you very much today.